differentiation, effacement of the cortical sulci, and the insular river sign. So these signs, they require a woken up physician at night, sometimes a radiologist, and sometimes you get the images on your WhatsApp. Somebody is shooting those images from the console and sending it to you on WhatsApp, and then the clarity is not there. So just imagine that as such these signs are seen in 30% of patients with LVOs, right? And imagine that what will happen if those images are transferred via WhatsApp, where it loses the resolution, the clarity, you can't scroll, all those things. And then these small abnormalities on the plain CT scan, which are the Hepatitis artery sign and the dot sign and all those things, I think it is just probably sometimes luck that you will miss them. And then you need to do these things that we talk about, that scoring the aspects and the more difficult PC aspects in posterior circulation score. So I'm just laying a ground for why have AI, why use AI, right? And then you have the CT angio, which gives us information where the blockage is, what is the pattern of collaterals, whether it is good collaterals, whether this patient is rapidly progressing or this patient is a slow progressor. All those things, this data is very important in an individual patient to individualize the decision. So all these complexities, then something is added when you have a patient out of the window more than 4.5 hours, then you want to take a decision regarding whether to do any procedure for this patient. You need data on CT perfusion, right? And then there are all these parameters that you can't keep on calculating, right? You have a cerebral blood flow, you have cerebral blood volume, you have mean transit time to peak and all those things. And then you need to have these images. So just imagine how much time your radiology department is going to take to give you all those images. At least minimum 15 to 30 minutes it will take to process all the images and send it to you. By the time you already driven down and you're sitting by the side of the patient and still waiting for the information. So we'll go back one slide, and just for the sake of clarity, how do you define an infarct and how do you define a penumbra? So infarct is basically the volume of the brain which is lost before you are reperfusing the patient, and the penumbra is what you are going to salvage. So how do we calculate it, and how does imaging modality calculate it? So you have something called as a cerebral blood flow. So imagine that this area of the brain has a blocked artery, it's not getting blood flow. So when you have a reduction of this side blood flow as compared to the other side, keep the other side as normal. If this blood flow is less than 30% of the other side, that is called RCBV, RCBF less than 30%, right? And cerebral blood volume which is less than 40% from the other side, with the increased mean transit time, means this blood flow is blocked. This blood is taking more time to reach that and then wash out from that area. So it is slow, very, very slow, and it is less also. This blood flow is less also. This is an infarct. Because a damaged brain doesn't need the blood flow and doesn't keep the blood flow. Whereas in the penumbra, what happens? There is a slowness of the blood flow, but there may be an increased blood volume. This blood volume, whatever is reached over there, is not being thrown out into the veins, right? So this difference gives us this difference between penumbra, which is a larger area, which is not yet dead, versus a smaller area, which is an infarct, which is dead. You are trying to salvage the penumbra, and we need to understand that in rapid progressors who have a poor collateral flow, this area will shrink very rapidly. This penumbra we will be losing very rapidly, and that is why we need to act in time, we need to act fast. Now, we also have this information based on MRI, and we need not do that. So, why do we need the AI? Because the stroke burden in India is huge, and we have a very heterogeneous population in terms of socioeconomic strata, the reach to the hospitals, and the pockets, right? And in terms of infrastructure also. So what happens is that many patients are in far-off area where technology and the infrastructure and the personal manpower is different, bridge this gap. What it can do is it can support the triage of patients, it can increase the levels of diagnosis, reduce the misdiagnosis, it can improve the workflow efficiency. So the entire team, there has to be a team, there has to be an ER physician, there has to be a radiologist, there has to be a neurologist, there has to be interventional neuroradiologist, and many other people, including the ones which give clearances. Sir, rehab comes later, sir. We are talking of the golden hour. So we will come to rehab. Yes. And all these people need to be on par. And in our hospital, even the people from the finance, they are on that, and everyone is live. So this kind of thing, rapid AI and other systems can do. So we will take a representative case. This case is a 55-year-old female who has a left hemiplegia of 2 hours duration and landed 2.5 hours duration and landed in the ER and is an acute ischemic stroke with occlusion of the right MCA M1. And this patient is being, so on the left what you see here is basically an image of the brain. We are trying to do the aspect score on rapid AI system, right? And it would be very difficult to understand what is the aspects here. It looks like a normal brain, and the rapid AI system gives us an aspects of 3. This aspects of 3 is actually very bad, right? So sometimes there can be a problems in the reading. You see, according to this system, you see that this M1 is actually blocked. Right M1 is blocked. But actually if you do a CT angio, then you see that the entire blood vessel from the neck is blocked. Right. So this can also lead to misdiagnosis as to the site of localization. So please don't rely only on AI. Right. This can also a lot of confusion, and this clot can be removed and this patient can be salvaged. So we need human intelligence also. Right. So what about should I give a minute about AI? Everyone knows what is AI. So AI is basically artificial intelligence. It is aiming to be what your intelligence is like. There are physicians, there are super physicians. So there is an artificial intelligence and there will be a super artificial intelligence. We have not reached that stage of super artificial intelligence till now, right? That is why these mistakes are there. So we have in the systems that the AI is there. We have an input and the computer has some algorithms and then there is an output. So there is a term which is called the machine learning. Now what is basically machine learning? This machine is not only giving outputs based on the rules. This machine, based on large data sets, can learn by itself. It's a machine learning. Machine learns and tackles on previously unforeseen data. So new data it can, on which this machine has not learned, not been exposed to this data. This machine can still give you outputs on that data. So this is learning, and this machine can evolve over time with new data, with new experience. It has memory, right? And then based on that, there is a system which is called the deep learning. So in the deep learning, what happens? The model which I told you, there is a superficial learning. There is a data which your machine has been fed, and it is learning over time, and it is giving a better outcome. Now, in deep learning, there will be many layers of these nodes. So the first layer of the node will deal with some data. It will process that better. The second layer will do different. So simple example is, let's say that you see an image. Your computer or your mobile phone, you just pick up your mobile phone and click using AI on some image. And this will tell you what image it is. Suppose it's a monument, it will tell you which monument, what is the history. So how? So first layer will go looking at the margins and the color of the image. Then the second layer will tell you the texture of the image, so granity of the image. Third will try to match it with some previous images. So there will be multiple layers. So this is called the deep learning. And then there is another concept which is called the convolutional network. Convolutional network is basically trying to mimic your brain structure. So how you have many layers of neurons in the brain. So similarly, these different layers of neurons do different function, and then they sort of match the output. So that is CNN. So what happens in AI basically is that you have an input, then this machine will learn from the patterns. You know, neurology is about learning patterns. So you see a patient, you know this pattern, I have seen this before, oh this is MS, right? Then you can make a prediction that this multiple sclerosis is basically an advanced MS and you know 2-3 years down the line this patient will be bedridden, right? So I need to do something to avoid this patient getting on wheelchair. So this prediction, this neural network CNN can make, right? So you don't need to only just see an image and say, oh this is Taj Mahal. No, you need to do some prediction that in 100 years down the line this Taj Mahal will look like green, right? You know, and it will tell you what to do. So these kind of things, when it comes in stroke imaging, imagine what is going to be the impact. So there are certain things that we need to understand regarding this AI, that using AI in stroke, and this is all being done just now. You know it, you do it, but you're not thinking this way. I need you to think like this, right? So you need to detect a stroke with the AI, and what you detect is basically you see aspects, you see the cohesion, infarct volume, what is the hemorrhage, all that. This is being done with AI, and then you can see basically you can time the stroke. So suppose you have a CT scan. If I give you a plain CT scan and say that how old is this infarct? Maybe you know if it is like looking very dark, then you can say maybe you know it is 8 hours, 4 hours, something like that. It's very faint, then you say maybe 2 hours. This AI system can almost accurately tell you how many hours old infarct is. So this is better than me. It's not even matching a good neurologist, good radiologist. It is getting better. So based on a plain CT scan, you can time this thing, and then you can predict with AI. So you can predict that how this infarct over time, what will be the final infarct volume, whether it will go into an hemorrhage, and you can also predict what will be the functional outcome of this patient at 1 week and 3 months down the line. So this is prediction which every doctor is supposed to do. We need to prognosticate our patients that this is an old lady, I will not normalize because she will not make it, right? This is a prediction we do, and based on that we can take a decision. So this AI will help us in predicting how the imaging will look and how the patient will look after some time. That is the importance of AI. So this is all that, you know, in a pictorial form, that you can do diagnosis, you can do treatment based on that diagnosis, you can do a prognosis, and you can do prediction. So based on your CT scan or your MRI, I can tell you, or the AI can tell you what is the risk of you getting a stroke after 5 years. That is prediction, and based on other data also, some other data whether you have a heart disease or not. So this is coming in a big way. So we all know rapid AI. I will not go into rapid AI to save time, but this is how it looks. So rapid AI first tells us that there is no hemorrhage. If there is a hemorrhage, it will tell us what is the size of the hemorrhage, what is the lesion location, what to do. Based on that, you can take a call. Then the second part will be there is no hemorrhage. Then it will tell you what is the ischemia. So you will look at the brain parenchyma. What is the time duration elapsed? It can tell you. It can tell you how severe, what is the aspect score, where is the blockage. It will tell you whether there is an LVO. So there will be an alert on the system that there is an LVO detected, and the entire community which is on this can collaborate. It can also give you rapid AI perfusion. So basically, after 4.5 hours of infarct, then you need the perfusion information to choose the patient for any further reperfusion. And then there is another thing which is called detecting an aneurysm, because you done a CT angio or an MR angio on this patient. So if there is a patient which needs any further treatment for an aneurysm, you can do that. There are a lot of these metrics that they have given. I don't want to go into all that detail. But there are many service providers. We should know some of the names because they are competitors and not collaborators. So, and many of them, they are doing well. If you want, you can take a picture. This is a new kid on the block, right? And this is getting slightly better than rapid AI. I am not using it till now, but I know one system where it is being used and they are also happy. So we should know basically. Now this is a very important slide, right? What this slide means that this is a 2024 publication. What it does is that rapid AI compared to human readers for acute stroke imaging for detection of intracranial LVO, right? So how does rapid AI pair with an expert reader? So let's say that Dr. Arvind Nanda is there. He's an expert reader, right? But we don't have him everywhere 24/7. So that is why we need the rapid AI. If you are there, we don't need AI to read the images, right? And this is what this article tells. Experienced readers of acute stroke imaging can identify the blue box down, can identify LVOs and LVOs with a higher accuracy than rapid AI software in a real world setting. The negative likelihood ratio of rapid AI software was not sufficient to rule out an LVO. So every time you have a rapid AI use, it may not rule out that there is no LVO, right? So you may miss an LVO also. So that is also very important. And there are some technical limitations with AI which we should know, all of us should know. First is that there can be motion artifacts which can, confound these interpretations. Then scanner and protocol, affects output variables. Then there are fixed perfusion thresholds may not apply universally. So some patients you take time to max as 6, but in some patients you may need to take time to max to 8. So that variation only an expert radiologist will do. Because once this information is there fed to you on your system, then everybody is already running. So somebody must have missed that information that this patient has stroke or not, and that is a bad way. I would say that it confounds everyone. It will tell that there is no LVO. Then the radiologist is sleeping, everyone is sleeping, and next morning people are, oh, sorry, we missed it. So there are a lot of these limitations. And some limitations are also related to ethical and legal issues. We should know that, and this is coming in a big way, right? So, this is probably one of the slides that I want. So, some of our friends are doing good work with AI. Now, this is something very important. The lower down the title, the deep learning based generation of cerebral blood flow CT perfusion images from non-contrast CT scan. So imagine that you have a non-contrast CT scan of a patient. Using an AI, you can generate a CT perfusion map of this patient. Non-contrast CT perfusion images, so you don't need to give contrast, right? This article is by Dr. Vivek Nambiar from Amrita Institute, and it's coming. So you don't need to give contrast. Just imagine what is the impact. So here, last line is very important. The model utilizes ResNet 50 architecture, effectively maps and delineates contrast enhanced CT images from non-CT scans, demonstrating a strong performance with a 26.4 decibels PC and PSLR and 89.49 SAR respectively. So it's very highly accurate, right? So probably time to come, this will be the way forward. And to conclude, I would say that prompt detection and treatment of acute cerebrovascular disease is critical to reduce morbidity and mortality. That we all agree, right? AI offers personal prognostic insight. So you will know based on what information we have from this AI images that aid in tailored treatment plans for stroke patients. This one is going to do well, this is not going to do well. You can decide that. And use of AI to support clinical decision making, reduce inter-rater variation, means that misdiagnosis, read it as misdiagnosis, and improve treatment selection by aiding and diagnosis, including detection, triage, and outcome prediction. So this is very important. I think this is a way forward. And there are some slides. I'll just skip that for the time being, just for the interested people. There's some data out there. Thank you so much.
We would like to invite our next speaker, Dr. Amit Aslam Khan. award first prize in clinical and radiological profiling fistular circulation. So welcome for you, sir.
Thank you. At the onset, I would like to thank the organizers, Dr. Dural and Dr. Nanda, and also the chairpersons for inviting me here to share my views on the stroke. Today's topic that I would be talking on would be vessel occlusions. They have been categorized in 2020 as medium distal vessel occlusions, also known as MeVO or DMVO. And the definition has been put forward as in terms of diameter of the vessels, which is ranging from 1 mm to 3 mm, and sometimes they calibrate it to only vessels which are from 1 mm to 2 mm. I'm sorry, we checked it in the morning, it was working. And can you put it there? Take it. Like I said, they represent 25 to 40% of the strokes that we encounter, and more than 50% don't recanalize. So that's a huge point of contention. And like I said, in 2020 there was a statement where they thought that it was best to define what are MeVOs, and they took anatomy as well as functional disability as the criteria. And according to anatomy, they put down the limitation as 0.75 to 2 mm in diameter, the vessel size. They can be also primary, that means affecting directly into the segments of the arteries, or secondary, that means it was an LVO to begin with, and then transformed into a medium vessel occlusion. So functional, they put down as more than 5 as the NIH score cutoff for these, or anything below 5 with a disabling deficit. As madams described to us in the morning, it is very much individualistic as to what is disabling for a person. And anatomically, the MCA is defined as M2M3s. The ACA segments are A to A3s. However, they are excluded dominant segments. So, superior division or an inferior division which is dominantly supplying the whole hemisphere, and it is the same caliber of a M1. They said that don't treat it like a MeVO. Use your devices to recanalize those arteries as you would do for a LVO. So the strategy should remain the same. That's the importance of these statements. So what factors are driving Neuro? I mean, they are affecting the population who are younger, and they present with no greater severity of a functional deficit because they are supplying most of the electrical cortex. Suppose the central artery is involved. So obviously it would be a very devastating effect, or a language area is being supplied, or a occipital visual cortex is being applied. So they generally have a smaller core, but the functional disability that could lead eventually to it would be very huge. So they mostly is being driven by high volume centers also. And the recanalization rates without and with alteplase are, and there's a huge role for TPA in MeVOs. So 30% do tend to recanalize with IV TPA. So a MeVO patient should be given IV TPA because I will show you a few cases. And so outcomes, they have been defined as early neurological improvements, and they put it as a reduction in the NIH baseline of more than 8, or the 24-hour NIH of 0 to 1. So they are very strong predictors of very good favorable outcomes. And these are the rate of ANIs. With IVTPA it's 28 to 33%, with IA it's 35, with mechanical thrombectomy within 6 hours is 43, for Blister it's 30%, because we all know the perforators do their damage, whatever we do in the basilar arteries or the M1s, and with MeVOs it's 39%. So the Hermes meta-analysis came up with that mechanical thrombectomy in these subgroup of occlusions improve functional outcomes, and they should be done in all these medium vessel occlusions. However, the superior division, you can see the superior division was off. It was better seen in an oblique view. In this case, we went transdistal radial from the right upper limb. We got access into the right ICA, and our protocol is always to achieve as distally as possible. So most of our long sheets are in the cavernous sinuses, which are mostly the C3 segments. That's what we ideally aim for. And then we use an intermediate catheter, which we use for pinching. And you can see our microcatheter in the occluded segment, the stentriver deployed. And then we push the distal intermediate catheter so as to pinch that small stentriver.
and retrieve the clot. And this was reperfusion achieved. So this is another case which was a 66-year-old who had history of CVA in 2014, and she had again a ictus which was very early onset. The aspects was 4 because of the scattered origin of scattered emboli. So you can see the thrombus is very well seen on the M1. The M1 occlusion is there. There's disease on the right IC also. And there was a mismatch on perfusion imaging, and ADC, we generally use this for our patient. It helps us. So here you can see the M1 occlusion. We go in, we recanalize. There's a TK3 recanalization. As our teachers have always taught us that patience is always a virtue. You need to sit and wait and see what the effects of your interventions are. We waited for 10 minutes. And we saw that there was again an avascular area coming through, and we knew that there was a reocclusion of the superior division. So we again went in, taking our devices into the superior division, along with the stentriver and the intermediate catheter, and we recanalized. However, we saw some platelet aggregation at the origin of the superior division after a second pass. First was LVO, then the second was the first MeVO pass, and then we decided, as the MR did not show much of an infarct core, we decided to give intra-arterial tenecteplase of 2 milligrams in these branches to, so this was a mechanical thrombectomy along with the intra-arterial, and we waited for 45 minutes. There was no change in the perfusion and the TK3 recanalization. So this was a primary MeVO. This was a 68-year-old lady. She was a CKD patient. So these are the patients who you need to be careful of, because CKD patients have gritty, unresistant arteries. I mean, they don't give way. So the moment you go in and you push a little, you might land up in hemorrhage. So this was again an acute onset, but this was a posterior circulation. And here you can see a diffusion and flare mismatch. And the whole of the left PCA territory was involved. And you can see the PCA cutoff. So we went in with our, there was quite a tortuous turn along the P1, P2 segments. We did our first attempt on the recanalization. We achieved only suboptimal TK2 recanalization, because you can see a cutoff after the P2A segment. So this was our second attempt. We again went distally, and we pushed our intermediate catheters even more distally. And then you can see that there is spasm just after where it was occluded, and there's very good recanalization in the P2B, P3, P4 segments. So it was a large territory that it was being supplying, and the PCOM is also very prominently evident now, even better. This was another 80-year-old who was a hypertensive on irregular medication. Again, there was a lot of mismatch between the diffusion and the perfusion. You can see the small core. They generally present with these, and the perfusion deficits are larger. And this was the MR. You can see there was paucity of vessels on the left MCA compared to the right. And when we do a angiogram, it's difficult to predict, but you can see a avascular area there in the along the superior division. It is better seen, the occluded stump is better seen on the lateral angiogram, and that's what we went in and targeted. And like I said, this was the clot retrieved. generally, this is just one post. We have a tendency to send all our clots for histopathology, and this was a TK3 recanalization. So basically, MeVOs are important because, like I said, they supply a very important territory. However, literature is saying that it is compared to best medical management, there's no difference. But the reasons are valid because we have longer working times to take these patients for treatment. So we need to define what segments we need to work on. We need to increase the NIH scores to more than 9. I think more than 5 is again a lower threshold. So earlier the better. Individualistic approach, we need to look at the anatomy, we need to see what is feasible. If you have very thin arteries, do not attempt these procedures because there are subgroup of patients who would come like that, and first pass effect is definitely important. Thank you.
Now the house is open for questions.
Hello. So I was going to ask about the role of thrombolysis for as a anterior circulation stroke. If ICA is involved and the patient is out of the window period, then because there are studies which I read about tenecti place in more than 4.5 hours, up to 24 hours, where patients are in a setting where either cath lab is not there, or maybe the patient is financially constrained and cannot undergo mechanical thrombectomy. Then in an IC occlusion, not basilar artery, what do you want to say, ma'am, about thrombolysis?
Yeah. So when you're looking at a science and a trial, it's a controlled environment. So in a controlled environment, the inclusion is whether there's a large vessel occlusion. Because when in an LVO, you already have a guideline that you have up till this duration you can go. So you already have 6 to 8.5 hours. And with the vessel imaging and the demonstration of a viable tissue, you're going up. But when you are, do you have a trial in a practice where you do not have advanced imaging and it is suspected to be a large vessel? So the suspected large vessel without, and even if you demonstrate a large vessel by a CT angio and you have no wherewithals to say that it is a surviving penumbra, the guideline do not say yes to an IV. But you're talking about a situation at district hospital, you demonstrate an LVO and you do not have a wherewithal of saying that there is an ischemic penumbra which is demonstrable by an imaging. Do I give IV thrombolysis? That's what you're saying, isn't it? Because
the patient is in a tertiary care, ma'am, let's say, and we have done advanced imaging where we know it is an IC occlusion.
no, IC
And,
occlusion is not advanced imaging
no.
data. That's just vessel image.
Vessel imaging. But we have done that. Now the patient is, there is flare DWI mismatch, and but the patient is at 5 hours now.
What you're saying is you don't have a neurointerventionalist.
Or maybe we have, but the patient is unwilling to undergo
Right, so
mechanical
that's what, you
thrombectomy.
can't do mechanical.
Mechanical.
But the patient has an ischemic penumbra.
Penumbra.
Can I give IV thrombolysis? That's the question.
Yes, ma'am.
So they have done that along with tenectic place. In fact, up till 24 hours, that result was actually negative. But then again, I'm saying it's a controlled environment. So if I have a clinical practice setting and there is a mismatch, then I think I'll take a consent and I'll give IV thrombolysis. But when you do IVT, then you also have to look at, in your advanced imaging, all other parameters. I have a lot of microbleeds sitting there, Fascica's grade 3 leukoariosis, I'm not getting into it. Because even if they give you a consent, the guys are going to turn back and say your injection has caused trouble. And then you're out of the guidelines. So you should also be aware that you're in a practice. Be aware that you're also having to face a music when things don't turn out well. And there's no way, there is no AI, which is a godfather sitting there and say, okay, this guy will definitely benefit. So beyond guidelines, be careful when you're in a practice. Right?
Thank you.
Everybody agrees? No. Wake up stroke is up till, the 9 hours from the mid-sleep interval. But that's what I'm saying. So as far as your inner guideline, okay. What he says is that I have a clear-cut M1 occlusion. I have this occlusion sitting there and there is no interventionalist, or the guy say I can't afford mechanical thrombectomy, what can I? That's definitely a practical question. I think there you need to, make your good sense prevail and do that.
Ma'am, this is the same question, and this every time comes to our minds. So we wrote a paper in I think Journal of Stroke Medicine, Indian Stroke Association, that is published in 2020, where we use the diffusion flare mismatch as a surrogate to surviving brain tissue, right? And we published a series of 10 cases where we had caught patients at 5.5 hours up till 12 hours. Some of them, half of them having a large vessel occlusion, not willing for mechanical, not affording, whatever you have that scenario. So this is the same scenario that you discussed. And we showed that the MRS 0 or 1 was achieved in 9 out of 10 patients. And the last patient, the MRS was I think 2 because of some premorbid things. So what we showed is in a carefully chosen patient, carefully chosen and properly consented patients, it is possible that the diffusion flare mismatch tells that there is a surviving penumbra at 6 hours, 10 hours, and this has also been quoted and published I think in some Chinese study. I'm not remembering just now, but there is a Chinese study which talks about MRI diffusion flare mismatch as a surrogate to identifying penumbra and to choose patients for IV thrombolysis in case you can't go ahead. But this is not generally the rule. We have not done a randomized control trial, and as madam said that things can go off very rapidly badly. So we decided after 10 patients on publication of our patient not to pursue this, because I don't want to land on the other side of the bars. So that's it. I would I would tell everyone, please don't try your luck too hard. Sometimes it can be bad.
Again saying that, when a family has these issues that, I can't afford it, okay, this person is not there, you already discussed the possibility that you may need MT. And then you're giving IVT. The patient improves, the patient may not improve. Improves, you're the god. Patient doesn't improve, then they say, ki, you didn't do the best. And then, you have given an injection which has created trouble. So just when we are on the other side, and then I think it's better to stick to a guideline and have a dialogue and take a absolutely, complete, the informed consent should have everything written in it. And on not a programmed consent where you just take a line, I think, yeah.
Dr. Tufel, you want to add? No, thank you. That was quite nice. I wanted to make a comment because you in your talk, I just came at that time and you said in UK, I work in UK, we are very much clear about the guidelines and we work within the guidelines, and that is exactly the reason why, because if you get into trouble, we may not get the patient family, but we will get the lawyers after us. Okay, so we are very careful about going, and I think the trials are made so that we have certain criteria to treat it. Now, if you look at MeVO now, the whole Europe, and I've just come back from Calgary for talking about MeVO, and we had a closed group discussion about it, that it has changed the practice now because there is no evidence. We know the faults in MeVO because we were a part of MeVO too. We had lot of difficulty randomizing patients to MeVO because there was no equipoise, so there was a problem. So, and we have a negative trial now. So that doesn't mean that you don't treat some of them, you use your own clinical experience to treat it, but we are struggling now to treat MeVO. And one other comment I wanted to make to my colleague who is that Oja who made presentation on the AI. Okay, so I would be very cautious about using AI as a routine practice. We've been using AI and rapid AI, Brainomics, Nicolab for a long time. And I've done a lot of comparison. There is a problem with AI software too. It doesn't pick up MeVOs very easily. It's not a problem anymore. It doesn't pick up aspects very well. It overestimates aspects. So you can't rely on the aspects also. And I think it's very useful though, because if you have especially in India, I think it can work really well. Because if patients are outside, you don't want a radiologist because they'll take time, then it makes a huge difference. So I have Rapid and Brainomics on my mobile. I know every stroke that is coming in the region. Before the stroke consultant knows, I know the stroke. And I have to, and I heard you said that radiologists don't know how to do NIHS.
No, I didn't say that.
Something like that. No, but we are trained. We are trained now to do stroke. Our training involves, if the radiologists are involved now in going and spending time with neurosurgery, radiologists have to do every clinical side of it also, and it the same way works for neurologists now. So we are training both ways. So I might have misinterpreted that.
No, I didn't even talk about radiology. But the thing is that, in fact, I come from an institute where the base of the vertical in our stroke management is neuroradiology. So we, in fact, do not have neurology neurosurgeons as interventionalists. In AIMS, it's all neuroradiology. But then when I went into the national boards and then we created, Dr. Karapurkar is here, in our original thing, we had to get into our NEAT program, get the critical corpus of interventionalists. There we brought in neurology, neurosurgery, and also the radiology was part of the team. But till at such time, it was neuroradiology, which was a huge vertical. And now we do have the corpus expanding, so we need this interventional team to grow in because of our LVOs, and we have a greater ambit of all those who are coming into the interventional program. So I never mentioned radiology, so because that has always been my, in my kitty, I always took them along. Yeah.
Thank you.
If we have any more questions? So if there are no more questions, I would like to thank all the speakers, and we had a very interesting discussion.
Now, so after the excellent first session, we come to the second session, and I take this opportunity and privilege to invite Professor M.M. Mendiratha sir to be as a moderator for this session. Sir is working now as a Director of Neurology in BLK Max, New Delhi. Sir retired from GB Pant as a Director and Professor. Written around 60, has participated in writing 60 neurology concepts in books as well as 250 publications. And I request sir, after the session, to moderate a question answer into this session. Now, coming to the chairpersons, I request Dr. Tarun Ralot Professor Neurology at R&T Medical College. Sir, please. Dr. Pankaj Gandhi, Professor Neurology at Ananta Medical College. And Dr. Tarun Mathur, neurologist and a neurointerventionist at Paras Hospital, Udaipur.
Thank you so much for the kind introduction. And also I'd like to express my gratitude to Dr. Atula Pathre and Dr. Arvind Nanda for inviting me and to moderate this session. I'm aware of that we are running quite late. I'm a very time-sensitive person. We'll try to compensate if possible. So, we call upon the first speaker, what is mentioned as latest in stroke management, or I can say recent advances in the management of stroke. Dr. Patankar, please. Dr. Patankar, I think you will agree with me that we have to be time conscious and we are running behind schedule. Thank you so much.
I can make it as short as you want. I'm also hungry, so I don't mind. That's my picture there. I don't look like that. That's an AI-generated picture. So I'm going to start. Do you want to connect that? That's my daughter. She's 4-year-old. Okay. So I'm going to start with an old case of mine. This is a chap who was a bus driver and he had a stroke, as you can see. He's got a basilar stroke here. If I can get the pointer. Okay, the pointer is not going. So anyway, you can see that there is a basilar stroke and he's obviously got really bad circulation. He's got a PCOM here and I think that's what is keeping his top of the basilar open. But you can see the right vertebral artery is ending in pica. The left vertebral artery is clearly occluded. So, and you can see it's occluded right from the bottom. And what would you do? The only way, you got to get in there somehow. So what I did was I found my way into this vertebral artery. Initially it was occluded. I railroad myself and I actually stented him right from here. He was occluded and I stented him here and I carried on putting coronary stents all the way till I reached up, and then I did a thrombectomy. As you can see, there's a basilar stroke here, and then I did a thrombectomy, aspiration, and then the basilar was open. Okay, so literally, and this is a very historical case. This is before even the trials. Technology was there. We were using coronary stents, and we could get there. If you want to get somewhere, you will always get there. And this guy did very well. He was back to driving his bus. I'm not going to talk about trials because everybody has said, but it's amazing. Look at the amount of trials we have now. All of them are positive. All of them have shown positive, good outcome. Mechanical thrombectomy works. And if you remember the time before when the negative trials were there, can I get some water, please? The negative trials, we are talking about significant improvement. And this is a great time for us as stroke consultants, as interventionists. This is a golden era. Positive trials, and Padma has already spoke very well about all that, so I'm going to just skip through. We have diffuse, we have dawn, and all of them have shown that thrombectomy works. And we know we have extended from 4.5, 6, and now we have gone to 24 hours. But we also have discussed that when you go beyond time, after 6, you got to talk, what we say, you got to think clinically, you got to use perfusion. You guys use MR. I don't use MR. I use CT perfusion, CT angiogram. We don't use MR. MR is usually in a different part of a hospital. It's not possible to get it quickly. CT is the most easiest thing. But we also know the number to treat is look at the difference. If you look at the trials, it goes from what, 2.5 to 7.4. So you can compare to look at what cardiology has achieved, and their number is so high to actually number to treat, to see the benefit. So all these trials clearly show that thrombectomy is here to stay and is a treatment of choice in large vessel occlusion, and it makes a huge difference. There are answers, and my colleague earlier discussed about low aspect scores and the MeVO. Now low aspects, did somebody talk about it? Is somebody talking about it? But again, if you look at low aspects, and I'm not 100% convinced whether we should be really going in that direction so much, but the trials are clear. But there is a problem, and in our practice, we do take low aspects because of the trial. As Padma said, we are very guided by the trials. So trials are positive, so we do that. Now, quite often, the intensive care don't like it, but the stroke consultants who see these patients through 90 days, they know that these patients do make a difference. So I think it's very important to realize that we don't always, as interventionists, see these patients at 90 days, but the trial clearly is positive. And all the trials have shown favorable towards the thrombectomy. Again, this has been discussed. Large core, again, the trials are clearly showing that endovascular treatment is the treatment of choice. There are still some caveats here we need to understand, like we are taking a lot of these bad patients. Lot of these bad patients are occupying our intensive care, and we do have complications. So we are still questioning whether we should be looking at a subgroup within this, whether we can make a difference. But overall, the trials show it works. Sorry, I'm jet lagged. And again, there's a tension trial, there's a LAS trial, there are patient studies after studies which have shown low aspects, mechanical thrombectomy works. And again, people have gone up to 0, but I think I would be very cautious going that low. 3 to 5 is my margin, and that's what I stick to. But consistent benefit of endovascular treatment in large core patients, and that's the message that we need to be very clear, and it works. There is a risk, there are risks of bleed, but this works. Let's look at one of my cases, 76-year-old patient, NIHS is 24, and you see a thrombus, you see a CTA that clearly shows, and the CT there is a large core, aspects is 4, you see a perfusion, and this is brainomics, and you can see a perfusion mismatch. You have an ICA clot, you can see the ICA is kind of tapered here. You can go up, there is a stent here, you have used red. I always use balloon guides. That's what my practice is. I use balloon guide as a first line. I'm a stent person, so I use stents. And then you can see the recanalization, and there was actually no carotid stenosis. This was a pseudo-occlusion. And you can see these patients do well. Medium vessel I'm going to skip because you already had a lot of chat about it. But again, there are limitations of this study. I was a part of the medium vessel trial, and I struggled with getting this patient across because there was difficult for some people to actually randomize. A lot of these MeVO patients did not get randomized because some of my colleagues were hesitant to randomize these patients. So though we randomized some, we were not able to randomize because everybody had a different opinion. So remember, there was a problem in terms of selecting the patients. There was a lot of bias. There's a lot of heterogeneity. And how do you define what is large M2? And that itself was a problem. So we had a lot of difficulty in trying to figure out which patient to choose. Last week I was in Calgary with Mayank discussing about what we do now with MeVO and what's the next step, because obviously the negative trials have impacted our practice now. Here is a young patient, 70-year-old. 70 is young for us, okay? NIHS is high and contraindicated. Sorry, let's go to the next. You have already spoken about MeVO, but you can see NIHS is 13, local anesthetic, and you can see that he's got a M2. We've gone with Sophia, we used a solitaire, and we had a TK3, and it did work. So now the question is, nowadays I still do MeVOs in my practice, but I'm very selective because if you mess up and because the trials are negative, we could get into trouble, so we are very careful. But it all depends on whether you talk to your stroke neurologist, and if you both agree, then we go ahead. Low NIHS is a big problem. We've still not done very well about it. I think there are trials which are coming in, and as you can see, I'm going to show you some cases. It's also because there is some role of collateral circulation that some of these patients have got low NIHS because they either have pre-existing disease or they have very good collateral circulation. So we are still in that limbo, whether to do MeVO, whether we do low NIHS. I'll show you a case. This is a very recent case. This was a 27-year-old lady, just recently came with 7 weeks pregnancy and an NIHS of 4. She obviously has ischemia, and she has a left M1 occlusion. How many of you will treat this? Agree. Anybody else would want to treat? NIHS is 4, young woman, 7 weeks pregnant. So many of us would treat it, but it's a difficult decision. She's 4 in a trial, can be tricky. I actually had a chat with my uncle also, and he said, I don't know, I don't have an answer. We went ahead, did a balloon, and then we aspirated, and we got a TK3, and she was an NIHS 1 within 24 hours. Okay, and you made a very good point about it. It's when you look at NIHS, you have to look at why the point has dropped. If you got speech or you got very important functions, brain is brain now. It's not just time is brain, brain is brain. So I think that concept has to be different, and we need to look at why people have low NIHS. This is it. I'm going to move from this because I want to show you some technical side of it. Already you have discussed MeVO. One of the important things we need to look at is tandem occlusion. Okay, a lot of patients have carotid stenosis, and again, we know that we have to, a lot of them, IV thrombolysis may not work, and we may need to treat them with a stent or angioplasty. Now, there is a lot of discussion, which one is first, antegrade or retrograde. I go antegrade, okay? I like to stent or angioplasty, and then I go, but there are pros and cons of either way, and you might have your own preference. What works for you is good, okay? There is no clear evidence one is better than other. There are a lot of papers on that, and there is no clear evidence whether you go antegrade or you go retrograde. And I think it's your personal choice. But again, question comes is, do you stent or not? Now, I'm slowly moving away from stent. If I can angioplasty, I angioplasty. I had a few bleeds in my practice, so I'm very careful. So, again, I'm not going to talk about the data. I want to show you some cases, okay? So look at this 77-year-old. MRS is 1, and you can see there is a left IC occlusion here. We've taken the walrus balloon across, and then we have done a thrombectomy, and on the way back in here, we have put a stent in, and you can see that. And obviously, we give integral in. We do a CT before we give integral in. We do a CT before you put a stent. It's very important. Before you put a stent, do a CT on table. Make sure there's no problem before you do that. Posterior circulation, stroke is very important, and some of you will, I think the previous speaker talked about a bit. It's difficult, okay? It's a difficult thing. Again, I don't do MR in posterior circulation strokes. My practice is if you have a CT, it's a clinical diagnosis, you decide clinically and make a decision about treatment. You can do aspects, you can do MR, but you got a bit of a longer period in posterior circulation. And you can do longer. For children, I've gone up to 48 hours. So I've done thrombectomy in quite a few children, and I've gone up to 24 hours, I've gone up to 48 hours. I think children do very well. So I think you should be careful refusing children for thrombectomies, particularly in posterior circulation. And now, we are very good now because we have these 2 positive trials. We in UK, like you were saying, we had a big problem because of the negative trials. Because of the basics and best, we had a problem medico-legally. trying to justify. You get into complication, lawyers were after you. But now we have 2 positive trials, and they show the same thing. And again, is anybody talking about posterior circulation trials? If you haven't seen this, but this is, if you do ChatGPT, this is from ChatGPT, okay? It gives you clearly that all the 4 trials, puts them in the thing, and you can see there is a clear benefit in attention and Bausch trials, which show that there is a positive trend towards thrombectomy. So again, based on that guidelines, we have NIHs greater than 10, not NIHs less than 10. So NIHs greater than 10, thrombectomy is indicated. Now, I have gone below 10 too, like, you know, if patient is symptomatic, it's hard to say no, but there is the guideline suggests that NIHs less than 10, you probably may not need thrombectomy. So this is a basilar stroke, as you can see. And how much time I've got? Is there a timer? Okay, sorry? Okay, so I can, yeah, I am going faster. So as you can see, there is a basilar clot here, and we done a thrombectomy, and it's very standard. And then you can see the CT and MR follow-up, patient does very well, but then it changes when you start having problems. This is NIHs 7, and here you can see this patient has got a occlusion. Is this a dissection? And again, you can see that you come up, and you can identify that, and you can get a solitaire and aspiration, and there wasn't anything. Now, when there is a stent, when there is a stenosis, then it becomes a problem. And you have the same issue whether you stent or you don't stent. Generally, I tend to, if it's a vertebral dissection, like here you can see this vertebral artery is dissected here. I don't like leaving them because I know they reocclude, okay? So if I have a vertebral artery stenosis or a dissection like that, I tend to just put a stent in. Now we have Credo. I don't know whether you got Credos, so because it's a good stent and it often works very well, but you can use a coronary stent too, and it did quite okay. There are a lot of trials talking about direct to MT. Again, there is no evidence. We are working on this, but there is no clear, all the trials have shown non-inferiority to direct mechanical thrombectomy. So I think in UK, we still believe IV thrombolysis is still a treatment of choice. We would give IV if the patient deserves an IV. The question comes about GA and conscious sedation. Somebody talked about it. I think it's again individual preference, but I do a lot on the GA because one, I don't want to talk to anybody, you know, but so it's easy, but secondly, it's safer. The GA is so quick, okay? And your anesthetists are so quick that and if you have a complicated problem, it becomes easier to do. So but there are certain benefits of GA, of local. So if you can see this, there's an M1 occlusion. You do a thrombectomy, and looks okay. But you can see I still got an anterior temporal branch missing. Do I need to go back on it? But if you look at the patient was already talking, and she was moving everything. So there is a distinct advantage if you do local, and if your patient is already improving on the table, you can make a decision and you can stop. So I don't know whether you guys do it in your practice, but do most of the people here do local or GA? It's GA, yeah. And the patient did very well. Just a bit on technical side. You have already spoken about rapid. Brainomics, we use a brainomics, depends on which part of the country you are. In London, brainomics is very common. I don't think it's as good as rapid. You have rapid, I have brainomics, I have NICO, okay? So I know I have direct comparison experience on all three. I'm not a big fan of brainomics, but it does help. It helps the workflow. Your patient can't come directly. You take out all the middle people in between. So sorry to say, but the radiologists are hard to get in the middle of the night to make a diagnosis. So it's easier that the technician does the scan and it comes straight to the stroke consultant or the interventionist and the diagnosis is made and you save a pretty lot of time. There are problems there in AI, but if you know them, you can handle them. Here is a case, and you have seen this. So again, you can see, remember aspects, don't trust aspects on AI. Okay, it's not good. None of them are good. Okay, all three of them overestimate. So Rapid is good for MeVOs, Brainomics is not good for MeVOs. Nicolab is good for MeVOs. So again, you can have a good comparison. But here you can see, this is a good case. This was quite recent. This patient was a 69-year-old, wake-up stroke, and IHS of 22, so no thrombolysis. You can see aspects look okay. CTA was normal, but there was an occlusion. So Brainomics is quite good, and perfusion sometimes it tells you that there is a problem, you can go ahead. And here you can see there was no intracranial occlusion, but a CT perfusion shows a big penumbra. And then you can see there was the CTA was, as you can see, there was a good flow intracranially, but there was an occlusion of the ICA, and we stented that, and we angioplasted it, as you can see here, and then we put an exact stent here. So, and the patient did very well. Last thing, there are a lot of technical side we can do. We have improved. We have got better and better. So, first pass balloon guides. We know new catheters are coming in, large bore, super bore catheters are coming in, and there is a lot of these stuff. But one of the techniques which again, people are going transradial. I don't know. I'm not a big transradial person. I only do transradial when I have a problem like this. Here is a patient with a graft. As you can see, it wasn't easy. So I went transradial, and then I did a occlusion, and I did a thrombectomy. And you can see I got a TK3. I find it hard for stroke. Catheters are bigger, and you can't get bigger catheters through the radial. And I usually get through the groin, or I'll do a direct puncture. So I do direct punctures to carotid. If I'm struggling, I just go direct. Okay. The last thing I'm going to talk about is double stent retrievers. This I think it's one of my primary treatment choice. If I have a clot, I usually prefer to use a double stentectomy. I put 2 stents in, 2 catheters into the 2 M2s, as you can see here. And I'm going to show you a case. This is a 59-year-old. NIHS is 17, and you can see the aspects is good. There's an M1 occlusion, and as you can see, aspect thrombolysis was given. You can see the catheter. And you can see I've got 1 stent, 2 stents. And you can see the 2 stents here. And basically I got 2 stents in 2 M2s and single pass, and you get into, and I do it quite routinely. If you do it on a regular basis, my first pass success rate is around 80% to 85%. So it's certainly an option that if you're struggling with single pass aspiration, think about double stentectomy. Yeah. So I'm done here. Thank you. So technically we are getting better. Clinically we are getting better. Thank you. Sorry about my voice.
Thank you. Thank you, Participant, for your talk on what is latest in stroke management. Now we will quickly move to our next talk. We will invite the next speaker, Dr. Mukesh Sharma sir, for delivering his talk on carotid stenting.
Thank you, Dr. Mathur. Good morning, everybody. First of all, I would like to thank Dr. Atulab and Dr. Nanda for this invitation. It's always be a pleasure to be in Udaipur, where I did my MD, and meeting so many seniors and colleagues. So my talk is, तो फिर क्या होगा? क्या करना? So my talk is carotid stenosis. Actually, the carotid stenosis is one of the leading cause of stroke, you all know, and the leading cause of TI and minor stroke. So this is the pathology which actually give times to prevent the future stroke if you treat properly, and treatment depend on what exactly physiology behind the stroke. So the first case, the moderate side stenosis, smooth plaque, just double antiplatelet is sufficient after the first stroke. Second one, you can see that there is a white dot that is actually thrombus, but not significant stenosis. So initial period with a single antiplatelet with anticoagulation for a month, just you can shift to the single antiplatelet. The third one, which is long segment atherosclerosis, irregular plaque, probably ulcerated plaque with the stenosis. This need immediately intervention. The last one is the severe stenosis, probably producing the hemodynamic stroke, require urgent intervention. So the treatment depend what exactly is the pathophysiology behind the stroke. So that common site for the atherosclerosis is the bifurcation, but atherosclerosis may happen at high cervical ICA also, sometime the petrocavernous junction or supraclinoid segment may involved. So that high cervical and petrous, even with the first stroke, you can do the endovascular treatment, but beyond that, that is actually ICAD. So before doing the endovascular treatment, right now, whatever the guidelines says, wait for a best medical management, and patient is having again minor stroke or TIA, intervene in those patients. Common carotid artery usually doesn't involve significantly atherosclerosis, but yeah, the radiation is one of the commonest cause for stenosis at this segment, and second, the Takayasu disease, where this part is involved. So what the cases I was discussing was the elective cases where we have to do the endovascular or revascularization therapy. Now coming to the acute phase. So sometime a patient comes with the severe stenosis and tandem occlusion. These cases already discussed in the previous talks. Okay, so this is M1, M2 occlusion in the second slide. So to approach that, we have to open up this artery. In acute setting, we would like to avoid placing a stent because we don't know this patient can have the hyperperfusion syndrome or not, and in that situation we will not able to give the double antiplatelets. So if nice angioplasty is done, it's not reoccluding in the next 30-40 minutes, we left that. And if, like in the second case, when the artery is reoccluding after the angioplasty, we have to put the stent. There is no second choice. What happened? So for the carotid stenosis, we have the two treatment available. One is the CA and second is the CAS. When I was doing the DM, there was always be a debate between the which one is a better. CAS is better or CA is better. But no, now there is no further questions. Which operative hand you have based in your hospital actually should be exposed. So this is a CREST style published in 2011, clearly shown both are equal. With the MI chances are much more with the surgical part, and minor stroke were common with the CAS. And the complication rate is less than 1%. So the neurointervention, what we are doing, the procedure, I think the least complication happen with the carotid stenting. And two more procedures, one is the DSA, and second is now we started doing the middle meningeal artery embolization. That is also one of the safest procedure what we do. And the third one is the CAS. So when it should be done actually, so in the severe stenosis, when the stenosis is more than 70%, it should be done as early as possible if it is not a contraindication. And what are the contraindications? Is the size of infarction larger than the 1/3 of MCA, or there is a thrombus at the plaque site, you cannot perform. Otherwise, it should be done as early as possible. And when it's going time passing, the effect goes further down, and after 6 months, there is hardly any benefit. So it's the same as asymptomatic artery. If it is a moderate size stenosis, then the absolute risk reduction is around 15%. Still, if you see the number needed to treat, which is always better in the neurointervention if you compare with the cardiology and procedures. Okay, but the number are still, we are hardly doing maybe 2% or 3% in comparison to the cardiologists, what they are doing for the heart. So I'm going to show you the basic steps, how we are doing, how simple it is actually. When we are doing the angiography, we want to know these much informations. What is the plaque size? What is the stenosis? How is ulcerated or not? There is a thrombosis there or not? We have the EPD's placement safe site or not? How tortuous it is? So these are the information we usually get with the DSA. Okay, so most of the time when we are doing the DSA, we take the two views. One is the AP, one is the lateral view. But sometime when you are assessing the carotid artery, okay, multiple view is needed. Like in this case, if you see from the lateral view, it looks like a severe stenosis. In oblique view, it looks like a moderate stenosis. From AP view now, it is a mild stenosis. So in the different view is needed to assess properly about the stenosis. Similarly, like in the another case, it looks like a moderate mild stenosis, but just a doubtful thrombus, small thrombus. In the second, another view, it's a big thrombus actually. It's covering half of the circumference of the artery. So the different view is needed. So not only the neck view, you need to assess the intracranial circulation also to see the other stenosis involving the other part of the brain, number one. Number two, how good is the collateral? Okay, so somebody is having the good collaterals and you want to perform, almost you are safe, the patient is unlikely to have the hyperperfusion. But those artery where you are placing in the stent, having a minimal collaterals, you have to be extra cautious after the placement of the stent, because these patients are deprived of blood before placement of stent, and these patients can have the hyperperfusion. So be careful, those who are not having the collaterals. So I'm not showing the case. Young gentleman, hypertensive diabetes, presented with the nominal aphasia. If you see that MRI, there's a MCA is involved. On MR angiography, the right is having a severe stenosis, left you hardly see. So almost complete occlusion of the left ICA. When we are doing the DSA, we always check the arch also, because we are going inside. So sometime that we can embolize those soft plaque. Be careful. So first is the arch angiogram. Most of the neurointervention takes. Second, the right, you can see in the both the view is a severe stenosis, but it's asymptomatic. Along with the patient is having a petrocavernous severe stenosis and subclavian stenosis, and a posterior circulation, generalized atherosclerosis. So this patient is having a significant atherosclerosis involving both intracranial as well as extracranial vessels. Now coming to MR, which was hardly visualized on MR actually, the artery which was symptomatic, it actually not completely occluded. It's almost severely stenosed artery. So we first did the left one. So these are the hardware which is needed for the carotid stenting, not significant. And these are the steps which I am going to show in a case. So whenever we are doing the carotid stenting, if you are doing the elective, patient should be on the double antiplatelet. And elective, we usually start 5 days prior to the stenting. If you are doing an emergency cases, then if you are loading with the aspirin and clopidogrel, it should be loaded 4 or 5 hours before the procedure. When you are using the ticagrelor, and I think my practice has been changed. Mostly we are using now the ticagrelor when we are doing the cast, because you just load ticagrelor and aspirin 1 hour prior to the stenting, and the chances of thrombus is very, very less with the ticagrelor. And in the 2 trials where ticagrelor and aspirin loaded were used in the TIA or minor stroke have clearly shown the better benefit and the less chances of the complications. So we are using the same trial. Okay, so these are the other that should be on table when you are performing the carotid stenting. So this is the first step, placing the guide wire and my catheter in the common carotid artery. The second step, to cross the stenosis with a wire. First, so I am crossing the severe stenosis with a wire. Then the delivery catheter for EPD. EPD is a protection device, distal protection device. And after the placement of the distal protection, that is the distal protection device. So there is a 2 school of thoughts. Most of people are using the distal protection device, and so many like Atulab is not using the distal protection device. Yeah, so it's always be a debate. Okay, so making it a little bit more complicated. We are using the 2 steps actually. So we in India having the distal protection device only, but in the world we have the proximal protection device also available. MeVO, it was available 3-4 years ago. Now I think it's not available. So these are the device which you are using, actually the filter. So when you are doing the plasty and placing the stent, some debris may go up. That embolization prevent actually captured by these devices. So you can see these are the 3 filter in my cases. You can see these are the calcified debris. If it goes up, you cannot remove. You cannot thrombolize this material. So better to use when you are using the particularly ulcerated plaque, highly calcified plaque. In those cases, better to use the EPD in these patients. So after the placement of EPD, we do the balloon angioplasty with the severe stenosis. So this is the first where we are using the balloon and assess how much is open up. Then we place a stent. So this is the stent, which is the second one, how it is opening. This is the self-expandable stent. As soon as come out from the delivery catheter, is open up by its own. It's having the significant radial force. So it's very simple. So we have the 3 type of stent actually. One is the closed stent, then second is the open cell stent, third is the mix. So in the middle 1/3 is having the one more net actually to prevent this a finer cell size of that. So after the placement, the chance of debris goes up will be very less. So that is called C-guard actually. So this is a closed open cell design. Open cell design cells are actually more flexible. So whenever we are the tortuous anatomy after the bifurcation, that is the choice of stent to use. If the anatomy after the bifurcation is straightforward, then the closed cell is better. So these are the different cases. In the first, I use the closed cell, second is the closed cell, third is the open cell design because the tortuous anatomy, and the third, again, last one is the closed cell design. So after the placement of stent, we remove the distal protection device. So my catheter is going to capture the protection device. Now it's capture and we remove. It's very simple. It takes mostly 15 to 22 minutes to complete the process in most of the cases. After the procedure, better to assess again to see the dissection, spasm, or some distal embolization in the intracranial circulation. That is very, very important. So most common complications which is happened during the cast is a bradykinesia and hypotension. Okay, and I would like to have in each and every cases. because it is going to reduce the chance of hyperperfusion. Okay, if it is not happening, okay, that is a trouble. Okay, if BP shoot up, in particular in severe stenosis, that may aggravate the chances of hyperperfusion. So that this brady and hypotensile usually settle in the next 24 hours to 72 hours. And you have to manage the blood pressure between 110 to 130. Second is the minor stroke, usually happen during the procedure. The devastating is the hyperperfusion syndrome, but it is not so common. Now coming to the asymptomatic artery, that is the actually controversial topic. The CREST-2 trial is going on, but most of the society included intervening these cases if stenosis is more than 70%. This recent trial, this paper published in 2023, shows the best medical treatment is equally effective than treating actually. But suppose how long you are going to treat the best medical management? Somebody is 60, are you going to give the best medical management for 20 years with a 80% stenosis? It is actually easy to talk on this stage, but it is difficult to in the practical, difficult to maintain in a practical. Stopping the cigarette, okay, tobacco for 20 years, those who are doing for last 50 years. So it's really difficult. So which patient is with the asymptomatic artery are more vulnerable for the stroke, you can assess actually. So if in a subsequent investigation the stenosis is increasing further, better to intervene. If hypoic area on a Doppler is more than 1 centimeter, is a vulnerable plaque, better to intervene. If there is a hit on TCD, better to intervene. If the opposite artery is diseased, better to intervene. So these are the few features you can assess in your patient and decide in an asymptomatic artery. So that's the same case, the right was asymptomatic, we did and later on. We placed, you can the first one, second after a month, and together we did the petrous cavernous also without any complications. So what is the best medical management? You have to bring down the LDL less than 70, not 70, I would like to say the less than 10 actually, okay? And the drugs are available now, so, okay, so 1 lakh rupees, 6-month injections. BP, you have to bring down 130 to 80, and HbA1c less than 7. It's easy to say, but difficult to do. These are the things where I don't want to, or I be more cautious doing the CAS. Okay, difficult anatomy, significant calcification, or just string sign, maybe just a vasa vasorum, it's just applying, not actually to lumen. But we have done in all scenario except the last one where the thrombus is there. I centered almost on all the scenario except the last one. So be cautious when these scenarios are there, we are doing the CAS. So I'm going to throw a one patient. I want to know which artery is actually creating a problem. So gentleman presented with the TIA. I don't want to say the which one, okay, and having a multiple emboli on the both the hemisphere. The classical teaching is cardioembolic. We investigated, done for 3-week device, no AF, echo absolutely fine, young guy. MR angio, moderate to severe stenosis on the right side, left side severe stenosis. This is the angiogram. So you have the same, like moderate stenosis on the right side, left side ulcerated plaque with the stenosis. Which one is the culprit? The right one or left one? Absolutely. How many are in favor of left one? No, it's not. If you can see the left, only supplying the left MCA, how the emboli can go on the both the direction? Well, flow is in the reverse, ma'am. So flow is from the right to left actually. So emboli probably even it's a moderate stenosis. If you say in the base of the plaque there is an ulceration, probably thrombus formed there, disclose up in the both the side because the flow is on the both the direction. But in this case, we treated asymptomatic first. I was not worried about because there is no thrombus further. We have not treated that patient on the symptomatic side. So we treated asymptomatic first, left alone, best medical management, and he's doing well, good. So CAS is very simple. Okay, the fear the physician, neurophysician having, it is not. It's as simple as they are doing the coronary. We have the good hardwares to perform this procedure. It takes 15 minutes to 20 minutes. Patient usually stay two days and discharge. Thank you so much.
Thank you very much. I mean, probably, Pankaj, thank you. I'll try to make it very short. I'll follow Manita sir. So basically, it's a, can I have my slides, please? It's a slightly different ball game. This is something like where molecular biology meets acute neurology. So this is the frontier. So this is on basic talk where I have my colleagues in the university from other departments also. They contributed to this. The whole idea was so the clock stopped. Okay. So this is a dream for any stroke, I mean those who do treat acute stroke, that do we have something which is quick, a kind of biomarker, which gives you very early diagnosis, prognosis, guides your treatment, optimizes your treatment, gives you response for your treatment, predict complications like hemorrhage, predict systemic complications, and maybe it is a target to treatment also. So this is a dream, which doesn't happen in real life. So basically, this is what an ideal biomarker would have. And in addition to that, lastly, it can subtype your stroke. Let's go further. Excuse me, this doesn't work. Okay. So stroke, by and large, you know, there is an insult to brain that leads to local inflammation and systemic inflammation. So this is the key. I will not be going into inflammatory cascade of a stroke. Okay. So there is, we all know, just we all have DNA in our cells, everywhere in our cell, I mean body in cells, in neurons also. So once there is a DNA inside the cells, whenever there is a neuronal insult, in stroke, in acute stroke, the DNA gets released into peripheral circulation. And this DNA has a very short half-life. It has a half-life of like 15 minutes to 1 hour. 15 minutes is average half-life of DNA, which is in a normal person, cell-free DNA or DNA which is in your peripheral blood is in very small quantity. Once there is a stroke, it gets released into your peripheral circulation. Can you just do it yourself? So basically, once it is spontaneously going, can I go back? So the whole idea of telling you this, so this DNA is it's a snapshot of dying neurons, which is there in your peripheral blood for a very small duration of time. So if you can measure this, you can actually, know so many things. How, I'll tell you. So this is, usually we know the cell can die in a manner of apoptosis, necrosis, pyroptosis, which is inflammatory cell death. So these are various modes of cell deaths. Let me just put an analogy. Whenever we have any bacterial or viral infections, how the body responds? It is the DNA inside the bacteria or a virus, which is sensed by DNA sensors in our body. So there is a lot of inflammation in response to that. So same way our own DNA, once it is inside the cells, it is outside the cell, it activates many receptors, DNA sensors in our cells, in our macrophages, in our neurons. So everywhere these sensors are there. So basically, the whole idea is these DNA sensors in our body, they mount inflammatory response. Okay, so you can actually, depending upon how much neuronal insult, can I have the next slide, please? So there is this kind of cytokine storm in response to inflammation. Next slide, please. So basically, the idea is once the dying neurons release DNA outside in the peripheral circulation, which is reflecting neuronal brunt happening in your brain. So this gives you very early diagnosis. If you measure this cell-free DNA, it gives you very early diagnosis. Then this DNA, amount of DNA gives you amount of neuronal damage you incurred in your brain. A hemispheric infarct, it will have more than 10,000 levels. So this is the amount you can measure, and you can actually prognosticate. Early diagnosis, prognostication. Third thing would happen here is actually you can optimize your, because it's kind of, quickly it can be measured, preferably on the bedside itself, and you can actually guide your treatment. So this is something like a hidden clock in our blood circulation instead of a visible clock where you do clinical imaging and MRI scan based. So the whole thing is, and next, so this inflammation is the key culprit probably in acute stroke. So more and more cell-free DNA is there, more and more it gets into peripheral circulation. You have acute inflammation, massive inflammation, not only in the brain, but systemic inflammation. If there is a massive stroke, so this would amount a systemic inflammation also into your circulation. And this inflammation, you need to really have good anti-inflammatory medications to suppress this. And you all know, as of now, apart from statin, we don't have any strong anti-inflammatory medication in our armamentarium to treat stroke. So this is a missing thing. So based on that, so this was a small trial we published that we started, yesterday I was talking to Manish. We started giving curcumin along with piperine in these patients, because this is, you don't require any DGCI approval for this. You just give turmeric milk along with a black pepper and did it almost in 250 patients. So they did pretty better than those who were not given. So that's the kind of small study we did. So this was the paper. Along with that, since we were more in basic science, when we were retrieving these thrombus sample in acute stroke by thrombectomy, we subjected these thrombus sample to metagenomic studies. We almost discovered 27 bacteria in these thrombus sample, which is supposedly a sterile compartment. And these were all commensals or low-grade pathogens. So again, this is a clue that how, as Mukesh was talking about carotid, so it is not amount of stenosis. The inflammation which is sitting in your plaque by virtue of probably, bacteria which are there in a biofilm there in your plaque, that would determine vulnerability to stroke. So so what happens here, since the inflammation is key, and cell-free DNA, can I go to next slide, please? So there are various biomarkers. I'll skip this slide. Next. So this is what you take 5 ml of peripheral blood in a radiated tube, okay, and you measure cell-free DNA. So basically, as of now, I mean, when we were doing this project, Cell-free DNA measurements were done by a nanodrop which extract nucleic acid by doing RT-PCR. So you can actually, quantify DNA. But the problem is it takes a lot of time. Can I go to next slide? Next. These are earlier papers. Can next, please? Next. So this was, next. Okay, thank you. So this was first publication in 2018, where when we did these initial patients, 26 patients with M1 occlusion. Next, please. Next. So these are self-explanatory. Next. 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 So I'll skip slides because sake of time. So this is what it is. Can you go to previous slide? Huh? It's working now? So you see, this was the first paper. Actually, at that time, the purpose was to see the amount of cell-free DNA, how does it correlate with your prognosis in patient whom we were doing mechanical thrombectomy or IV thrombolysis. So we found that after a certain threshold of cell-free DNA, the prognosis is poor, irrespective of whatever you do. So IV thrombolysis or thrombectomy. So this is what this paper. So basically the whole idea was this. Can you go to the next slide, please? So the outcome was, significantly related to amount of cell-free DNA. These are various methods by you can do cell-free DNA estimation by RT-PCR, nanodrop, TAP station. So I'll again skip this. So number increased. 26 patients. Now these are 54 patients study published. Can you go to the next one? Now we have almost 200 patients in this study. So we thought that after publication of these papers, we thought that cell-free DNA does give you not only early diagnosis, diagnosis is clinical in stroke, so prognosis, treatment optimization. Somebody has a cell-free DNA of more than 10,000, I probably would not do a thrombectomy or even IV thrombolysis and rather give it to surgeon directly for decompression if levels are so high. So this was initial impression. Then we realized that this takes a lot of time. So why not to turn into some kind of device which can give you quicker results? Next, please. Next. So then we started doing on a nanodrop, which gives you result in 40 minutes or so. So again, thereby we could, categorize mild, moderate, severe stroke depending upon the cell-free DNA level in the blood. So this was another publication on nanodrop. Next, please. Well, so the whole idea of giving the cell-free DNA, if you can turn this into some kind of equipment-free bedside device which can estimate cell-free DNA. This is something nowadays we have in ICUs. This is cartridge-based estimation where biofire and all these things we do for infections now. So this is a cartridge. In this, you can actually measure cell-free DNA within few minutes, maybe half an hour at the max. So this was the idea. Because the whole idea of measuring cell-free DNA, we know that it does help. The biggest limitation remains the time it takes, because in 3 hours or 1 hour, if you get the results in acute stroke patient, it doesn't really help that way. So this cartridge thing, actually there you can do cell-free DNA estimation even faster. Next, please. So now the whole thing is shifting that probably we are trying to measure that at some kind of POCT device, cell-free DNA, like what you have pregnancy strip on the bedside, so that you can measure this cell-free DNA on the bedside itself. So these are the various devices nowadays. Next, please. So this is lateral flow assay on a nitrocellulose membrane. Next. So, and this is simply a origami paper-based device, which is what we are trying to develop. So, origami paper device, so you can do wax printing, wax dipping, make channels based on the microfluidic principle. You can actually put your blood sample on the one end, get 2 lines like you have in pregnancy strip, based on colorimetry or electrophoresis or fluorimetry, you can actually quantify the level of cell-free DNA. So the level of cell-free DNA would give you maybe within minutes. So this will be equipment-free, bedside POCT device. So this is, next. So results will be within few minutes. It can be deployed in remote settings. There is a dynamic monitoring. So like in our project, what we did was we did on the baseline, then we did at 24 hours, then we did at 48 hours. So in real time, you will know how your stroke is progressing. Whether your IV thrombolysis or thrombectomy is being responded favorably by patient or not. Whether despite of doing that, levels are increasing. So then you have to really devise different strategy for treating these patients. So something bedside, because you cannot do MRI or CT scan now, every now and then. So moreover, what happens here, so this is a stroke clock, a hidden stroke clock in your blood circulation, which will guide your line of treatment, irrespective of time windows, which we talk of. So that would be a paradigm shift probably in stroke management in times to come. And I tell you one very interesting thing also about this cell-free DNA. Early diagnosis, I talked about it. Prognosis, I talked about it. Treatment optimization, I talked about it. Guiding further line of treatment, I talked about it. It could be a target to treatment also. Why? Cell-free DNA, ultimately any infection, any virus, bacteria. So cell-free DNA is a protein of DAMP family, damage associated molecular patterns. So the DAMP family proteins, like for bacteria virus, we call PAM family proteins. So their DNA, RNA would be PAM family. So this is the same thing. It is a pathogen inside your bloodstream, in your peripheral circulation, in your neurons. The only thing is, as madam was talking about methylation, there are CpG moieties on a DNA which are unmethylated usually in a human DNA. Once they are methylated, they become pathogenic. So the amount of immune response your body mounts in response to your cell-free DNA. Let's say we talk about pneumonia and UTI in a massive stroke patient. It is not always nosocomial thing. Your catheters and wires and these are not producing UTI or pneumonia. It is the amount of massive cell-free DNA analogy to viral load or bacterial load inside your body that incite this response. So this is a very important thing, and why I'm saying, as Mukesh was showing so thick blood clots in his filter devices, these cell-free DNA, once they are entangled in your thrombus, you cannot lyse them with TP or any other thrombolytic agents. They become very hard. So then what to do? You know this DNA is not only producing so much morbidity in your body. So what to do? There are DNase drug available. So in inflammatory cascade, at least we have DNase commercially available, which, I mean, these pulmonologists use for cystic fibrosis, I think. So commercially it is available. So why not use this DNase along with TPA or Actilyze in these subset of patients? So this is one thing which, I mean, obviously trial would answer in times to come this thing, but we have already, we need to think in terms of inflammation, in terms of targeting this cell-free DNA, so we remove them from circulation and probably improve the prognosis of these patients. In the end, depending upon the methylation pattern in cell-free DNA, you can actually make it certain whether it's a large vessel disease, small vessel disease, a cardioembolic stroke, because the cell of origin can be identified. So this is the beauty of this. Can I go to next, please? I think. So I'll finish here. So the whole idea was just to give you a different perspective in acute stroke management, which will probably come from molecular biology in times to come. Thank you very much.
And we know each other for, I think, more than 30 years. And he has fellowship of American Academy of Radiology, Indian Academy of Radiology, National Academy of membership, and he is so well sought after. One line will be sufficient. He is Secretary General of World Federation on Neurotheology and doing wonderful work in the field of neurorehab. Hereby, I present you Dr. Neuro.
Thank you, Dr. Mandirata, sir. Dr. Atlup, my dear friends, it is a great privilege to be here and speak about neurorehabilitation. The last 10 years, that is one decade, what I have seen is at 80% of the people call me to talk in the last session last day. But there is some change which is happening is now people are inviting us into the first session and second session. I know you guys are all expert, you do the thrombolysis and get the result in few minutes to few days. But neurorehabilitation takes time. And therefore, Atlup, 15 minutes is not a justice to provide a rehabilitation. But I'm going to give you a brief idea that how, if you are not into this field, what you are going to lack and what your patients are going to miss. So I quickly will give you the ideas, try and finish it in very short period of time of my slides, and I'll move them very fast. So I'm not going to speak to you about India. I'm not going to speak to you about stroke. You all are expert. But you know that most of our people are living in rural area where the rehabilitation specialists are not many. And there are different areas in the country where the stroke is much more common, and therefore these areas where the rehabilitation is not that well developed. So where the stroke incidence is high, we need to put an stress, because as you all know that nearly 50% of patient lives with some disability after the acute stroke. And you can see that it equally affects the both men and the women. But if you look at the manpower for the neurorehabilitation in India, and you can see that out of the 5,000 neurologists which we have, only 2,000 are sensitized for rehabilitation. And same is about PMR. So you can see that only 1/3 to 1/4 are the people who are working in the field of neurorehabilitation. And the worst part, the brain drain. So you can see that 2023 India human flight and brain drain index was 4.9. That means our trained people are moving out of the country. I think the Trump's increase in H1 visa fee would help India, because our experts will remain here and serve to our people. We should thank him. Now, what is the comprehensive care program? You all talk about primary prevention, acute thrombolysis, mechanical thrombectomy, MEO, LVO. But have we thought about that our stroke unit should have all these 5 things? That is basic stroke organization of stroke unit, hyperacute, acute, surgical management, stroke system of care and surveillance, and rehabilitation, and finally customize of stroke training and local settings. So if you are running best of the center, and if you are not taking care of all the complete part, I think you are incomplete. So you need to improve on that. You may have one of the best center. Now, neural recovery happens because of plasticity, and rehabilitation is something which push. And these are some of the way, if you look at the comprehensive care for the stroke care should include right from the risk factor to the reperfusion, to the cognitive therapy, neuroprotection and repair, and rehabilitation. And you can see that rehabilitation comes at third. And that is what is very, very important, because we need to promote repair. The neuroplasticity is there to make the recovery. So we did this study in Bombay Hospital. One of my residents wrote this article. He did consecutive 100+ patients. And you look at the amount of money spent on rehabilitation, even in best of the hospital, 3%. So that is something, again, need to improve. Under me, so I can understand that other people, it may be only 1%. And we also interviewed the neurologists. And if you look at the education, training, and practice of neuro rehab, majority rehab center are urban area. 38% have one or more multidisciplinary team, so there is no multidisciplinary team. And education and training is subpar. Monitoring benefit for professionals are low, and there are no advanced rehab centers available at all the places. I won't say they're not available in India, but not at all the places. And if you look at stroke situation, rehab situation in India, and I interviewed all stroke specialists. In one of the stroke meeting, I did this survey myself. 200 people I surveyed. 58.9% responded who have stroke unit, and that too in an urban setup. Only 18% had dedicated stroke rehab center. So I think this is something we need to really improve upon as a stroke specialist. And you could see that average cost, no tele-rehab in 70%, and that is something which is going to be the key factor for this country where the large population lives in rural area. And what are the things are, there are about 1,250 stroke centers in India. And if you look at the regional distribution, South India scores better than other part of the country. And if you look at urban versus rural disparity, 80% centers are in urban area, and only 20% of stroke rehab serves in the rural area. And if you look at advanced center, they're only 30%. And basic rehab at least are seen in 50%, which include a physiotherapy. Home-based and tele-rehab services only 20%. We need to improve it, be above 50% if we want each and every patient should get the rehab. And this has to be multidisciplinary approach. When in 2000 I started the neuro rehab OPD in one of the municipal hospital in Mumbai, there was no concept of multidisciplinary, but today it is well accepted. Everyone accepts that we have to have team to look at the patient. If you look at the conventional rehab, what we have been doing all these years was neglected was impairment. We were only looking at compensatory pathology, but now the modern rehabilitation should look at impairment, functional limitation, and treat the disability. That's a change which has come. And these are the phases of stroke rehab. Acute phase is 0 to 3 months, subacute is 3 to 6 months, and chronic phase is more than 6 months. Now you look at the transition. Many of us are practicing from 1990, but many of you are practicing from 2010, 2025. But you look at from 1990, I remember Rambhai Patel, who was one of the senior most physiotherapy, will put a hook into the wall, put a rope, and ask the patient to do the exercise for the hand and the leg. And from that, we have now come to the robotic. We have robotic for the wrist, elbow, shoulder, full hand, leg. So you have a great equipments today available. Again, you look at 1990, only parallel bar. Most of the center would have parallel bar. But move to the body supported. This was the treadmill which we built up in 2000 in Nair Hospital with local made stuff in 25,000 rupees. But now you see today the best of the treadmill available with body supported. They are expensive, but they are available, and many of you are having it. Again, you look at the transition from 1990 to the 2025. RTMS, TCDS, and VR, which has changed the complete outcome of the rehab. And if you look at even training in last 25 years, how it has changed from traditional method to the transitional phase to the present modern approach. So we are moving very fast. Like you have seen, thrombolysis, thrombectomy, we are also moving fast in the rehabilitation, same pace, and new treatment are come on, including all the aspects which you can go through. And if you look further, traditional method for neuroplasticity, remote and home-based, multidisciplinary, and motor learning technique, they have also moved from 2015 to the present. Early rehabilitation is the concept. When I joined the DNB in 1984, a stroke patient, 15 days, lie in the bed, do nothing. But today, within 24 hours, we are mobilizing the patient. Tilt table is something which every stroke ICU unit should have, so that you can start mobilize the patient from 3rd to 5th day, and here the patient on even 7th day has been made to stand with large intracerebral hemorrhage. There are so many papers which comes and which shows that early rehabilitation is the key. We have AVERT study from India, which also favors that. So what are the strategies to improve the neuro rehab in India? Task shifting. Since we do not have many trained people, we need to have people who could do the task shifting, and this can be done through the training phase, practice phase, and maintenance phase. We have been doing this, including involving the caregiver, nurses, and others. Family-based rehab is something which is the key, and you need to train the family right from the day one, which could be an ideal rehabilitation in country like India, because we are having a very strong bond in our family, and family can take care of emotion, and they understand the patient much better than others. And family-based rehabilitation along with the tele-rehabilitation is the key, which I wrote in 2019, much before the COVID. But COVID has proved that this concept is going to be the key for the neuro-rehabilitation in developing countries, as well as in countries where the population is largely remaining in the rural area or village. So we need to strengthen tele-rehab in our countries. These are the ways which can be looked into. These are the motor rehab, which has changed from task-specific training to mirror therapy, robotic, exoskeletal, virtual reality, functional electric stimulation, high-intensity repetitive practice. Aquatherapy is coming big way. Many of the centers are now coming out with big aquatherapy, and high-intensity interval HITT is something. Similarly, in cognitive rehab, in the stroke, there are a lot of new things has come. Computerized training, the app-based therapies are something which can be done at home without even the therapist, and they are taking a lot of interest, a lot of new development has come. Speech rehabilitation for both aphasia, dysarthria, and apraxia, and constraint-induced speech therapy is similar to the constraint-induced movement therapy, where patient is encouraged not to reply in the gesture, but every time practice with the volume. So these are some of the new therapy. Again, augmentative and alternate communication is also being used by the therapist. Similarly, swallowing rehabilitation has been very much looked into, and it is now something we are looking into more and more. We need to have access, and NMES is something which can help many of our patient stimulation and allow the swallowing. There are modified diet, there are EMST, and FES is something which we need to do. We again, another student did the study, and he evaluated more than 100 patients with swallowing assessment. Even on day one of admission, when the patient is out of the ICU and on the discharge of the patient. And you could see that it can tell you the severity of a stroke. Those who have persistent dysphagia have more severe stroke. Those who have posterior foci stroke, they continue to have the dysphagia. And nearly on admission, more than 40% patient has the dysphagia, which remain up to discharge in nearly 12% of patients. So this is something which is an eye-opening, and we need to do assessment day one or day two. Challenges of neuro rehab in India are limited access to service, high cost of treatment, shortage of trained professionals, lack of awareness and education, inadequate insurance, lack of standard care, underfunding in public sector, insufficient research, fragmented healthcare, and the social stigma. So there is also change in the cognitive rehab in last 25 years. And I'm sure if you look at the cognition of all your patients whom you have done IV thrombolysis, you will find that though thrombolysis has improved the motor function, there is a significant amount of cognition yet been affected. And this study is something, there are a couple of centers which are doing, and we really need to look at that. And I think those who are doing active thrombolysis, they must look into. These are some of the key changes in stroke education in India, and we are improving upon that, try to help them. This is how we have trained more than 500 people with botulinum toxin in stroke. We also looking at low-cost make in India, and these are some of the techniques which we are developing under the banner of IFNR. This is a glove for the hand which we have developed, and this is again low cost in India, less than 3 lakh rupees, and it has been added with FES, and now we are developing BCI along with this glove. So this is something new technology we are developing with IIT Gandhinagar. So these are some of the development which we are doing. And if you look at the stroke rehab in India in PubMed in last 25 years, there is a significant increase in number of articles showing that a lot of new people are coming to this. And these are the consensus statement we have developed. The rehabilitation, first time in the world you have a textbook which was come from India, and I'm very proud that we have been able to do that. IFNR has also developed a journal, so if your rehab article, you are most welcome to send us to the publication. Stroke in neurology has also been taken, and this was the first time review in neurology which came, and then regularly we are featuring. Now we have advanced stroke care, which also features the physicians we have. This is something you can get online free of cost. Clinical pathway in stroke rehab, which we have produced from WFNR. It gives you everything about stroke rehabilitation, right from the primary acute care, right up to the community care of the stroke. So to conclude, rehabilitation following stroke has evolved in India in past 25 years. Importance of MDT and new technology has been recognized. Low-cost rehabilitation is need of our, and we need to develop, make in India, low-cost robotics, low-cost VR, low-cost BCI to develop for our patient. Education and training need to have important, and Atlub is really working hard, and we are starting the fellowship in neuro rehab, first time in this country, along with Atlub in the Pacific University. I think your therapists can look for it for 1-year training, which will have an internship with Romania Society for the 2 weeks to go there and train. So awareness on early rehab with MDT approach to be followed uniformly with common guidelines. Insurance coverage for rehab, we have been working on to get the packages with ICMR for the rehab, and rehabilitation for stroke may be quite different in the future in India. And for those who are really interested, this is something next April, tele-neuro rehabilitation, first time happening in India, which is going to change the practice of rehabilitation in this country. And I'm sure you all will find it very, very interesting. I think don't miss out the chance. If you have 1% interest, join there. And those who are into the rehab, the World Congress of Neuro Rehabilitation is next year at Korea, Daegu, and the abstract submission is open. You are welcome to send. Thank you very much.
Thank you so much, Dr. Surya, for your concerted, continuous effort to improve neuro rehab in the country and at Asia-Oceania level and national level. We all are with you and wish you all the very best in your vision and mission in this direction.
Thank you, sir.
Thank you so much.
Thank you.
Dr. Abdullah, please.
Thank you very much. Thank you, sir, for chairing the session. I mean, I had just, because we are already running short of time, so I think tea and coffee is already on from the beginning. Those who want to take tea, coffee, we can continue the session if, I mean, is that okay? Is it okay if we continue? And meanwhile, somebody is willing for a coffee or tea, they can go out and have it, if that works. So, I think we can move to the next session. May I invite Dr. Madan Mohan Gupta, Senior Consultant Interventional Neuroradiologist from Jaipur. Madan has recently changed to Mahatma Gandhi Medical College. Dr. Rajesh Khoiwal, Senior Consultant Neurologist from Paras. Dr. Mukesh Garg, Professor Neurosurgery, Ananta Medical College. So, chairpersons are there. Pardon? You want to, maybe after this we can have questions. Yeah, sure. So meanwhile, Dr. Madan, I think if our speakers are also around, Dr. Rakesh is here. Okay. If you can introduce Dr. Rakesh Singh and we carry on.
So for the next session, I'm talking about the cerebral liaison to access our aneurysms. I would like to invite Dr. Rakesh Singh. He is a senior intervention neurologist in Mumbai. Yeah. Good afternoon, everyone. We'll be discussing in short what to see in the aneurysm during the DSA and how we do it. So, can we start, please? Sorry, I'm not very good at all these technical things, so play kar do. Just play there. Yeah. So here we go. So when we do a DSA, always the debates are for all these points. So in short, I thought one line, groin puncture versus radial puncture. All trials have shown that both are more or less same. So whatever you prefer, you can go for a groin puncture, you can go for radial puncture. But by and large, we are more comfortable with groin puncture because it is faster, because the artery is larger, and our all catheters are basically made for groin punctures, though now radial catheters are coming in. Now, use of heparin in acute subarachnoid hemorrhage. If we are using a new material for all the cases, then definitely we may not use the heparin. But if we are reusing the thing, then heparin preferably should be given. We usually give 1,500 heparin prior to the angiography. Now, I'm not talking about the treatment part, only the diagnostic part. Anesthesia, if patient is cooperative, obviously local anesthesia. But if the patient is uncooperative, moving, language barrier, then better to have a general anesthesia during the procedure. Machine, to be truthful, machine doesn't matter. If you have a C-arm, you have a good machine, bad machine, whatever. If we do it properly and we plan it properly, on any machine, diagnostic DSAs can be done, and more than 95% of the procedures can be done, I would say, on any machine in the world. So we should not crib about machine, my machine is not good, my machine is not bad. Most of the time it can be tackled if we plan it properly. Obviously, patient has a renal dysfunction, then non-contrast medium like MRI we can do, and we can do a dedicated 1 or 2 shoots in 10 to 15 ml of contrast, which can be done depending on your preferability. You can use CT contrast or you can use MR contrast. Both are relatively safe if we use a low quantity. Sheath, for diagnostic purposes, we use usually 4 French sheath, but please be aware that when you are using a 4 French sheath, you should have a 4 French SIM catheter also available, because if suddenly the anatomy is difficult, then you have to convert from 4 to 5. So sheath, wire, we usually use a Terimo wire, but whatever wire you are comfortable. And catheters, depending on, again, your preferability, you can use either H1 or you can use vertebral catheter, whatever you like. So coming to the main aneurysm plan. So the plan of our DSA is not only to diagnose aneurysm, because most of the time when we take them on table, we know that the aneurysm is there. So diagnosis is only one part if the vascular imaging is not done. If vascular imaging is already done, then that part is already taken care of. So why to do DSA? So basically the aim of doing DSA is to plan the treatment. See what we are expecting during the treatment and what best offer we can give to treat a specific patient. Many times as an interventionist, we may not be doing the case. It may be a good case for surgeon. So while doing DSA, we should keep in mind that the patient may be going to a surgeon. So from his point of view also, we should think of when we are doing a DSA. And once a diagnosis is made and the treatment plan is made, no need to do extra runs to increase the dose or radiation dose of patient and ourselves also. So once the diagnosis is made, we should stop there. Now 3D is always good. If we have a 3D in our lab, it's always better, all of us know. So you do a single run, you do a 3D run, check which is the best possible view, do that view, come out. So it saves time, of course, but if you don't have a 3D in your lab, nothing to worry. Most of the time, if we logically use our AP, lateral, oblique views, we can know which is the best possible way to go. So like this case. Now, if someone shows me this image, it is useless. I just know it is aneurysm. But just I make one oblique view, I know that the MCA is there, distal artery is fusiform, it's a dumbbell-shaped aneurysm, one artery arising from the neck. So just taking appropriate view, which will be useful for the treatment, is the most important thing while doing the DSA. These all things we should keep in mind. When DSA is not seen, the aneurysm is not seen, or normal artery, we know there is aneurysm, and we are doing other DSA for just to rule out other aneurysms, then AP and lateral, or down or lateral, whatever you prefer, those views are more than sufficient. Now, when we are doing a DSA for any subacute hemorrhage case, we should always do bilateral IC and bilateral VA. Believe me, minor things can be missed if we don't do all 4 arteries. If all 4 arteries are not showing aneurysm, then we should always plan for bilateral ECA and subclavian runs. Because as all of us know, that dual AV fistulas and micro AVMs are known to have a SH-like presentation. So when the DSA is negative, always you should plan for bilateral ECA and subclavian run. And sometimes we know that even spinal dual AV fistulas or spinal AVMs can bleed in the brain. So especially if the blood is in the posterior fossa and patient started with a lower back pain or lower neck pain, then definitely we should think of spinal. This was one of the patients who had ruptured twice, two ruptures, twice DSA done, labeled negative, and third time when we saw, classical history was neck pain, and patient had aneurysm. He was bleeding actually in the spine, but the presentation was like a SH. So we should always keep in mind, if DSA negative, we should think of spinal SH also. Obviously, all of us know that the first DSA is negative and it is not perimesencephalic SH. We should plan a second DSA after 3 to 6 weeks because of the spasm. Many times at acute setting, we may not see the aneurysm. Now, coming to over-reporting. Sometimes the aneurysm is not there and we tend to report. Like all these slides which I am showing, all these cases were reported as aneurysms and treatment was planned. Sometimes treatments were done and retrospectively realized it is not aneurysm. That's the reason I thought. Now this case, so he was labeled as a infundibulum with bleed, rather it was labeled as a bleb, and the treatment was planned. But we thought, no, even a small artery, if it is coming, it is a infundibulum, it is not a bleb. This was to my case only. I was out, the DSA was done, it was labeled as there is a small clot there. This was labeled as, sir, there is a small bleb, we should plan flow diverter. I came in, I said, no, जोर से shoot ले वापस से, second shoot. 1 minute later, the artery is seen. So it was definitely not a bleb. It was, and no, these mistakes all of us do. These are all our cases. I also have done mistakes and I have learned. So just thought we should think of that. Going to same thing like this. It's again an infundibulum with a posterior communicating there. Again infundibulum, posterior communicating there. Now this is the true bleb. Now true bleb usually, first rule, the artery should not come from the dome. That is first rule. And second rule, most of the time it is on the medial or the posterior surface. So it will be better seen on bit oblique view, not a classical or lateral view. After all these things, always confusion is there, whether the infundibulum can bleed or not. Yes, it can bleed. So this was one of those cases. It was infundibulum, but usually the infundibulum which bleeds are larger and they're multi-lobed. So this was bilobed with an infundibulum. Of course, it was the cause of the bleed. So whenever we have a bleb, if it has ruptured, then we should be careful in reporting all these things. Coming to perimesencephalic, we are traditionally taught that classical perimesencephalic bleed usually are non-aneurysmal, and we need not do so. Most of the time we do CT angios or MR angios, which are negative, and we say DSA is not required. But personally, as an interventionist, we feel that yes, it should be done, because once in a while these odd cases is going to come. So these are 2 cases in the last 2 months where, in fact, this when I showed to my surgeon, he was not convinced. He said, nahi, Rakesh, this is not aneurysm. I had to go in and put a microcatheter and show him, no, it is aneurysm only. It is not a artifact of my DSA. And this was one of those very small distal aneurysm seen in a distal artery. So perimesencephalic SH, yes, majority of them will not be secular, we know that. But once in a while, we'll have few odd cases. So I strongly feel we should do at least one DSA, good DSA, to look for posterior circulation, minor things which can be missed on CT angios or MR angios. Now coming to, while doing the DSA. Always when we are doing a DSA, of course we decide what is the site of the aneurysm, what is the size of the aneurysm, and what is the direction. In our reports, we should always mention these things because it's good for us, it's good for the surgeon who is going to operate after us if we are not operating. And as far as possible, we should always point towards the evidence of rupture. This is especially important when patient has a multiple. These are images of single patient. He had one SCA, he had MCA, he has ACOM. Now, which to treat? Obviously, we go by CT scan where it has bled. So first indication will be where the bleeding is most. For many times, the bleeding is so much, it's everywhere. So it's difficult to know where exactly he has bled. So first we should treat the aneurysm which has bled. And then, of course, if it is amenable, then we should treat all the aneurysm. Like in this case, to be truthful, I was not sure which aneurysm to treat. Because all three aneurysms had a bleb. And obviously the SH was extensive. So we ended up treating all three. Fortunately, patient went well. This was one of those. Same thing. Now this, again, if we see a bleb, it should be reported so that it can be treated accordingly. Second thing, once we have diagnosed the aneurysm part, we should always look for the spasm thing because it has a treatment implication. If patient is in severe spasm, these patients are not good for surgery. The moment we touch those arteries, they go in spasm and invariably post-op, patient will have infarcts. But we know that from intervention point of view, we can treat them safely. So these were two cases where there is severe spasm of the ACA and MCA. These cases should not go for surgery. They should directly be posted for intervention. They are very high risk for surgery per se. Other effects, of course, we should note if we have mass effect or hydrocephalus. Now I thought we'll go by one aneurysm, which are common. So for ACOM, if the fundus is down, down and oblique views works very well. If the fundus is up, then the caudal and oblique views works well for us. This we should remember because our aim while doing the DSA is to show the neck. Unless we show the neck, of course, we cannot plan the treatment properly. So in a ACOM aneurysms, obviously, the aim should be same, we should clearly see the neck. Most of the time, caudal views and caudal oblique works very well for us to show the neck. Now, from ACOM aneurysm, usually they are both amenable for coiling and clipping. So if really it's a wide neck aneurysm and chance of recanalization very high, of course surgery should be preferred. But in a narrow neck or wide neck where we can do coiling easily, it should be preferred. But ACOM are one of those aneurysms where both thought for intervention as well as surgery, both things should be given. Same is true for PCOM. PCOM is easy for surgery, PCOM is easy for coiling. So depending on the morphology of the aneurysm, we should decide whether patient goes for coiling or clipping. The best view for PCOM aneurysm most of the time is pure lateral view. The lateral view gives you exactly where the aneurysm is and exactly where the PCOM is arising. So that becomes easier. As I said, it's good for coiling and clipping both things. This we should keep in mind. Now many times the neck is not seen well in the lateral view. So if in the lateral view you just make bit of caudal or cranial, the neck opens up. So those things we should keep in mind when we are doing the PCOM aneurysm morphology thing. Paraophthalmic aneurysm, again, the best view is lateral because the artery is, as we know, as it enters the brain, it is completely lateral. So we can see even small aneurysm nicely in a lateral view. And for paraophthalmic aneurysm, because of the surgical difficulty, because as we know, the bone is just here. So it is very difficult for surgeon to get the lower part of the neck. So these aneurysms are preferably, they should be coiled rather than clipped. Of course, there will be preferences, but I'm just going for more likely and less likely. Coming to fusiform aneurysm, these are very difficult aneurysms to treat. Believe me, half of them will present as ischemic symptoms. But by and large, if patient presents with ischemic symptoms, we should not treat them, either intervention or whatever it is there. So ischemic symptoms, fusiform aneurysm should not be treated as far as possible. If a patient comes with a fusiform aneurysm and bleeding, yes, a treatment should be considered, but all of us know, being interventionists, that our complication rate for fusiform treatment is very high, which should be conveyed to patient. Basilar fusiform, 25% complication rate. It's a big rate. So unless we are forced to intervene, as far as possible, we should be conservative, especially in a non-ruptured or non-bled cases. So these are few cases. MCA fusiform, obviously we did not treat. This was ruptured, but we treated this. The patient did not do well. This we treated. He had a bleb. He did well. And this obviously we did not treat because he had ischemic symptoms. Patient was throwing repeated TIAs. Now coming to dissecting aneurysms. These are various dissecting aneurysms. All of us know V4, V4. This was one of unusual PCOM with a rupture. These are cases which are going to come in time. So first DSA may show very small aneurysm in the supracranial ICA, and 3 days later the aneurysm was this much big. Now these cases are the cases for, I would say, intervention, preferably obviously flow diverters to save the artery. All others, if the dissection in the distal artery, still I would say the best treatment is just to occlude the artery. If it can be safely occluded, of course that is a treatment of choice. If it cannot be occluded, so either flow diverter or we should bypass the artery and occlude the artery. So that will be the treatment of choice. This case here is a pica aneurysm, so obviously rest all we occluded, these two we did a flow diverter. Coming to vertebrovascular or posterior circulation, now this is coiling, coiling, coiling. There is no role of clipping. Those surgeons will say, or I'm not blaming someone, but many surgeons clip. Now this example, this patient was posted for clipping before we were involved. So posterior circulation, any aneurysm, as far as possible, we should go for coiling, not clipping, unless the social factors or whatever factors are there. So posterior circulation, so basilar top, SCA, V4. This obviously will be the flow diverter or occlusion if the artery is non-dominant. If artery is dominant, we should try to save the artery. All others can be coiled or device closures, as Dr. Nitin will be talking more about it. MCA. Now we are on the opposite side. So MCA aneurysm, as far as possible, are better for clipping. Why? Because it's easy to clip. The outcome, long-term outcomes are definitely better with clipping. Whatever device we use, see, all of us do MCA device closures, I'm not denying that. All of us do MCA coiling, I'm not denying that. But in the best possible scenario also, our cure rate is not crossing 80%. I would say best centers, best hand. But in a clipping, MCA straightforward, wide neck, the cure rate, all of us know, are more than 90-95%, maybe more, not less. So MCA aneurysm, wide neck, still I prefer clipping as a first choice. Obviously, if patient doesn't want to open surgery, coiling can be done. I'm not saying it cannot be done. All these cases could have been done with the coiling. But we should give them choice. Let patient decide what he wants. So this was wide neck. All cases we gave clipping first choice. But patient decided no. She was a lady with a religious belief that her brain cannot be opened. So we closed it with a device closure. This case, actually we coiled first because at that moment patient did not wanted a open operation. So we coiled it and later on we clipped it. And all rest of the things we had to clip because patient's choice. Other aneurysms, sometimes we will have AVM with aneurysm. So in these situations, obviously, if we are going to treat the AVM, first the aneurysm should be tackled. Because if we treat the AVM while pulling the catheter, all of us know that artery straightens. And that is the time where these aneurysms tend to rupture. So if you are planning a treatment of AVM, then we should treat the aneurysm first, go in and then treat the AVM. Or if you are not treating AVM and this has ruptured only subarachnoid hemorrhage, obviously the aneurysm should be treated first. This was unusual locations, A1, A1. This is not unusual, this is common, I would say. This was one of the, again, first DSA was negative. This, a small aneurysm, the supracranial ICA, was seen on the second DSA. As I said, in such aneurysms, in a thick SAH, spasm, this will not be seen on the first DSA. So this was, it was a large SAH. So we thought we will do a DSA on the third, fourth day only. On third, fourth day, we could see this small aneurysm which can be missed, and this is one of the classical carotid cave or bleb, whatever we want to call. Now coming to the last slide. See, we all of us do DSA, but always, many times we find that the report is not proper, I would say. So always when we do complete a DSA, our report should always include a clinical history. Why? Because see, we know the patient, but patient may not come to us for follow-up next time. He may go to someone else. Now if we say 5 mm aneurysm, I don't know whether it is ruptured or unruptured. Patient is not giving me history, he has come for second opinion. So if I have a thing, okay, it is unruptured aneurysm. So the second person will be at ease to give an opinion, unruptured 4 mm I will not treat. 7 mm ruptured, of course I will treat. 2 mm ruptured, I will treat. So a short clinical history in our report should always be preferably mentioned. We should always mention, as I said, site, size, and any site marker of impending rupture. Say a bleb is there, a dissection is there. If these things are there, even if patient is asymptomatic, we tend to treat those patients. So those things should be always mentioned. All 4 artery reports should be given. See, all of us are in hurry. So we write MC aneurysm. And believe me, all of us must have seen those cases. There is one aneurysm mirror sitting on the left side also, which all of us have noticed but not reported. So preferably all 4 arteries report we should give when we are doing a DSA. Subtracted and unsubtracted images should be given. See, everyone will not have a iPhone ka app where we can subtract from non-subtract. Patient may go to a tertiary center, secondary center, where the unsubtracted images may not be there. And surgeons prefer unsubtracted. See, as an interventionist, we most of the time don't need unsubtracted images. But for surgeons, AP and lateral, that is the most important view to plan their surgeries. So preferably we should give subtracted and unsubtracted images of at least the aneurysm. And always when we are giving a report, we should give a treatment plan. We are not diagnosticians. We are treating the patient. So whenever we give a report, we should always give a treatment plan. Okay, clipping is preferred, but coiling can be done. Flow diverter should be done, but clipping can. Whatever we feel at that moment or whatever good for that report, we should do that. But it should be mentioned and committed. Because many times patients are, all of us know, patients are confused. We are talking about 10-15 lakhs when we are doing any major procedure. So those plans should be always mentioned on the report. Thank you.
देखना पड़ेगा ना, इसको पहले बंद कर दो। पहला स्लाइड लो। आ गया है वो आपका। ये है ना, मेरा ये ना। नहीं ये आपसे से ये नहीं, ये इनका था। ये हो गया। हाँ ये ओपन नहीं किया था। ठीक है, पहला स्लाइड। बस ठीक है।
Thank you, Atulab and Arvind, and thank you, chairpersons. A pleasure to be here. I think Rakesh has made a beautiful presentation. He has shown exactly what we should look for and what we should report when we do a DSA. I have been asked to talk on selection of hardware and for treatment of aneurysms. But I'm to be followed by others who are going to talk on flow diverter, on intrasaccular devices, etc. So I'll try and keep my talk more general. So equipment, I'll divide into equipment, accessories, access, microcatheters, coils that we use, and the assistance hardware that we use. So the most important thing is, though Dr. Rakesh mentioned that any cath lab is enough, if you have a biplane, I think that is ideal. We don't have a biplane, we are working on a monoplane. But if you can have a true neuro lab, the big advantage is that in addition to the intervention part, you can do a CT. So if there's any complication like a hemorrhage, or if you are deploying a coil or injecting glue or onyx, you can see where it is going in the brain. We see only the arteries when we are injecting. We don't see the brain. So if you can do a CT, especially if there's a small hemorrhage or a small amount of glue or onyx going astray, you can see it very well on the CT. So on these newer neuro labs, you can do a CT immediately. Of course, you can do rotation and Dyna CT. The Dyna CT is what we are talking about. You can do magnification and something called a 3D roadmap, which again is very useful when doing complex cases. And the biplane is very important. Unfortunately, we don't have it. Very few places have it. Atulab is one of those who has the pleasure of having it, where you can see in one plane you think it is going perfectly as you want it. When you look at the other plane, you're horrified. Alright, it's gone somewhere else. So that happens. So this is the equipment. What are the accessories? So here, for instance, this is a connector. This is a Y. It used to be only a Y like that with one arm. Now we have two arms. So sometimes when we didn't have the W, we used to connect 2 or 3 Ys in succession, because we may want to take 2 microcatheters, we may want to take a microcatheter for the coil, 1 catheter for the stent, etc. So a W is very important. 1 ml lower lock syringes. When we had started out in the 70s and 80s, there were no 1 ml syringes, lower lock syringes. Non-lower lock you can get, but we work only with lower lock because we are worried about air. So if the syringe gets disconnected from the catheter, air can get in. So that's the reason we always use a lower lock. Heparin, already mentioned, we always have nimodipine going in the irrigation. Nimodipine to prevent vasospasm. And one thing which I always talk about is, the arrow is not coming there. Oh, no, you don't see the arrow. So one thing that I talk about is the blood set. A lot of people use saline drip set without filter. The filter is the important thing. So that blood set that you can see, it is with filter. So you have to make sure, yeah, so you can see that filter. So this is very important when doing any intervention. And I've learned this from Professor Picard, and whoever has come and seen us or worked with us has always used a filter. Nimodipine, of course, after we finished, Omnipic is the contrast that we use, so we can use any non-ionic contrast. And it was often believed that Visipic, which is iso-osmolar, is better, but now they have shown that it doesn't really matter, provided you have primed the patient well, patient is well hydrated. There is, if required, give soda bicarb and make sure that the patient will tolerate contrast. And at the end of the procedure, we use a closure device, which is like a suture on the artery. So the angio-seal is the one which is commonly used, is very simple to use. There is another one called per close. So up to 8F for a 6F or 8F artery, arteriotomy, we can use an angio-seal. But above 8F, we need to use a per close. The peripheral guys, when they do the aortography, for instance, or they do the aortic stents, they use big 24, 6, G, 11G, etc. So there you need to use a per close, which is like a true suture, which is actually a suture on the artery. Access is very important. I think no patient should be taken up without a proper planning. And in that planning, access is very important. So root may be femoral, radial. Radial has a longer learning curve. Femoral we are used to, so it's much easier. So you have short sheaths and long sheaths. This is to puncture in the aorta. So some people use a short sheath, a 6F or 8F, through an 8F, we can use a 6F long sheath. And we may have double access, we may have triple access, we may have quadruple access depending on. So you will have a short sheath, a long sheath, a guide cath, and a micro cath. We have a whole lot of these long sheaths available now. One of my boys, I asked him to see whether we could get a comparison of the sheets, and he just went to ChatGPT, and within 2 minutes we got all this information. So, first time I saw ChatGPT being used for a PowerPoint, but all this breakdown was obtained in 1 minute, literally 2 minutes. So all of them, the long sheets are 6F, but they are all either 88 or 90. I think all of them, 90. They are different companies, and most of them are hydrophilic. They need to be hydrophilic so that other things that we have inside will move smoothly. There will be no friction. If they are not hydrophilic, there will be friction. And the other big difference is that some of them, like the Fubuki, is a single thing, whereas the others have different segments. So some parts are stiff, some parts are less stiff, and the most distal part is very soft. So that's what is seen in Neuron Max and in Cerebase. These are very soft tips which can be taken distally. Earlier I think somebody mentioned that he had taken it to the Peters ICA, so that those can go to the Peters ICA. Then we have guide catheters. Most of the guide catheters that we use are 6 French. Sometimes we use a 5 French, but most of the time they're 6 French. And what we should remember is a 6 French may be ID of 7.0, internal diameter of 7.0, internal diameter of 7.1, and 7.2. And that small 1 millimeter difference may make a big difference between which two devices you can take inside. So always not look only at the 6F, look at the ID. So 5 French usually either it's a 5.6 or a 5.8. So always look at the ID. So these are the typical neuron. So these are different companies and different guide catheters. This is the workhorse which most of us have used for ages. This gives a very good support, but you can't take it above the Peters ICA. Whereas the Sophia, the Neuron, and these can be Nevian. These can be taken right up to the M1 if required. Microcatheters are of two types. One are the flow-directed catheters, which we use for distal aneurysms, and the more stiff catheters, which we use for coils or FDs. So the microcatheter for stent or FD is typically larger, 21 or, as I'll show you later. So some of these microcatheters are pre-shaped. So either they are straight, they are 45, or they are 90 degrees. So advantage of pre-shaped is that you can, for instance, get into the MCA bifurcation, paraclinical aneurysm, or the carotid cave aneurysm. These shaped ones are easier to navigate in. But most of us shape our own catheters. So either you use a kettle or you use a gun to shape the catheter. So most of us shape ourselves, and we have to make the shape according to the anatomy. So you look at the anatomy and you give it that curve. And there's mandrel. This mandrel makes life easy. When we started in the 90s, there were no mandrels. We had to hold the catheter with our finger against the steam, and we used to get scalds. So we use a smaller ID for coil delivery, 017. When you have to use a stent, it is usually a 2.1 or a 2.7. And today we have got very nice guide catheters which can take into the ICA. So that is the advantage of it's easier to deploy, especially stiff things like the FD or the stent. FD is a flow diverter, which is also a kind of stent. So these are all the different microcatheters. And when I started out, we had only 2 or 3 types. SL10 was my favorite. But today, the one which is most commonly used is the Echelon. The Excelsior SL10 was what I was telling you is my favorite. Headway 17, Headway Duo. Headway Duo is a very soft catheter, which can be taken distally into small arteries. There are some catheters which are stable, which stay inside the aneurysm. Some catheters which come in and out, those are unstable. So the echelon is a stable catheter. So especially with a tortuous anatomy, the echelon is a good catheter to use. Microwire. We always advance the catheter over a microwire. And we have again a host of microwires. For me, for many years, I had used a transient, but now, for the last several years, we have been using the Traxis by choice. The Traxis, the tip is 0.12, the rest of the length is 0.14. So the tip is smaller, so therefore more easy to access. But the favorite wire of most people is Synchro. And again, you get them in pre-shaped, or you can shape most of them. So even if they are pre-shaped, you can change the shape later yourself. So these are the packs of the various different wires. Like I told you, the Synchro is the favorite wire. For us, our favorite wire is the... So for distal aneurysms, getting those stiff catheters may not be very easy. Like in this aneurysm, there is no way you can get the SL10 or any of these. So here we need to use the flow-directed catheters. So there we use either a Mirage, a microcatheter is Marathon or a Magic. Through the Magic, you cannot inject onyx. So if you need to inject onyx, you can inject glue and N-butyl-2-cyanoacrylate, bucrylate, but we cannot inject onyx. So for that, we need to use one of these other catheters and one of these. So this is a micro wire. So we have the hybrid wire which comes with, which is to be used with this Bolt Sonic, and the Mirage which goes with the Marathon. But we use preferably when we are doing the Marathon, we use the Traxis, because we find that with the Traxis we can go a long way into smaller arteries rather than the Mirage. So this is the DMSO and Onyx. These are the same from different companies, and this is the glue. So we change the polymerizing time of glue by adding Lipiodol or now Bevidol, which is cheaper. So if we want, when we are injecting into a high flow, for instance fistula within an AVM or an aneurysm, where we don't want distal migration, we use more concentrated glue. Where we want a slow flow thing, we want to occlude the artery and an AVM, then we would use a 20% glue. So that percentage we change by adding Lipiodol. Coils, these were first used in the early 90s. We had used some coils called tungsten coils. I had done maybe for 3 or 4 cases, and to our horror we found that the tungsten, after a year on follow-up, had disappeared. The coils had gone. So later in 1996, we were all trained, Dr. Uday, myself, 5 or 6 of us, Santosh Joseph from Chennai. So we had gone and got trained for the use of GDC in 1996. So after that, we started using GDC. So the first coils were all GDC and made by this company called Target. But eventually, Boston bought over Target, and they were Boston Scientific. But these coils have evolved over the years. For some years, we had coated coils, which were thought to be very good. But eventually it was realized that coated coils are not as good. So we still got some coated coils. But basically there are 3 types of coils. The framing coil, which goes against the wall of the artery, the periphery of the artery, forms the scaffolding into which we try and pack as many coils as we can. That is called the filling coil. And then we use a finishing coil, so that the last 1 or 2 coils are the softest coils. So again, this was done by Dr. Joshi, our colleague. He made a comparative analysis of all the coils which are available in the market. So these are the companies. Luckily for us, we have access to all these coils and all these materials. This is not true in many countries, in Japan particularly. You can't get all these coils. You get only 2 or 3 companies' coils. So we are lucky in that sense that we have all of them. So the analysis is there. Basically, you have to you use whatever you like. So, but all of us, the first coil is always a 3D, and into the 3D then we pack the other coils, the helical coils. We have assists for coiling. If the neck is very wide, the coil will prolapse into the parent artery. So to prevent that from happening, we use assists. So this can be a balloon, it can be a stent, it can be a flow diverter. So balloons are of 2 types, they are compliant or the super compliant. And there are single lumen and double lumen catheters, balloon catheters. So they are both from the same company, but one is meant for arteries like the basilar, for the ICA, for sidewall aneurysms. And the other, the hyperglide, is meant for peripheral. So the balloon bulges because it's a hyper compliant balloon, it bulges into the aneurysm. So for instance, this is a typical hyperglide balloon. So you get the coil in, inflate the artery, deflate the balloon, make sure that the coil stays inside, detach, and so on until you got it all. So this is for the less compliant balloon. And this is the hyper-compliant balloon where you can see it is bulging into the branch. It can bulge into the aneurysm also. So transform is another balloon which is a single lumen balloon. The difference is in a single lumen balloon, the wire has to be advanced a little distally for the balloon to inflate. In a double lumen balloon, it is much easier because the wire is in a different channel and the contrast or what we use to inflate is in a different channel. So a double lumen balloon, again, we have 3 of these, all 3 are available and all 3 are used extensively. Then we can come to stents. So we have these stents are of 2 types, closed cell design and open cell design. Dr. Mukesh, when he had talked about carotid stent also, he had said we have these. Similarly, we have the open cell design and some of them are laser cut and some of them are braided. Solitaire is a stent which is also used for thrombectomy, but we first had used it for aneurysms. So it was a non-detachable, it was a detachable, now it is non-detachable, what is used for stroke. So again, have open and hybrid and closed cell. So the enterprise is a closed cell. And some again are braided and some are nitinol. So this is, for instance, the barrel stent which bulges. Similarly, the Atlas also bulges into the aneurysm. The Vasco is the microcatheter through which you deliver the Leo. The Leo was our favorite for many years, but now we have all of these. So the advantage is that these small balloons, small stents, go through small catheters, the 017, the coiling catheters. Most of the others go through a larger catheter, 21 or 27. Then we come to flow diverters. Again, we have all these companies available to us in India, and most of them go through a 27, but now the new ones go through a 21. The 27 is a bigger catheter, it's more stiff, more difficult to take distally. The 21s are softer, easier to navigate. They are all, the technique of deploying is different for all of them, but I think you have to learn which one is better. And somebody else is going to talk on them, so I won't waste time on stents. The Fred from Microvention is a true double-layered stent, FD. All the others are single-layered. Some have 24 wires, some have 48 wires, some have 64 wires. Each is different. And the newest kid on the block is the intrasaccular devices. Again, there are multiple of them: contour, web, Nextend, Nautilus, and Dr. Dangi, I think, is going to, or Dr. Tufela is going to talk about them. So we have the web, we have the contour, Luna, Artis, Medina, and Galaxy Seal. Galaxy Seal is the newer one which is being developed and being tried out. So again, I won't waste time on this because one of them will cover on it. So in conclusion, know your hardware. Before you start any treatment of aneurysm, you have to plan. And I keep saying every time, there is no such thing as routine in neurointervention. No case is routine. Even a diagnostic angiogram is not routine. You have to plan each case, keep prepared for any eventuality, and if there is, say, a lost coil, a broken coil, a misplaced stent, you should be able to pull it out. So you should have the wherewithal to pull it out. And to do that, you must have a solitaire, because we think today that solitaire is the best device to pull out any broken catheters, any stretched catheters, any stent which has got misdeployed. So you must have a solitaire, even though you're not going to use a solitaire, you must always have it. And so you must plan for any complication. And when you are planning to use any stent, FD, flow diverter or stent, the antiplatelet therapy has to be carefully planned. Thank you for your attention. Thank you.
Thank you very much once again, sir. Now I take this privilege to invite another lecturer.
अच्छा वो भी होगा.
Arvind, thank you. Atulab, thank you. As if we require an excuse to go to beautiful Udaipur. Thank you. So this is a critic, for bifurcation aneurysms. So the way that I see about the people who are, how do I go forward and backward? Okay, thanks. Maybe 20 of us who do higher neurointervention, and for the rest, probably this is too technical. So just pardon me if it gets too technical. I'll try to finish it in the time given. In case I'm overboard, then we can stop when the time is up. So this is about contemporary. At every given time when we started this practice, 30 years ago and sir before me, we were contemporary. So what we were doing in the 90s was contemporary for the 90s. Similarly, so forth. We are now in 2025. After going through the journey, now we can say that what is contemporary now. The most important thing is not to forget the experience that we have had over the decades. Bifurcation aneurysms are very common. Why do they develop? It's because of the hemodynamic stress. Why do they bleed? Because of the hemodynamic stress. Our job is to secure the aneurysm. And so coils are mainstay. They have been for the last 3 decades. Even today, they are equally important in your armamentum to have coils to secure the aneurysm. The challenges with bifurcation aneurysms, why today also it's a topic to be discussed, is because the neck can be wide, so it cannot be simply treated with coils with a narrow neck. And more importantly, the base branches, they can be incorporated in the neck or in the fundus of the aneurysm even. Sometimes the access can be tortuous, but that's the case with anything that we do because it's all endovascular. So these are various cases. I may show some of them in this talk. Bifurcation aneurysms, the commonest are the MCA and the ACOM and the basilar top, also ICA top. Sometimes when there is fetal PCA, even PCOM aneurysms becomes or behaves like a bifurcation aneurysm. As I said, tortuosity is always a problem regardless of how advanced our material is today. But probably if through the tortuosity, if you have to treat, today is the best time because we have absolutely fantastic access and distal access catheters. This is what we use in treating aneurysms, coils of course, and balloon for a long time, stent for a long time, FD for last 15 years maybe, and intrasaccular devices for last 7 or 8 years. And I'll try and show you each of those cases and what are the advantages, possible disadvantages, if any. This is the talk. Ruptured aneurysms do not use something which is going to stay in the blood vessel because that will require antiplatelets. Ruptured aneurysms may require an EVD, may require a shunt, may require an evacuation of the clot. That means surgery. So you'll have to stop antiplatelet, so your stent can get thrombosed. So that's the simple talk is ruptured aneurysms, balloon assistance, coils or whatever intrasaccular device, do not try and leave something behind which is going to require antiplatelet. Sir has already said that there are two types of balloons. The dual lumen, the DL balloon is more secure. Also, in case the stent is required, then the stent can navigate through the lumen of the second lumen of the balloon. Simple cases first, it looks that how am I going to control the superior division here? And so that's why when we have the balloon in place, it tremendously helps. And where is the balloon? The balloon is in inferior division. It's not in superior division. But this is the balloon which can get inflated in an irregular fashion, which covers the origin of the superior division. And so once you have the balloon, your job is done. Because then you will put two more coils and you will get the aneurysm completely occluded like this, with the superior division fully open and patent. What if the superior division, so-called, is a subcortical branch, which comes from the base of the aneurysm? Many people today would say that I would just put a flow diverter there, and they're not wrong. But we are talking about ruptured aneurysms. We are talking about primarily trying and avoiding putting in a stent or flow diverter inside the blood vessel. So a balloon can do this job very well. So this was the roadmap of the balloon in place at the base of the aneurysm, also protecting the origin of the branch, which now looks like it may not have been incorporated inside the neck, but it was, and it was saved by the balloon in place. Follow-up, of course, is fantastic. It looks as though the aneurysm never existed, and this is just coils and balloons. So coils are also not, it's not a hopeless device to use coils today, because aneurysms may recanalize. They do, but many times they don't if you do a good job right in the first place. Similar kind of job can be done in other situations with a simple balloon and coils. Once you pack them well, they stay packed and the aneurysms remains occluded. Some aneurysms look to be more complicated or complex than they actually are. This is like 1, 2, 3, 4 branches coming from the MCA bifurcation or trifurcation. But if you see carefully, the neck is not that impossible. So just one balloon inside the main stem from M1 to the biggest branch is going to do the job. So it looks complex, but actually it is very easy. Once your balloon is there, once you have defined the neck, then it's just a question of how many coils you want to put. This was done many years ago. Again, it looked impossible. How are we going to save all those branches which come, especially the one which comes from the dome of the aneurysm? So we did the same thing. When things are complex, try to make them simpler so that maybe they are not all that complex. So this is what we did, and all the branches are saved except the one which was coming from the dome. But if you see distally, all those branches are collateralized very, very well, and all of them are filling antegrade well. And The long-term result of that aneurysm was fantastic. What about this? Is this coming from the neck? It's actually coming from the fundus. How are you going to support this? With a single balloon which goes from here to here, and then you coil it, and of course the coil is going to occlude this artery. Looks small, but goes to very important structures in the brain, and that's why sometimes you will have to use, this is the angio of the same patient, you'll have to use 2 balloons. Once you are used to the idea of putting multiple devices inside your guiding catheter, you just have to take a guiding catheter or guiding sheath which can have 3 and sometimes even 4 different catheters going through it. And this was 3 catheters, of course, 2 balloons and a catheter for the coiling. So once you do it, it is not all that difficult, all that complex. It's just that you have to overcome your inertia in the mind to use multiple devices inside one. And so after controlling both the branches, this is the result that we have. Another one of the same. We were not sure just one balloon is going to control this. So we had to put 2 balloons, and it is not at all difficult. And MCA, which is reasonably 2 to 2.25 millimeter in size, can easily take 3 catheters. Same goes with the ACA. The follow-up result of the same, with both the branches are fully open and patent. So this is about the balloons. It's time tested because we have been using coils from the 90s, we have been using balloons from the 90s. It's just a question of getting used to the balloon. I find that many people are hesitant to use the balloon because in the initial part of their careers, they have not used the balloon. So become a balloon boy or a balloon girl. Once you start to use it in every single case, it becomes part of your alma mater that you cannot do without. Most times you will put 2 coils more with a balloon, and sometimes 1 out of those 20 cases which ruptures during your coiling, during your procedure, balloon is absolutely going to save your backside and the patient's life. Sometimes with the balloon, as I said, DL balloon is effective in putting the stent in. This was one such case. The balloon was placed like this, good coiling, balloon inflation, good coiling, and then through the same balloon, the stent was deployed. This you can do if it's not an acutely ruptured aneurysm and you want a longer durable result, which is possible once the stent is in place. Some stent cases which are directly, this is a distal aneurysm, and I was not at all sure whether I would be able to save the branches coming from the base, even though this is a M2 aneurysm, it's not a trifurcation aneurysm. So it's better to cover the base with a rubber stent and then coil it. The result is always more durable if the stent is inside. Similarly here, this was not an acutely ruptured aneurysm, so stent in the superior division. There are many stents which Sir talked about in his previous talk, and you can have your own choose, own pick, whichever is your favorite, and then you use this. As with 2 balloons, sometimes you have to use 2 stents in different configurations. So in this, I was not sure whether the 1 stent is going to do the job. So sometimes you have to use 2 stents, and the combination is up to you. The permutations that you can use, open cell, braided stents, 2 braided, 2 open, it's up to you. It is not all that complex to use multiple devices, as I said before. This was an aneurysm which is more difficult than most of the aneurysms we have showed you so far. And so here you have to see that which of those branches is easier to get through. And so the more difficult branch, you would put the stent in first, and then through that stent you would have to go through the other artery. And then once you're inside, you can go ahead and coil the aneurysm completely with 2 stents. It's like a Y stent and coils. This can be done with 2 catheters or 3 catheters. This can be done with 1 catheter if you are using an open cell design. So just 1 catheter for one side, the same catheter to the other, and then that catheter through both the Y stent can go into the aneurysm, and then you can do this. So it's not always that you require 3 and 4. This is more difficult to do because both are braided stents. The access through the first braided stent is not difficult, but sometimes you do require an angioplasty of the strut because the strut is small, it's not an open cell design. So this is a very, very robust one. You can do this with Leo baby, or you can do with the Evo, but be prepared that sometimes you may require angioplasty of the strut, either before or later. So as I said, it is more permanent than the balloons or the coils. And ideally, if the patient is not acutely ruptured, then you can put the patient safely on antiplatelet and gives you good results. So before we go to the flow diverters, I will talk a little about intrasaccular, because this is supposedly a critic. What I basically am showing you that everything works. If you have reasonably good experience, reasonably good training, everything works. You just pick your choice and it is going to work for you. So these are small little aneurysms. As many people say that if it looks like a web, then it's a webbable aneurysm. Web was the first intrasaccular device. We have used a lot of contour here in India, Nitin is here. And of course, the third one is not yet available, the arteries. So whatever that we have, we are picky and choosy because we started with coils, we believe in coils, and with coils and balloon coils and stents, we believe in that more than intrasaccular. But sometimes, if the neck is really wide, you can really do this, like in 20 minutes the case is done. Wide neck aneurysms, we don't really know that how, again, 2 stents, 2 balloons, it's tough. Rather than that, what looks like a nice rounded shape, an intrasaccular device is going to get through, and you can see it very well. And once you do that, a wide neck aneurysm with incorporation of both branches can be tackled very, very easily and very, very fast. So this is the follow-up angio. You don't even know where was the aneurysm. You have to look for it. Only when you know that where the web was, that's where the aneurysm was. One more, I'll go fast on this because it basically means the same thing. Follow-up angio, where is the aneurysm? As good as new, the arteries are pristine. This was with contour, I think. So same thing, very difficult to control this without a stent, but a contour device with a good angle that is absolutely vital when you do this, that you need to have a good projection, a good roadmap, and a good machine to see those devices. So your actual job is faster, but the before and after and taking multiple runs and vaso CTs, etc., that's what takes time. So the procedure time is not shortened, but the actual time that you spend engaging the aneurysm is very short. And so if you have a good machine, then these devices are really not so difficult. This is all good results. I'm going to show you one case with, this was easy, ruptured aneurysm. A web was used, unfortunately, a very defensive web sizing. So this aneurysm is small aneurysm. Patient is well, but the aneurysm is still filling. Now, who is to tell that the web is there, but the aneurysm is not going to rupture again? So you will have the recanalized or recurrent aneurysms, which require a stent at the base and, of course, coils. And so we treated that. Last part of the talk is for the FD. And so FD is definitely a genuine device to be used if the aneurysm involves a branch. So rather than engaging the branch or engaging the aneurysm with coils, we just put the FD. This is follow-up. The aneurysm is gone, the branch is gone. So what happened? I already said that it's a subcortical arteries are dangerous, but if it goes slowly, then it opens. I'm sorry I could not play that video. So another one, a small little one. What are you going to put here? Intrasaccular device, coils, stent. It's best to use a flow diverter. It's easy to do and you're out in 15 minutes without any problem here. And once you put over here, once you put a flow diverter, then of course you will have stagnation of the aneurysm, which happens almost immediately. Some aneurysms are tricky. There is no way of treating this aneurysm, so we thought it's a ruptured aneurysm. So in spite of everything that I've talked about, we still decided to use a dissecting fusiform P1 aneurysm. So you cannot occlude this, so we decided to use the flow diverter coming in from P2 to basilar. That part of it, not so difficult. It looks beautiful, isn't it? It's already healed. Not so. Because if you occlude the branch acutely, then these branches are going to cause infarctions. This is what happened. And so we opened it eventually with whatever that we used, but if the branch goes acutely, then infarcts happen. Patient had a deficit from which he took a long time to recover. So here, biggish occipital and scar territory infarction. Follow-up angio, okay, come on, this artery was gone, was it? It was. The problem was that this artery went acutely. If it goes subacute or chronic, absolutely no problem, because the collaterals develop very well. Another complication, after which I'm going to stop this talk. Here, difficult. What are you going to use? 2 balloons, 2 stents, 1, 2, 3 arteries? So, flow diverter. Whenever in trouble, go to flow diverter. Flow diverter, wow, the aneurysm is gone. What else is gone? The 2 arteries are gone. And what was a difficult aneurysm turned into a permanent deficit. It's a large MCA infarction. This is the case. If there is time, I'll show, otherwise I'm done. Just for the technicality, because I've been showing all the devices. When you're faced with aneurysms like these, really genuinely a large aneurysm at the bifurcation, trifurcation, then it is difficult just to use one device or one flow diverter or stent and coils to get away. So sometimes it is difficult. The aneurysm, I don't think that the videos are playing, but you see that this requires a flow diverter. At the same time, here, rupture, but not acutely ruptured, subacute, and it's like a sacculo-fusiform aneurysm, and with many branches, the superior and inferior divisions coming from the aneurysm. So sometimes you have to take a call about doing something which is not only reconstruction. This is a deconstructive therapy. So we looked at the angio and we thought that one of those arteries can be electively sacrificed. So we got through the aneurysm, we went into the temporal branch, did a nice test occlusion with the balloon inside the temporal artery. I'm so sorry, this is not going to fill. You have to believe me when I say that there was good collaterals coming in from the PCA to the MCA. And then we occluded it, sacrificed it on table intentionally. So once you do that, then it's very simple. A little loose coil inside the aneurysm and put a flow diverter from the superior division right up to wherever it comes. These are the branch occlusion coils and loose coil packing of the aneurysm. And we finished it. When on follow-up, when we did, this is how we finished it. Aneurysm still filling. One artery is gone, it's filling through the PCA. And the flow diverter is there. It is not doing the job acutely. But as we follow up this patient, it was perfect. The mass effect was gone, the aneurysm was gone, the PCA was taking care of the temporal artery, and the whole thing has remodeled itself. So sometimes it is not only about saving and reconstruction, sometimes it is about using what you have learned from years together and combine all the techniques. So in critic, what I have to say, simple. Do not try and leave something, a stent or a flow diverter, in acutely ruptured aneurysms. You have coils, you have balloon, or you have intrasaccular devices. But intrasaccular devices, sometimes they cause pinching of one of the branches, which may require a stent, so it is counterproductive. So first overwhelming choice for ruptured aneurysms is still coils with whatever that you want to protect them with. And for subacute or chronic, which you can load the patient with antiplatelet, then you have wonderful flow diverters, intrasaccular devices, and stents available. As I said, if you have good experience with everything, then almost anything goes. Good result is the key in bifurcation aneurysms. Thank you.
So, you usually say that coiling still stays.
Coiling stays. And
Still of our treatment.
at least till the time that some of us are going to retire, coiling is going to be there.
Thank you very much, sir. Now I request the next speaker, Dr. Tufel. Me and Atula are deeply thankful to you. You have taken a long flight from Toronto to be here this morning and you're still in steps.
My voice is going.
That will take it.
Sorry. Okay. Thank you. I have to get a timer on, which is, just let me know when I'm 2 minutes before, okay? Uday has already covered technical side of things. Everything is still the same in terms of which aneurysm you treat. You still, coiling is the first line of treatment, I think. But then you have stents, you got flow diverters, and today we can treat these aneurysms in so many multiple ways. There is no one way to skin the cat. There are multiple ways, and it all depends on your experience. So I've been asked to talk on sidewall aneurysms. I didn't know there was a definition of sidewall aneurysm. Still, I was looking at and Hans has come up with a paper. So it is what Ravi Ramakanthan used to tell us, that you can publish anything. If it doesn't go in the journal, it will definitely go in some newspaper. So you can see it's very easy to get a paper in. What I'm going to do today in the next 15 minutes is to talk about sidewall aneurysms. And when you talk about managing sidewall aneurysms, you're looking at the location, you're looking at the pathology. Is it a saccular aneurysm? Is it a dissecting aneurysm? Is it a partially thrombosed aneurysm? And then hopefully if we have time, I will show you a complex case, but that depends on the time. So let's start with some basics, okay? This is a PCOM aneurysm, standard bread and butter business. This is a 56-year-old lady presented with headache and third nerve, and the CTA showed a subarachnoid hemorrhage. As you can see here, this is the internal carotid artery with a PCOM aneurysm. There is a nice PCOM coming in. There are multiple ways you can treat this, but today most of the people who are experienced in this, they're going to do a nice 3D. You can look at this here. You can convince people how you want to treat it, but this aneurysm can be coiled, okay? You get a nice balloon sitting in. Yes, there is a dominant PCOM coming in, but you can coil this aneurysm, and there you go. We can get a nice coil in. There's a little bit of a neck residue there. We know that this neck residues can stay, but again, if it does come in problem, we can always retreat it. But as you can see, this aneurysm has been coiled and was okay. Let's move on. Now, things are changing. You can, like I said, you can treat aneurysms in different way. This is you can see subarachnoid hemorrhage from a PCOM aneurysm again. But here what you can see again, the PCOM aneurysm is there. You got a bit of a large nipple there. There's a very nice base. It's coming across internal carotid artery. Can you coil this? Yes. Can you stent it? I would not. Okay, because it's a ruptured aneurysm. So technically what you want to do is either you coil it, and this is definitely, I think one of the speakers talked about clipping. Grade 1 subarach PCOM aneurysms are still a very good surgical target. Surgeons can get a good result, but again in UK, 99% of acute aneurysms are coiled. So here we decided, well, we could coil it, but you can see we have put an arteries, and you were talking that arteries is coming. It's again a very nice device. Sizing can be very tricky, but now the technology, and it makes, you can do this in 5 minutes, and time is not necessarily the most important thing, but it makes a difference. You can easily put a device in. It's easier to size, it's easier to place than the web. So technically it's making a life a lot more easier than what we were doing with intrasaccular device. But long-term data is still not there. What happened? And here you can see significant stasis with the PCOM aneurysm there. And you can see the aneurysm looks very good. And look at the shape or the angle. It's very difficult to get a web sitting in, although you can get a 17 web. But RTs makes it a lot easier to drop the device into the aneurysm. And here you can see we've done that. When you move to another sidewall aneurysm like carotid ophthalmic, this is something I think is once upon a time, people would do different ways. I have some surgeons who are desperate to clip aneurysms. I have literally told them if they ever clip a carotid ophthalmic aneurysm, in UK there is a lot of regulation. We could take them to General Medical Council and finish them off, because I think this is one place we do it very well. Carotid ophthalmic aneurysms, the results, and we have recently published 120 aneurysms over 6-7 years. We have 100% occlusion, less than 1% complication. and had one death recently. This is a carotid ophthalmic aneurysm. As you can see, it's very important sometimes to see where the ophthalmic artery is arising. Is it arising from the aneurysm? Is it arising from the artery? Because sometimes they can have some implication in visual symptoms, but most of the time you will get away with it. You can coil this aneurysm. Sometimes you don't need to coil the aneurysm, and you can just drop a flow diverter across, and usually the occlusion rates are very good. Pretty much in over 5 years, I've got 100% complete occlusion in carotid ophthalmic aneurysm. I have never retreated standard saccular carotid ophthalmic. I'm not talking about dissections or other ones. This is a 6-month follow-up, and you can see a perfect result with the artery reconstructed, and you can see the aneurysm is gone. Look at a complex case. This is a lady who presented with headaches. And I've never met a family. I mean, you guys are very used to complex families, right? Because you have 10 people ringing you, one patient, every patient's family has some doctor, and they'll call you, correct? That's the practice. We don't have that. We have to try and call patient's family to see if they really want to come in or not. Sometimes they don't even come in. You know, sometimes we tell them, you want to come in, it's very difficult, but people don't come. I've never met her uncle who was a GP, and he could do a brain surgery. He was trying to tell me how to do brain surgery. It was so difficult. Okay, Asian family, big aneurysm, and you can see this, very complicated aneurysm. And again, you know, what would you do? Well, you could do a test occlusion, and that could be the best option. I decided not to do test occlusion because her uncle just would not want a test occlusion because he knew better than me. So I thought, okay, well, we will not do a test occlusion. We decided to treat this with a flow diverter, but then I thought I'll coil it. So I was using a Comaneci device here. And you can see I'm around inside the aneurysm, and then I was trying to coil this. As I was coiling this Comaneci, the coil got stuck in the Comaneci, and then I was in deep trouble, okay? It doesn't happen very often. I've used it many times. This is the second time I had a coil stuck in the Comaneci, and the coil was stuck, and now I couldn't pull in and out. I had no choice eventually to just occlude the artery, but when it was in here, I saw that there was a good cross flow, and she did pretty well, and I just closed the artery and the aneurysm. But what happens? Look at the follow-up. If you look at the follow-up here, this aneurysm has got flow now coming from the PCOM. So I'm going to flow divert this. So you got to be very careful when you treat these large aneurysms. Even if you occlude them, you got to follow them up. Because I have cases where I have completely occluded it, but it has still ended up finding its flow. So I think 5 or 10 year follow-up is very important in these aneurysms. Moving on to a different pathology like a blister aneurysms. When I do blister aneurysms, I have a completely different way when I look at them. Because the disease is in the wall, you need to be very careful how you treat them. If I can, here is an MCA aneurysm, and you can see a blister in a 45-year-old grade 1. Sorry. And here you can see the aim is to drop off, I mean, like Uday was talking about, this is a disease of the wall, so you have to treat the wall. But the problem is that a blister can bleed. If you just put a flow diverter on its own, you may get away with it, but you may not get away with it. I'm going to show you 2 cases. One I got away, one I did not get away. And here you can see, I put a stent here, and I put a small coil. I always put a coil. But you need expertise, you need experience to put a coil in a blister aneurysm. And here you can see this aneurysm has, this vessel has remodeled, and this patient has done pretty well. Look at another case. This is again a 40-year-old lady with a subarachnoid hemorrhage, as you can see, and with a small blister aneurysm. What happened here? This was at 7 o'clock in the evening. I had the most shittest radiographer that I could ever get, okay? And I needed to go to the airport as well. So I decided that I will only put a flow diverter there. And I put one flow diverter, if the video works. Probably not. But anyway, so I put one flow diverter there, and the videos are not working very well. So you can see one flow diverter was placed across the aneurysm. Okay. So the stent is put. I was worried. I had left the country and I was worried, so I made sure that somebody does an angiogram. This lady had an angiogram on Friday and it was negative, okay? Not on Saturday, she rebled. So on Friday, she was okay, GCS 15, angio was nothing. Saturday, she rebled. And you can see that the aneurysm has got bigger, and then we had to go back, and then we had to put another flow diverter inside, because then you don't have a choice. And she did okay, luckily. So a very important lesson, if you can't put coils, please think about putting 2 flow diverters. I've had enough patients I've seen where you put 1 stent and it may not work. Now cost may be a problem here, but it's not a problem for us, so I always put 2. So here in a patient, standard here, again you can see blister aneurysm. We are not going to be able to put a coil here. I wouldn't even try putting a coil here, but I will put 2 flow diverters here. So you can see there was a pipeline stent put in. This is very recent case, and then there was a derivative 2 heel put in. I like the heel, and in these technologies they quite are useful, and you can see the 3D. You can see that there is a good occlusion there. Let's move to a different location, posterior circulation. If you look at saccular aneurysm in the posterior circulation, here is a standard saccular aneurysm. What do? You are going to need a flow diverter here, but I would like, most of the times, I will put some coils here and then put a flow diverter there, and I have occluded the aneurysm. You can make things a little bit complicated if you fancy it. Here is a patient with a stroke, and you can see he has got a complex pica aneurysm. The pica is just coming off from the base. It's a dominant pica, so you don't want to lose it. What can you do? You can do multiple things. Here, what have I done? I have put a neck stent here that protects the pica because it's coming off here. So you put a device here, you coil the aneurysm, and then you drop a flow diverter here. Because I know intrasaccular device on its own may not work here. So you need to, so you have to think like a surgeon sometimes. I know, because they'll clip aneurysm and they'll think it's gone, but they don't do angiogram, so they never know, okay? They, you know, if you look at ISAT data now, and ISAT 2 data, there is a recurrence with clippings too, and we know that. These aneurysms are nasty, so they need some strong treatment. And here you can see, I've dropped a flow diverter, you can see the neck stent, and you can see the coils. And then the end result is looking like this. I've got a follow-up on this, it still is occluded. But when you have a dissecting aneurysm like this one, here you can see the posterior circulation aneurysm, again the PCA, it's a nasty dissection. What can you do? You could just close this artery, because in this location, there is always a lot of collaterals. So yes, you can close this, but again, you may not want to for various reasons. So here you have decided to put a stent here, and you can see I've put a catheter in there, and then I've dropped a flow diverter across, and then I can just put some coils there and close the aneurysm. So you have very multiple ways, but you could have just coiled it, I think, and that could have probably also worked in this location. And here you can see what happens if you have a different location. Now this is something I think one of the speakers was talking about. So the first speaker are talking about SC aneurysm. So this is a ruptured SC aneurysm, small SC aneurysm. You could just coil this. As you can see, we have just coiled the aneurysm, and it's not technically challenging. I mean, you know, no aneurysm is simple, but this can be done reasonably simply, putting some coils. But what happens if it gets a bit more complex? You got another SC aneurysm on the other side now. It's a bit wide neck. It's got a SCA coming off there. So what do? As you can see here, this SCA needs to be protected. So how do we do that? Well, you could just put coils and flow divert. You could just put a flow diverter, or you could put an intrasaccular device there where you can allow it to protect the SCA, which is coming off from the bottom. So you put a device sitting there, it protects your SCA. You can coil this now, and then if you fancy it, you can put a stent, or you could just leave it. There we did not put in. What about if it gets more complex? And if you look at the basilar termination here, this is a nasty aneurysm, and there is a branch coming off there, and there is a branch, and I think Anil asked me, this is Anil's case from Singapore. I said, what, and this was a VIP patient. So he said, well, what do you want me to do? I said, well, the only thing you can do in a VIP patient is just put a flow diverter there and then put some coils in this corner. And I think that's what he did. He put some coils and then he put a flow diverter across. And he has a follow-up now. You can see, and Uday showed very nicely some examples how the artery will remodel. And it's very important to understand the flow diversion has changed how we treat these aneurysms. And this has been pretty good. And that's and that's worked. What happened? How much time? 2 minutes? Okay. Yeah, I'm nearly finished. So if you look at this one, what happens if it's another aneurysm? Now this is a 14-year-old boy and he's got a wide neck sidewall aneurysm. And what are you going to do? Okay, well, you could coil this, but coiling was not going to be just straight. So one of my colleagues, and I wasn't sure whether this will work, I would have preferred to put some coils, but he didn't put the coils, he just put a flow diverter in. And to be honest, you know, you never know, there is good stasis, but you can see good stasis, but it took nearly 2 years for this aneurysm to go, and you can see that, and the aneurysm did go, but it took 2 years to go, and that's a long time. Let's move on, last final case. This is a complex aneurysm. We did about a year or 1.5 years back. Technology is improving, and sometimes I think we make choices. Here you can see there was a very complex wide neck MC aneurysm. We could have just flow diverted it. But we decided not to flow divert this because I think this lady had some trouble with antiplatelets, but we eventually ended up doing it. Anyway, here you can see she had a horrible access. It took ages to get up, but once we got in, we then decided, you can see it's a wide neck, quite a fusiform type of aneurysm. We managed to get, and we were thinking, well, we could have put a stent in. I did not put a stent. I put a neck stent instead to get protection. I put some coils there, and then I decided not to put standard coils, but put Trenza. Okay, now these are supposed to be a bit more stiffer, but don't have long-term follow-up. But here I've got a 1-year follow-up and a 1 or 18 months follow-up, and it has remained occluded, as you can see, because I did not want to put antiplatelets on her because she had some trouble because of the antiplatelets. And anyway, that's, thank you very much. I'll stop there. Thank you.
Thank you, sir. Now we will continue next session also. So, I will continue the thinking answer from side analysis, effective use of the analysis. Yes, good.
So good afternoon. I think so parallelly lunch is going on, so I won't be standing between your lunch and this thing. At the outset, I would like to thank Atulab and our friend Dr. Nanda here and all of you for being present here, of course, during the lunch session. The topic says giant aneurysm and wide intrasaccular device. Actually, it should be wide neck bifurcation aneurysm and intrasaccular devices. So basically, I just wanted to make very things clear from the beginning that I will be just covering wide neck bifurcation aneurysms and intrasaccular devices for how well we can manage. So advances and practical insights. So very important to understand the anatomy as well as the angioarchitecture. If you really want to have good outcomes and long-term outcomes, basics have to be very clear. So I always teach my fellows or students that understanding the anatomy and the principles of either it is clipping or endovascular means one has to study the angioarchitecture, have the basics concept clear, and then only you can have good outcomes. So you can see here wide neck bifurcation aneurysms, neck more than 4 mm or the neck dome to neck ratio has to be creating an unfavorable geometry for conventional coiling technique. Lot has been discussed before by all the stalwarts before me, and it's very important to understand everybody's concepts, and they were stressing that each device is good, but where to use it in a better way to have good outcomes is what we have to understand and experience. So these bifurcation wide neck aneurysms can be at the basilar top, MCA bifurcation, ICA top, then A1, A2 junction. So these are the commonest types where we are talking about intrasaccular devices, and the indications are. So complex architecture is very important. Dr. Uday just mentioned there can be branches from the neck or the dome of the aneurysm, which we have to always be careful about and decide the strategies. Now, what happens when we have a wide neck bifurcation aneurysm? The earlier strategy is coils, very good initially for ruptured aneurysm with balloon assisted or stent assisted, but you can see high recurrences rate. I will come to that, why these follow-up I said 2 has so much of recurrences, and then the technical complexity, which we cannot have such situations whenever we are dealing or trying to have balloon assisted or simple coiling in wide neck. So treatment, it's very, very important, surgical option or endovascular options. Microsurgical clipping. So where I was trained in Japan for clipping long time ago, we used to do clipping earlier. Then these wide neck bifurcation aneurysms were clipped non-conventionally by one of the stalwart neurosurgeon, Professor Sano, by vertical clips. Usually we clip parallel to the parent artery, but he used to clip perpendicular and reconstruct the artery at the neck so that there is no residual neck. He used to take 7-8 clips per MCA bifurcation aneurysm and see to it that no branch is occluded, but only the aneurysm is secluded from the flow. So reserved for complex bypass procedures where we have to sacrifice the vessels and we have no other endovascular means, maybe with various reasons, there we can still think of bypass procedures. Lot has been discussed. I won't go into details of balloon assisted. I will just come back to my talk, intrasaccular device concepts. So it's very, very important when we used to clip, what our understanding philosophy is very carefully, just listen to this. This is very, very important, and you will also learn from here why it is important to, why we get recurrences, and this can help explain. So when we were at Sano's training, he used to tell us that the aneurysm originates from the intima, and there are 3 layers as we all know, but the third innermost layer is the origin of the aneurysm. And what we usually treat or see on a 2D or a 3D is we see at the adventitia. So we try to plan a strategy wherein we cover and think that this is the location up to which we can occlude the aneurysm or cover the aneurysm with coils or something, and leave this part which is a potential for regrowth. That's the concept one has to understand in any aneurysms, and especially in wide neck bifurcation aneurysms, because the aneurysm originates from the intima, and that has to be taken care of to have good long-term cures. So when we talk of intrasaccular devices, it has to be pulled back, perfectly adhered to the neck from within and anchored very well, so that long term they should not displace and there should be no inflow into the aneurysm sac, and only the branches are preserved well. So how does it work? They are flow disruptors, there is a stasis induction and endothelial healing. So if we go back to this slide, so there is stasis in the aneurysm, there is a flow disruption, formation of thrombus, and this inside up to the intima, the device whatever you are using, if you can get it down here, it will help to form a good endothelial scaffold and formation of a new artery there, excluding the aneurysm from the circulation. So that's very, very important, conceptualizing and understanding. We should not blame the device for not having used it as a philosophy, what is it made for. So that's very, very important. This is a very diagrammatic, animation. Can you just run this video? Is it playing? Okay. Sorry, it's not just playing the video. Okay. So what I wanted to show here is, this is the animation representation of a wide neck bifurcation aneurysm. When you put a intracircular device, this is for contour. The contour is like a saucer shape. When we deploy first, before detachment, we have to bring that device and the marker should be well within the lumen. Don't worry about thrombosis or having a thrombus there at the neck, because this is the device which needs to be anchored well within the contour. The name itself says that it takes the shape from within into the aneurysm at the neck, and we have to bring the marker down within the lumen so that there is no movement of the device inside, as well as it anchors thoroughly, so helps in formation of a good scaffold and taking care of exclusion of the aneurysm from circulation. We usually load these patients for want of simple thing. We are bringing the device down into the parent vessel. If there is a thrombosis or it slips, we may have planned for flow diverter or other stent assisted coiling in these patients. So this advantages is that these antiplatelet is used only for in case as a standby therapy if another device is required into the lumen. So there is an enhanced safety profile, branch vessel preservation. I will come to this, why it is important, branch vessel preservation, and it helps in endoluminal devices. So this was the publication we made in Neurology India. Trust me, this is not an Indian journal as such. It is well accepted all over the globe, and it has a very good important impact factor. So we published about 18 cases in initial experience of our contour when we started in 2019, and these were all ruptured aneurysms, and we had follow-up, and now we are going to publish our follow-up data very soon with almost 85 to 86% success rate in our follow-up series. So this was our data. You can see MCA, ACOM, ICA bifurcation, basilar top, and DACA. So antiplatelet protocol we loaded. Now we have changed that we load on table. Earlier we used to do 2 hours prior to the procedure, and this was the sizing, which is very easy as against contour or other devices, not very complicated, and you can see that this is the way we size the device. And this was the literature which has been published, and you can see contour has fared well even today. And the other intracircular devices, just for us to know what are the other options, Medina, but all these are not yet well appreciated or accepted, and they just fell out of the use somehow. We don't know why. So this was a spherical Luna device, not very well, never became popular, but these are what just for namesake I'm mentioning. Then comes Artesia. Now it is being used very widely all over the globe, and they have said that 6 months follow-up, 80% occlusion rate. So it's almost matching to web and the contour, but definitely it needs a longer follow-ups and usage. Then this is another one, Natulisa intrasaccular system, but not yet become popular, but these are one of few options. Then comes the next stent, which already Tufel has described, and then comes the web device. We initially used before contour launch. This was the only thing which was available for intrasaccular in India, and we have done many cases. But for me, there are some disadvantages. This is also a very good device in select cases, but the disadvantages, as you can see, because of the fixed shape, completely like a cylinder, when we deploy into a sac of the aneurysm, the sac is never very definitive shape like this. Inside, if you imagine, it can be irregular, and that's why there can be some flow from the side of this device and it can recanalize later. So success rate has gone up to 54% with the web IT trial. So it's not very what we call successful or advantageous in most of the patients. That's why we came with our better option, which definitely has even today time tested with a success rate of follow-up studies of about 5 years now. Last year somebody has published a follow-up of intrasaccular devices, 4 years follow-up, which shows web is around 80 to 84%, while contour is about 86%. So they are paralleling as of now today, but we definitely need more long-term follow-up for these devices. And in our continent, in India, there are lots of operators who are facing that there is some movement of this device into the sac, and there is recurrences and failure of these devices. But I think so for our experience is quite what we call, we are quite happy about this device, and we fortunately all our patients, wherein we have done around 54 cases, there's not a single re-bleed later in the follow-up of 4 years now. Then Tenza, and then comes the seal. This is one which is, I think so very soon will be available for us, not yet launched in India, but it will be soon available. But I feel the problem again is going to be the straight size at the neck, which is not going to address our philosophy of the intima coverage, but maybe we will have to try and have good long-term outcomes. So few of our cases, these were the first case which we did in 2017, a ruptured aneurysm. There was a clot there. I offered them open surgical clipping, but they were not at all ready. So we said, let's use a contour. So we initially put a larger contour, as well as deployed few coils, because it was acutely ruptured with you can see here a bleb there on the top. So we used a contour and coil, and she came for follow-up. She's doing excellent. 5-year follow-up. She's back to her routine life. This was another small gentleman, young 42-year male, presented with diffuse SH, classically presented with very typical blister-like aneurysm. That time 021 system was not available in India for contour, and we used a small 5 mm, but into this with a 2.7 catheter, and we were lucky that we could exclude the aneurysm. And this is a follow-up at 6 months, and this patient is also doing well. Just for want of time, this is the last case. This is another ugly looking ACOM artery aneurysm, wherein there was a possibility of arising of this ATO from the neck. So we positioned it very strategically, studying from all the angles in 3D, and deployed this contour in this patient, and she so there you can see there's immediate stasis there, and patient has done well. So few of our cases with follow-up, you can see we have had varieties of indications in bifurcation aneurysm, but our strategy is always there to keep and anchor the device well within the proximally at the neck. Pull it into the lumen. The marker should be within the lumen. You can see here. Somebody might say that it will form a thrombus, but no, it doesn't form a thrombus. It well anchors, and we continue antiplatelet. If we feel that there is a propensity or a flow limitation into parent vessel, we can continue for a week or so, even in ruptured aneurysm, because you have brought the device down. There is no flow into the aneurysm. There is stasis. It will never bleed. So this is a few of our follow-up cases. You can see how well we bring the device into the parent vessels, then pre, post, and 3 months follow-up. Another case where we did into the pica junction, and this is complete what we call follow-up with, you cannot see or identify an aneurysm at 3 per. Then this one, few of our cards. So most of the cases where we have used it for anterior circulation, ACOM and MCA, as they come more commonly to us with ruptured aneurysms. But we have also used for posterior circulation in basilar top, right from small, medium to larger ones. But the highest or the largest diameter available for us is 14, so we cannot go more than that. So key technical consideration, what is the most important thing is understand whatever device you are using. This accurate sizing is very crucial. Stable apposition, especially at the neck, where there is a propensity to form or a regrowth. Strategic positioning of the device and advanced imaging. The most important thing which we always teach our fellows or the beginners is you always have to do a vasosity. So as Uday had already said that the technical time of deployment of a device or the procedure time is very less. Go in, position the microcatheter, deploy the device and detach it, doesn't take much time. But positioning, you have to give much time by understanding on vasosity. Every time, once before detachment, you have to do a vasosity, wait for some time. You are sure that there is no flow, there is good stasis, the device is well opposed at the neck, and if the marker is into the parent vessel, then you can detach and confirm with vasosity. Because the whole device is not visible, it is only the marker which is visible, but with vasosity you can easily understand. And all my follow-ups you can see, every follow-up has a vasosity, and that's how our results maybe are good and accurate. So there are limitations, of course, we need long-term data, technical expertise, as we all know, we should have some experience and directly don't jump to, because this is an easy deployable strategies. The previous operators have already said that experience is important, coiling, then stenting, then we can flow diverters, then you come with the intrasaccular devices, because it has its own learning curve. And evidence has to be an important key, that you should select the device in select cases, appropriate cases, so that you have a good long-term outcome. Future dimensions, hybrid device deployment, which will be coming very soon. Enhanced material where we can see the devices properly. AI integration is going to be there, and expanded indications like sidewall aneurysm, which already Dr. Tufel has mentioned about. So when we think, we change our thinking, we change our action, and when we change our action, results change. Thank you for your kind attention.
Good afternoon, everyone. First of all, I would like to extend my thanks to Dr. Atulab and Dr. Arvind for giving me an opportunity to speak here. So, my first introduction to word blister aneurysms was in year 2002, when I was under training and under Dr. N.K. Mishra. I did an angiogram, and daily evening we used to go to his room to show all the angiograms. I did one angiogram which was normal, supraclinoid ICI, sir, this is an aneurysm. So he just simply said, this is what aneurysm? Sir, it's an aneurysm. He said, what aneurysm? Sir, it's an aneurysm. So, and then he scolded me like anything. And because the other thing was, I didn't do the cross compression in that view. Because I think he wanted that. So that day was my first introduction to a blister aneurysm. So the blister aneurysms are rare, basically surgical pathology. We all are now dealing with surgical. There have been a complex aneurysms to deal with in the initial part. Now I think so first time this term in 1979, O'Hara and his colleagues described a specific series of aneurysms arising from the non-branching site of the sclerotic parent arteries, accounting for 1% of the aneurysms encountered in their practice. So these, and in the year 1988, Takashi used the Japanese word that is shimame, meaning blood blister, to describe these aneurysms. So these are the aneurysms which were initially So the term blister aneurysm is predominantly restricted to half dome-shaped aneurysm arising from the same definition which was given by O'Hara. At other locations, the most common site which has been described is the supraclinoid ICA. At other locations also it has been described such as MCA, ACOM, PCA, and but etiopathogenesis is mostly this sclerosis in the wall of the blood vessel, especially high. So what exactly is the histology which is the reason for this? So basically if we see there is defect in the wall of the blood vessel. Histological examinations of blister aneurysms usually reveal a gap in the arterial wall which is covered by a thin fibrinous tissue that in entity which makes these blister aneurysms a kind of pseudo aneurysm itself in an entity. So these aneurysms once ruptured, they increase in size, they change in morphology. So some dynamic pathology also keeps on going on at that time. So these are the different kind of aneurysms, and the histological thing which we see in aneurysm. This is the blister aneurysm, saccular aneurysm, and dissecting aneurysm, where the hematoma and all those things are found within the wall of the aneurysm. So basically, etiopathogenesis is they account for approximately 0.5 to 2% of all the ruptured cerebral aneurysms. The basic reason for their formation is arteriosclerosis and subsequent ulceration, focal ulceration, which leads to the loss of the wall of the blood vessel in that particular area, and which eventually fibrinous formation, which leads to fibrin deposit, and local fibrosis happens, and the entire wall is just replaced by a fibrous tissue. So Ogawa and colleagues suggested in 2000 that development of these aneurysms is more strongly associated with hypertension than arteriosclerosis. But once formed, hypertension becomes the key dominant player in their rupture. So diagnosis, we all know 3D angiography after CT and SCH, we all know CT angiography. In CT angiography, we often sometimes tend to miss a small blister aneurysm, which is a small dominant bulge seen in the supraclinoid ICA. So 3D angiography and normal or two-dimensional angiography are become the cornerstone for these aneurysms. Because there is no wall in the wall of such blister aneurysm, they as such becomes very fragile. And as Dr. Tufail has said that for blister aneurysms, he is always advised to put 2 aneurysms, but I'll show one case where even after putting 2 aneurysms, patient had a bleed and we lost the patient. So these aneurysms are very fragile. So clipping alone, which initially clipping was done by surgeons for the same, they used to wrap it with muscle, subsequent adhesive coating and clipping or encircling clips. They used to do a lot of things which there's some special, a lot of surgeons might be knowing about it. I haven't seen this clip, that is Sund encircling clip. And they used to use some synthetic wrapping material also. But all these surgical procedures, despite all these things, had a very high morbidity and mortality. This is the kind of procedure which was done, a kind of blister aneurysms ruptured. They used to encircle it with a material and then put an encircling clip and then put in some glue or all over that so that it stays and everything is there. So endovascular approaches are usually now taken for such aneurysms, and they can be either constructive or reconstructive. Deconstructive consists of balloon or coil occlusion and using these aneurysms, and in some cases initially if the artery is very bad, we also used to do some parent vessel occlusion. But in endovascular reconstructive options include direct embolization with or without balloon or stent assistance, single or overlapping stents alone, and flow diversion. Now there are a lot of challenges involved because if you have a very small blister aneurysm and you try to put in a coil, as soon as the coil touches the wall of the aneurysm, it may just give away because it is already ruptured and it's already a pseudo aneurysm, and if there is no wall there, so as soon as the coil touches, there are very high chances that it may re-rupture on table despite you having a balloon there. So there are multiple reported cases involving direct embolization of blister aneurysm from most centers with the assistance of balloon or stent and primary coiling without any. But now we use a lot of flow diverters for treating such aneurysms, and flow diverters usually are supposed to be done with some coiling, but in some cases, if you are not able to coil it, then it's as advised by Dr. Tufel, it's always preferable to put 2 flow diverters. Now, we have also tried telescopic stent techniques using self-expanding enterprise or neuroform stents which were initially there. So these are the flow diverters now which we have enterprise, pipeline, we have Derivo, we have Surpass, and for putting all flow diverters and antiplatelets, flow diverters in blister aneurysm, we have my protocol is usually 40 milligram loading dose and 300 milligram of aspirin, and we usually give this medicine 2 hours just prior to the procedure. So now I'll show some cases of blister aneurysms. So this is a classic blister aneurysm initial case, 34-year-old male with subarachnoid hemorrhage. You can see a small blister-like lobule seen in the supraglenoid ICA. So this we have this is the case when I was there with me and Dr. Vipul Gupta were doing it together at Max in the initial days. So we had used a coil-assisted flow diversion. We placed a coil using a catheter, and thereafter we did, and in some cases, this was probably a simple enterprise used, and we placed 2 overlapping enterprises in this case. You can see, and 1 year follow-up, there was complete resolution of the complete disappearance of the aneurysm. We had initially tried placing a coil, but because this was the smallest size of coil, we were not able to place, but still we ended up putting in 2 overlapping stents enterprise at that time. This is another stent-assisted coiling. We first put stent, did coil the aneurysm, used an enterprise. After 15 days, again the aneurysm has regrown, and then placed another stent within and again coiled it. But despite that, and then the patient went home. The third case, so a big, our right ICA blister, you can see the blister, you can see it's protruding in. Grade 4 ICA. So in this case, we used a flow diverter, but we did place one single coil around the within the aneurysm. This was the first generation pipeline with a single coil placed within the aneurysm, and this is what, and then we achieved complete occlusion of the aneurysm. So the patient follow-up is also there, and there is no recurrence of the aneurysm. Patient is stable. Another ruptured aneurysm, left ICA blister. Here we tried putting in, here in this case we just placed a single pipeline and we didn't place any coil. We at that time probably these were the initial phases of treating blisters. After this patient went home successfully without any problem, but usually I advise to put at least one coil if possible within the blister aneurysm. Now only FD, another case, you can see a small blister where you can see in the along the just next to the origin of the ophthalmic. We just placed, because it's too small to place any coil, we just placed a single flow diverter. Again, this was pipeline shield. The aneurysm is, patient has followed up, there is no aneurysm. Now again, this is another patient with 40-year-old female with headaches, left ICA blister, treated after 3 years of diagnosis. Patient had headache, sudden severe headache with small subarachnoid hemorrhage 3 years earlier. Patient didn't do anything. This is the CT at the time of when patient came to show me. So this was during the time of COVID. Patient had sudden severe headache, was diagnosed with SAH. But patient came to me in 2023. So at that time I thought it was a blister aneurysm, and this was the reason for her subarachnoid hemorrhage in 2020. And I was surprised that patient is still alive and roaming around with a blister aneurysm which has ruptured, and she was sitting in front of me. So I just advised her for the procedure and placed a surpass evolve in that. Patient went fine, she is doing fine, absolutely no issues. This is another patient where we did, this is a 55-year-old female with ruptured blisters, which increased in size within 2 days. We placed 2 telescopic P64. Still the patient re-ruptured after 2 days. You can see this was the first angiogram where you can see a small pointed approach. We placed the first P64, but within that there was some initial, the proximal end of the flow diverter did not open. So we went inside ahead, did a plasty and placed another P64 from the distal end to the proximal one. Despite that, after 2 days, patient was extubated, patient was doing fine, absolutely, she was eating, and despite that, after having one meal, after 2 days, she suddenly collapsed, and we did a CT, and it was totally grade 4 SH, and she did not make it. And this was, we did some plasty, we did everything. This is the in cross view of that the aneurysm is totally covered by the 2 flow diverters, but still we lost that patient. And we did the angiogram also. We were not able to see anything, but still the patient had a grade 4 SH and she did not come out. So basically, although blister aneurysm pathophysiology is not fully understood, the parent vessel wall fragility and the tendency to rupture intraoperatively have historically made his entity difficult to treat. But now with endovascular flow divergent techniques, and usually I now advise to put at least 1 coil in the blister aneurysm, even if we are using a flow diverter. So initiation of dual antiplatelet therapy in context of flow diverter or stent placements definitely complicates if there is on-table rupture. Thank you.
Right, I'll put a timer on. Okay, so thank you again. Hopefully, a lot of this thing is covered already, so I won't have to repeat a lot of things. But I'm going to try and refresh everybody about why should you think about devices. When you look at devices, you need to understand why the occlusion rates are what they are and whether they are okay. And when you think about occlusion, you have to go back to start thinking about what is endovascular treatment is all about, and it all comes to ISAT. What I'm going to do is I'm going to talk about some of the advanced treatment, but today, in the beginning, I will discuss some amount of ISAT. Plus, this doesn't work, okay? You need to sort this out. So, important thing is to think about ISAT. Why is it all important? Because ISAT is one of the very first randomized controlled trials that tells you in terms of what the occlusion rates are. When you look at the ISAT, remember ISAT gave us a significant information about ruptured aneurysms, and the relative risk reduction which changed our practice. What we also know from ISAT is that the retreatment of rate was around 10% in these aneurysms, and there was some early retreatment, some late retreatments. But if you look at the surgical there is a retreatment in the surgical group too. So when surgeons always keep talking about clipping does not have any recurrence, it's not really correct. You look at the ISAT data, you have got recurrences itself within the ISAT data. Why is it important? Because when you look at coiling results, 18 years down the line, you still see a significant effect of the coiling. So it's not only immediate, but it's also 18 years down the line. The risk reduction is very high. So when you compare aneurysms, recurrence versus in terms of rebleeding from surgical versus endovascular, you can see the risk of rebleed is very small. Have you found my pointer or not? Come on, guys. Who made you an IT, guys, if you can't get a pointer sorted? Okay. Right. So the number of rebleed is very low. Okay. So overall risk of incidence of rebleed between coiling and clipping, you can see the risk is very, very, very small. So not only the coiling is durable immediately, but also in the long term. And this is very important because when you look at aneurysm treatment, you have to remember what is the recurrence rate of these aneurysms. This is useless, isn't it? I'll pick this. Thank you. It works? Okay. Yeah. Yeah, no, it's okay. Don't worry. Okay. Okay. So, anyway, so what we are looking at, so this is important. The annual rupture risk from a recurrent aneurysm is very small, and that's kind of very important thing. Why am I telling you all this? Because we as endovascular operators, we have to realize when we treat aneurysms, we need to remember constantly what is the end goal. The end goal, particularly in acute aneurysms, is to prevent a rebleed. So coiling, clipping, intrasaccular device, flow diverters, depends on which country you are. The treatment can vary, depends where you are. You may have some strong neurosurgeons, you may have some strong interventionists, depending on your training, depending what incentive you have. Different countries have different incentive. So the treatment can vary and the reimbursement can be different in different countries. So the treatment can depend on where you are. Then it depends on what type of aneurysm you have. One MC aneurysm, but look at the types of aneurysm. How can you have same treatment for all of them? So you have to decide what treatment is right for that particular aneurysm. So we need some time. Why do we need new technology? We need new technology because we know there is a retreatment risk in terms. We know the rebleed risk is small, but some of these aneurysms have a higher. Now you should never compare apple with pears. Different aneurysms are different. So the recurrence and the retreatment rates will be different. A wide neck aneurysm cannot be compared with a small saccular aneurysm. And that's why we have other trials, and they all have shown with coiling, the recurrent rate is around 8 to 10%. So we need to improve. Evolution, as you can see, technology is evolving. And as the technology evolves, you can see that there is a increased risk of, in terms of the complication rate, particularly with balloon, particularly with stent, with flow diverters, the occlusion rates get better. But when you look at intrasaccular device, the occlusion rates don't really get too much better, but you can't compare because you would expect most of these intrasaccular devices are used in wide neck aneurysms and not straightforward coiling aneurysms. So we have got better. Where have we got better? So in the next 14 minutes, we're going to go through some of the stuff where we have indeed got better. So let's start with the coils. There has not been much progress in terms of the coils. Coil is a coil. Every person has his favorite coil. Okay, there are some coils which have changed. I showed you earlier the Trenza coil. Target coils, I think they are a new addition to us because they are small and they can be very useful, but they are very soft. If you look like a blister aneurysm here, it's a tiny coil. It could be very difficult, but when you have a coil like a tetra coil, it allows you to put some coils in aneurysm that you would have probably struggled to put coils in. Now Trenza, this is supposed to be an intrasaccular device. Again, it allows you, like the Medina coil, is a bit more bigger coil, gives you more scaffolding, but it is very early days. I have done a few of them. I don't have a long-term follow-up. The data from the trial should be out soon, but again, it's just a coil, and again, it's an expanded coil, which Stryker tries to sell it as an intrasaccular device. Time will tell. What about flow diversion? Is there any advances on flow diversion? We all know that surface modification is there, and all these stents are having some type of surface modification, and it is done to prevent thrombosis, is done to reduce the platelet aggregation, and is done to reduce the thromboembolic things that you see or the events. Now, you could talk about different flow diverters. If you look at the study which is on Derivo heel, you can see there is it does reduce the risk of thromboembolic, okay? But again, would anybody use only single antiplatelet for a flow diverter? I wouldn't. Secondly, is prasugrel the same as clopidogrel? Probably not, okay? So in using a prasugrel or a ticagrel and calling it a single platelet is not necessarily the right thing. But again, so I don't think I would still encourage anybody to use just single antiplatelet at this stage. Stryker have come with Surpass Elite. I've done a few of these. And again, I still use double antiplatelets. I still do the same as I do. Here is a patient with a carotid ophthalmic aneurysm that you can see. And you can see that, and it works pretty well like any other flow diverter. You can see the 3D, and then I have dropped a flow diverter here, and it's pretty slick like any other flow diverter. So certainly it's a good progress from the previous Surpass. But technology, all these flow diverters are now coming up with coated flow diverters. But again, would we stop giving double antiplatelets? I don't think we are at that stage or we have that evidence. The good thing about flow diverters is the low profile flow diverters. That is something which is good because 17 system makes it very useful. And there are so many of them now in the market. I have used Silk Vista, I use a P48, I use Derivo. I haven't used Fred Jr., not a big microvention user for flow diverters. I don't use Fred, but again, it's an easy stent to use. Some of you might want to use that. It's all individual preference. Again, you get a good complete occlusion with these small, low profile flow diverters also. Let's look at a case. This is an ACOM aneurysm which was treated in the past. Patient went ahead with coiling. As you can see, the patient was coiled in 2018. What happens then? follow up, the patient has a recurrence. As you can see, this is an elective aneurysm, and it's got a recurrence now. So then what happened? The operator decided to put a contour there. One thing I would try and advise, don't put intrasaccular devices in previously treated coil aneurysms. They will recur unless you have a very good anchor, web, contour, neck stand, arteries, everything. I've done everything, doesn't work. I've already done it. I can tell you it doesn't work. Don't use it, okay? So contour doesn't work, and it did not work here. So whoever the operator was, he did not think about it, but we didn't have that experience at the time. But in 2023, you can see there is a recurrence that you can see in the back of the aneurysm here. And now what you need to do is put a stent. You can use your 17 system, floor derivo, and this is what I think was used. And we knew that the neck is on this side. There is an ACOM here, but we put a derivo stent here across it and try to bunch it up here and then cover the neck, as you can see here. And that was treated with a derivo stent. And the 6-month follow-up, the aneurysm is gone. Whereas we have already discussed, and Nitin already spoke about intrasaccular device, I'm going to just touch a little bit on it. You know, you can use intrasaccular device if you use it in the right cases, in the right way, and if you size it properly, it will give you the right result. Use it in the wrong place, it will not give you the right result. So here, if you have a web, you can use it as a stand, you can use it as a coil. I've been doing web for nearly from 2012. Let's look at this case. This is a standard web aneurysm. It's a left MCA. As you can see, the aneurysm looks pretty good. I've used a web here, and you can see now, 9-year follow-up down the line, the aneurysm has still stayed occluded. What does the contour do? A contour is a braided device again. As you can see, it's connected. It's a double braided. It's called half a web, but it does, the sizing is easy. Then less numbers, so it takes some of the pain that you have with web away. Here is a patient with the ICA termination. You can see the contour has been dropped here, and then you can see the contour has been dropped, and you can see the 12 months occlusion, 2-year, 3-year, 4-year occlusion. So in a right aneurysm, it will work. What can go wrong? Okay, well, if you choose the wrong one, you're going to have a problem. Well, if you size it wrong, you're going to have a problem. You should try and keep perioperative antiplatelets, if not long term. Use perioperative antiplatelets because thromboembolic is a definite, a certain risk, around 13 to 15% complication with thromboembolic. Symptomatic is around 4 to 5%. So you will get thromboembolic. Try and give a perioperative. And Nitin was talking about bringing contour particularly down. It's very important. Let's look at a case here. 57-year-old patient who presented. It was unruptured aneurysm. Look at this aneurysm. Is this an intrasaccular aneurysm? No. This isn't an intrasaccular case. You put a wrong device, you're going to get a wrong answer. So if you look at that, somebody has put a contour there and then put some coils. What's going to happen? It's going to recur. So you have a follow-up, and this has recurred here, as you can see, and then it's a significant recurrence. So what is the treatment here? The treatment here is a flow, not an intrasaccular device. Treatment here is a flow diverter. You need to understand what some of these aneurysms. We've been coiling now for nearly 20 years. I understand more what not to coil or what not to use rather than just use it, and that's experience. And remember, experience comes with bad choices made in the past, okay? So it takes time. So here what I've done, I have put a, obviously you want to protect the SCA, so I put a contour here, but then I know the treatment of option is a flow diverter, and I have put a flow diverter here. So you can see there is a contour here, and then there is a flow diverter put across. All right, can I call you back? Bye. So so you can see that there is a flow diverter and you got stasis, and I have now got I think a 1-year follow-up, and it has stayed okay. Now any intrasaccular device, remember, don't think about aneurysm as a one-shot. I think that's a very misconception. You have to think like the surgeon. You got to cure the aneurysm. So how you cure it? Bad boys need bad treatment. So if you have a contour, if you think you need coils, put coils. If you need a flow diverter, put a flow diverter. So if you look at an MC aneurysm here, this is it's a reasonably big aneurysm. Now anything in contour 9, 11, 14, I put some coils. Certainly 11 and 14. 9 plus or minus, 14 and 11 contour, don't put it on its own, you will get recurrences. They are big aneurysms, they will get pushed, put some coils. So here you can see I put a contour and then put some coils, and then I know this is gone and it did not come back. Okay, what else we got? We got next 10. Now when is next 10 useful? Sometime if the aneurysm is too big and you can't get a contour, the contour and next 10 or web or anybody, if you can't touch the wall, don't put it, okay? It won't work. Put as many coils in it, but if the device doesn't touch the wall, don't put it. So if you want an aneurysm which is like 10 millimeter, but the neck is around 6, 7 millimeter, contour will not work because it's too big. But next 10 might work because it sits at the neck, because you're just sitting at the neck and then you can coil. So here you can see a complex basilar acute ruptured aneurysm. This is a bad aneurysm because this will recur. And if you look at this, I put a next 10 because contour won't work, put a next 10, coil the aneurysm, and you got a complete occlusion. And I've now got, I think now I've got a 2-year follow-up too, and it has not budged. This is where we are getting better because we are understanding what not to do or what not to use. Here we knew that the device was sitting on the wall. I knew contour will not work. I used an extend and I packed it and it worked. So you have to learn about it and you can change your treatment. Moving on to some other device, E-clips. What E-clips does is it forms a bridge, and there are two types. One is a standard and one is a flow diverter type, and you can drop it. I used to use it when it was a 4 French. Now it's a 27 system, so it's become quite easy. It's actually pretty good for recurrences. Here is an aneurysm that you can see. You drop the E-clips on one side, you drop the E-clips on the 2 leaves on the other side, and you can coil within it, and it will do a good job. I am very optimistic. This is a very good option. I have done quite a few now. I haven't had any recurrences from my E-clips treatment. I've got 3 minutes, so I should be good. So are we getting better and better? Well, technology is getting better. Now, Medtronic have come with this device called RTs. It was previously Lunar. It again is a much more softer. It's a double braided device. And again allows you, I think I showed you earlier, RTs in a PCOM aneurysm. It's like a web, but not a web. And it allows, it's a bit softer, and the sizing can be it's still a bit tricky, but not as bad as web. Now, but we don't have long-term follow-up. So you need to be careful about when you use it in the right patient, because you need to be clear what the implication and follow-up is going to be. So if you look at an ACOM aneurysm here, you can see the RTs is sitting right on the aneurysm, and you can see that you have occluded the aneurysm. I haven't got the images here, but this is the case that recurred. So I've done about 20 now. I haven't got a 2-year follow-up, but one of them has recurred. I don't have the images here, but what if you see this RTs, there is a bit of an endoleak here. So this endoleak has caused me trouble, okay? So when you don't size it, or you think sometimes you have sized it, but it wasn't the right size, then it will recur. This RT's case actually is the only case I have with recurrence of the aneurysm, because I think when I look at it, it wasn't sitting properly, okay? And finally, then another new technology that is come in, which hopefully will come here too, and I've started doing these cases, is Nautilus. So you have a device that is a neck bridging device, like the neck stent, and you can coil it. So here is a patient with a basilar termination aneurysm that you can see. As you can see here, the Nautilus device is a little bit funny, you got to get used to it. It comes out like this, and you think, is it going to sit? But once it sits, it immediately forms itself, and then you can see it comes down on the neck, and then you can coil the aneurysm. So it does work, and it does a good job. I don't have follow-up on this, but there's a trial which has been recently been finished in US, and that should be coming out with their results but the trial results, initial trial results, don't look very bad at all. But like with all intrasaccular device, you need some long term. You need at least a 5-year follow-up minimum. So, so technology is getting better, and that is based, remember ISAT, we knew the rebleeding risk are small. Wide neck aneurysms are still a problem, but the technology is helping us to get it better. Thank you. On time. Yeah.
Can you pass the mic for me?
I have a 5-year follow-up on in saccular carotid ophthalmic aneurysms. I think the paper has been accepted. It's around 120, 130 aneurysms. We have got 100% occlusion in a carotid ophthalmic aneurysm with flow diverters.
Oh, with flow diverters?
With flow diverters.
Oh, you mentioned that you just coiled.
No, flow diverter.
Oh,
with
flow.
or without
Okay.
coils, because if the aneurysm is more than 10 millimeter, I always put coils.
Because that's the most common site for recurrence in the...
Yeah, but with flow diverter.
Okay.
So carotid ophthalmic
I thought that it was
aneurysm,
only coiling.
I think flow diverter. Now there is an alternative my thinking of not using flow diverters, but can use a braided stent like a Leo and put coils. It's possible, you can do it. Remember, flow diverter is not without complication. I had not had a single death in my carotid ophthalmic till about 4 months back. I had a death, okay, in the carotid. I thought I had 0. My 0 became 1 now. I don't know why she bled. I had the case on me. I didn't show it here. And I still don't know when she bled. She bled somewhere during the procedure, but we can't see it. There was no hemodynamic disturbance. There was nothing on the angiogram. I mean, I wasn't in the procedure till the catheterization was done. I don't know whether it happened before the catheterization, but I had a very senior registrar doing it. And anesthetist never said anything, but I had 1 death from a carotid ophthalmic. And she woke up, and obviously I did the flow diverter and I disappeared. Post-op CT had a bleed. Nobody picked it up. In the night, she rebled and she died. So she was missed from, there was an intraoperative bleed which was missed post-op. And it's my fault because I did not look at the CT. I just went out after the flow diverter. And she died.
This French data which says that if the aneurysm is more than 1 centimeters, there's 50% recanalization with web.
If the aneurysm
if the
is
aneurysm more than 1 centimeter, in craniocaudal extension, there's 50% chance of recanalization.
No, it is 100% chance of recurrence.
Yeah.
Okay.
50% recanalized.
Yeah. So I've done now probably more than 200 plus webs, okay, and proctored hundreds of them. So 2012 we started. I would not put a web in aneurysm more than 9 millimeter, okay? That's my margin. And if I put a web, then I will put a stent. I know it will recur, and I have the same problem with contour too, okay? It will recur, that's why I put coils.
With contour, the problem is the dog earring. Because when you have a wide neck aneurysm, the neck is never converging.
Correct. No.
Yeah.
No, you're right. So I didn't talk about it, but quite often when you put a contour, you need that dysplastic appearance of the base so that you can bring it down and you create an artificial Y stenting. That is the main aim. If you can't get that, don't put it. You will get a dog ear and you will get a recurrence. Yeah. So this is something we have learned now with contour. You need a dysplastic base and you need it to come down. And that situation, web is good. But when it becomes more than 9 millimeter, you need a contour with coils.
Yes, that you. How do you assess? Yeah.
Okay. Thank you. Thank you. Thank you.
Now I invite my dear friend Dr. Vivek from Max Hospital.
कनेक्ट करना पूरा सिस्टम रीस्टार्ट करो
Any questions from the last all lectures which we have heard? Any questions? Dr. Asulov is ready to answer those questions. I have been seeing he is very attentive on this.
अभी पिछले वाले मैक में कौन सा ये लगा था यहाँ पे चेंज नहीं लिंक हो जाता ये नोवा हिस्ट्री से और क्या कनेक्ट हो रहा है बट sorry for this glitch. Good afternoon and thank you Arvind and Dr. Atlab for having me here. Since morning we are talking about different technologies, how it has helped us to make our patients' lives better. But every advance comes at a cost. And the flow diverters are one thing which has absolutely changed the way we treat aneurysms in last 10 years or 15 years. But the cost which we pay for that are the complications associated with it. And why it is very important is because when I see my colleagues, my younger colleagues, my fellows doing independent cases, they feel that flow diverter is the answer to everything. They would put flow diverter left, right, and center, and they say there is no complication in our hand, or it's very minimal. But it's just that you need to have enough years to have those complications, because beginner's luck is definite thing there which works. So, and it is not my belief that FDR with complications. World over, there are enough papers. I'll just quote a couple of meta-analysis, which actually tells what's the real world scenario when we use flow diverters. And then we'll go to how we can, what are those complications and how we can help in mitigating them. So this was a study recently published around 3,000 patients, which says the complication rate is around 17%, combined both ischemic and hemorrhagic. And in ruptured aneurysms, which is predominant practice throughout our country, the complication rate is higher. It's almost double. And it is not that one device has a complication, other does not. Almost all devices will have complication depending upon how frequently do you use them. But when you see which are the territories which have more complication, any territory with more perforators have a higher complication. And that's why basilar, proximal P1s, M1s, the devices, FDs being used in those territories will have a higher complication. And what are these complications? They could be hemorrhagic, they could be ischemic, and they are not only the hemorrhagic and ischemic complication. Yes, true that they occur most frequently within the perioperative period, that is the first 24-48 hours. The rate of hemorrhagic complications in long term goes drastically down. It's almost negligible, very, very uncommonly it will bleed. But the rate of ischemic complications, they don't go down so much. If you see this graph, the hemorrhagic complications go down, but the ischemic complications can occur even at 1 year or 6 months or 1.5 years down the line. And now we understand the braid deformity in flow diverters. So we know why we are having those complications 6 months, 1 year down the line. And hemorrhagic complication is not only just the aneurysm rebleed. There could be all kind of rebleeds within the brain, but thankfully it is less. It's not very common. So why do we use technology which has 14 or maybe 14 to 20% cumulative complication risk? We use it, if you see this data, which is almost of 2,000 patients, the conventional technique of coiling or assisted coiling versus flow diversion, it says, yes, the complication is high, but the long-term occlusion rates or the recurrence rates are definitely much lower. They are clinically statistically significant if you use flow diverter. So yes, it's a great therapy, but we have to really, really see where we can use or where we should use and what precautions to take. For the sake of teaching or for the younger colleagues, I've divided the complications of flow diverters into the perioperative, post-procedural, and delayed complication. And Dr. Atlub has specifically requested to talk about FDBD, so which I will cover in delayed complications. So peri-procedurally, I will show you cases. So this is a case-based review. So this is starting with a thromboembolic complication in the immediate perioperative period. This is an oldish gentleman with ruptured aneurysm. It's a basilar trunk aneurysm. If you see, there is really no other way to treat this aneurysm, either surgically or endovascularly, but to do a flow diversion. And as Tufail and Dr. Manish was saying, that we do treat these aneurysms with coil along with flow diversion, and that was done. And if you see this image, this is a very reasonable result. The artery is reconstructed, aneurysm is gone. And patient did relatively well. She was okay for 5-6 days. But on 7th day, she had a clinical neurological deficit. We repeated the DSA. DSA was normal. And this is the comparative MRI, preoperative and 6 days later. You can see that there are a lot of ischemic changes. And this is happening 6 days or 5 days after the procedure. Why it has happened? Nothing is closed, everything is patent, the device is same, aneurysm is same. But this is a perforator-rich territory. So all these perforator-rich territories, repeatedly, we will have complications, these small strokes, which may not be relevant going for long term for the patient, but sometimes it can just debilitate the patient. Another example for the same very young patient, she came with an unruptured aneurysm with headaches. It was detected incidentally. M1 aneurysm, temporal branch incorporated. Since incorporation was there, we thought we'll just do a simple flow diverter. Adequate flow diversion was achieved post-procedure. And this is the CT. 1 day post-op, 2 day, and last is maybe 2 months post-op. So second post-op day, you see the basal ganglia region. The infarct is developing. Again, smooth, 20 minutes procedure, nothing going wrong, but it's just a device in a territory which is a perforator-rich territory. You really can't do much about it. There are ways to prevent it, but you can't really avoid it. And that's the reason I say that flow diverters, though they have made our life much, much simpler, but it's not the solution for each and every case. So what we can do for the thromboembolic events? They mainly are because of clot formation within the device, or sometimes in the perforator-rich territory, the struts of the flow diverter covering the perforators. So we can partly oversize the device in these territories, And whenever we use dual anticoagulation, I think all of you agree, clopidogrel is not the way to go. One should not experiment in your early phase with clopidogrel. If it is an intracranial device deployment, you have to go with either prasugrel or clopidogrel or cangrelor or ticagrelor, whatever is your device. So what more? Now the technical difficulties which can cause complications. What are the technical difficulties with flow diverters? There could be foreshortening, there could be prolapse of the device within the system. So there could be clot formation within the device. So see, this case is a young male who came with pressure symptoms. It was unruptured, but patient was acutely sick, was intubated in the, this child was intubated in the ER because he was having repeated vomiting and was had a low GCS. And this was the situation. Again, a large basilar trunk aneurysm. And this is what we planned, that we'll just go in, put in a couple of coils and put in a flow diverter. It should be relatively simple thing to do. What we fail to understand is that this distal landing zone, we thought it would be enough. It was just 5 millimeter, 4.5 millimeter. So we went in, one catheter in the aneurysm, another in the PCA, started deploying. But if you see this video, if it plays, yeah, it's playing. The more I open the device here, the more it sinks inside. And it falls, it fell within the aneurysm. So this happened twice, thrice. We were trying to avoid the jailing of P1 perforators, but it happened multiple times. But thankfully, we could recross it and deploy it from the P1. Now it is nicely being deployed from the P1. But since this plan changed on the table, device was same, so it was a shorter device. It finished somewhere here. And so it's hanging, the free end is hanging here. So this is not a treatment to do. This, we are going to harm this patient rather than to benefit this. So we had to secure this device by putting in a braided stent so that the device is causing adequate flow diversion across the aneurysm, as well as it is secured inferiorly within the basilar with the stent. And you can see a lot of flow diversion effect is coming immediately. And this patient did well, but again, the point to reiterate is that flow diverter, it looked simple. It's a straight artery, no curve, no lot of tortuosity. It's a young child, so access is very simple. But if you don't plan it well, just do think it's a simple case. You can, even with my 15 years experience, we just landed in trouble like this. But thankfully, this patient did very well. The aneurysm slowly got, we could not put coils because plan changed on the table. The thrombosed component slowly got absorbed, and the beautiful reconstruction of the artery we could achieve down the line. And this child is doing well. So another major thing which can cause complication is poor opening or poor deployment of the device. It could be operator specific, it could be device specific, it could be anatomy specific, but the end result is the device does not open and clot formation occurs. See this patient, keratoophthalmic aneurysm, again, as the previous Dr. Tufel was saying, our protocol is same, put a couple of coils, maybe 1 or 2 large coils, and deploy the flow diverter across it. And you can see here, at the bend, it is not opened very well, here. So what is the way, again, for the younger doctors present, one can just recross it with a microcatheter, massage it, and usually it will open. But if it does not open, like like in this particular case, it did not open, so you could take a DAC. So this is the distal, this is the this is Fargo Mini. So we took this DAC inside the flow diverter over a 27 microcatheter, and the inner wall just just popped open, and that was the end of it. So this is a very routinely done thing, not a big deal. But the point is that if it does not open with microcatheter, if the anatomy permits, you can take a distal access catheter across the flow diverter and it will open, and the embolic complication will be less. But it does not happen always. See this patient, this is the complication which we had. And why we had this complication? Again, same treatment, coil, flow diverter, it is finishing here. The moment we recrossed it, it foreshortened or it retained its original length. And this is the end of the flow diverter, from here till here. So flow diversion was good, but immediately post-op, you can see this clot formation. It's a big, large chunk of clot. If I don't control it, this artery is going to shut down within 5 minutes. So we gave escalating dose. I use abciximab intraarterial routinely, so we gave escalating doses. It lysed the clot, so intraarterial GB2B3A inhibitors are a boon for us. So this clot got lysed, but within 5 minutes, it formed again. So it happened 2-3 times, and then we realized this was the situation. Because of the foreshortening, there was a blind pocket here between the wall and the flow diverter. And that was the site where the nidus was forming. So again, this is technically looks very simple, but if you have situation like this, then this is not going to go away. We thought we can just balloon it. This is the hyperform balloon. So we just thought we'll plaster it against it. But once the free edge is in the air and the length is not there, you can't oppose it well. So finally, we had to take in another stent. Again, Leo, I think it was Leo. And we just telescoped it. And the clot immediately disappeared without any further antiplatelet. So these are the technical issues which one can face, and this can cause complications. What you need to avoid them or to minimize them, one, definitely training. Without training, you will have these complications or sooner or later. Case selection is very important. You should know where to avoid or where to go forward. Vaso-CT or advanced good machines. Somebody in the morning was saying, you can do aneurysm in any kind of machine. Yes, you can do. But quality work, you need to have good equipment. Preferably biplane for aneurysms would be my recommendation. Stroke, maybe you can get away, but not in aneurysms. And have as much distal access it is whatever is possible with you. Distal access makes the handling of the devices much smoother, much better. So if you have a triaxial system in every case and your guiding catheter is parked close in the cavernous sinus, the chances of these mal-deployments will be minimized. And of course, GB2B3A inhibitors, intraarterial infusion, massaging. And if clot does not go away, plasty or telescope stenting is the way to go. So injuries, yes. The last case, Dr. Tufail was talking that he lost a patient of carotid ophthalmic aneurysm because patient bleed was missed. This is something similar to that. See again a giant aneurysm, and this was an unruptured aneurysm. This patient came with pressure symptoms, some endo problems. She was investigated, and this was the artery. This is my PGI Times case. So this artery, we thought the whole artery is ectatic. The aneurysm is there, but the artery is ectatic till here. So we thought we'll cover from normal till normal. So we put 2 flow diverters with 1 single coil. We covered it. It went well. Patient, it was smooth. Post-op CT was this. So there was a small SAH. Patient was brought back. DSA was done, and there was no bleed. At least we could not figure out where the bleed is. And we thought it was a small bleed and it got sealed itself. We will get away with it. And this is the follow-up CT after the check angio. The bleed increased. So we could not find the bleed. Bleed increased. Case was smooth. Again, whatever, when I say case is smooth or when you say case is smooth, it is smooth because, and patient is in trouble, it is because we have missed something. So it is always operator's fault. If a complication occurs in initial perioperative period, it is not device fault in majority of the patient, it is operator's fault. And so this happened, we withdrew the antiplatelet, we could not do anything, we were losing the patient. Patient was okay for 1 week and then everything shut down. The entire ICA went away. We went in, we recanalized it, but this patient landed into status and we ultimately lost this patient. And one patient lost elective aneurysm case who has come for elective surgery. If you lose a patient, it changes your practice for another 6 years or 10 years. Because you can't lose an elective case. If a patient has come for elective surgery, you have to make sure that he or she goes home walking as they have come. In ruptured, still you have that some latitude. So ICA dissections, again, they are not a big issue. This case came to me from some other center. They were trying to access this. It got dissected, it got shut down. Patient came, and we just went in, did the flow diverter, and put in stents. Now, you just can put, in cervical ICA, you can just put coronary stents and get away with this dissection, so it's not a big thing. I think I have 2 minutes? 2 minutes, no? So, other things we'll skip. What the new complication or the new thing which has come in last couple of years is the braid deformity in flow diverters. So we knew for last so many years that the aneurysm, the patent artery gets stenosed, or sometimes you have a delayed complication rate, but we did not have a real answer for that. But now we know braid deformity is to be blamed in majority of the cases. And what is braid deformity? Braid are the wires. right? So when the construct of the flow diverter, it gets deformed. It can get deformed in many ways. Either it will collapse, or it will constrict, or it will bump out. So these are the technical terms given to it is fish mouthing, foreshortening, braid collapse, bump, or combination of this. If any of these things occur, it changes the caliber of the parent artery wherever it is deployed, and one can have complication. Fortunately, these complications are not life-threatening, but in some cases, especially when they are retreated for ischemic complication, people land into trouble. And they came into our knowledge or our understanding after we started using, the company started using DFT technology. DFT is drawn filled tubing. So just for in a couple of seconds, I'll tell what is DFT. If this is the wire, this is not radio opaque. This is a cross section of the wire. If you fill a radio opaque in the center of the wire, in a straight wire, if you have a core which is radio opaque, and over that you have the core material of the wire, then you make this wire, construct this wire, you call it a drawn field technology, just to make it more radio opaque and softer devices. So because of this, initially it was blamed that DFT technology is to be blamed for brain deformity, but now we have enough papers to say that everything is directly, indirectly causing this brain deformity, be it patient factors like size of the vessel, discrepancy in the proximal and distal landing zones, tortuosity of the vessels, as well as the material, whether it's nitinol or cobalt chromium, whether it is core wire or a drawn filled tubing. So oversizing or undersizing of the devices. And how does it look like? See this, all these cases which I'm showing of FDBD are from a research being done, which was done at PGI Chandigarh. My friend Chirag has done this study. This is the immediate post-op of this aneurysm, and this is the deformity. The device is foreshortened from this to this, and this bump has increased. And what it has caused narrowing in the parent artery. Asymptomatic. Fish mouthing, how does it look? This is the stent, immediate post-deployment. See this in 3 months post-op, this is the narrowing, and this is because of this fish mouthing and enhanced intimal, this white line you are seeing, this is the intimal hyperplasia, which is hyperactive because of this fish mouthing. So these are the classical examples of braid bumping or fish mouthing or foreshortening of the devices, which now we understand is FDBD, and there are many papers. These are the classical papers. Again, ChatGPT has made our life easier. So these are the 4 or 5 classical papers on FD if you want to understand what is this. And thankfully, it does not harm patient much, but when it does, it can cause definitely stroke for sure. And what the PGI paper, I've just taken a very small excerpt from that paper is, which is very interesting. This is the only Indian data to my knowledge of, I think, nearly 180 patients of follow-up of flow diverters, which highlights the flow FDBD problem. If you see nitinol versus cobalt chromium, so definitely, as we know, nitinol stents or FDs have more FDBD, and you see DFT versus non-DFT, again the DFT technology devices have more chances of FDBD, but no device, no technology is immune from it. As you can see from this data, every device has this issue to lesser or more extent, and how can we prevent them? This is my last slide. Device selection is important. Choose the correct device. Don't oversize it, don't undersize it. Measure it accurately on a good system and choose the device. If it is vessel is tortuous, then newer devices are better. Deployment technique, again, ensure enough landing zone proximally especially, so that you don't land in this problem. And these other things, these we do routinely, so not much. And please follow these flow diverter patient if possible in your setting, because few of these patients will have these problems. So this is what I wanted to share with you on flow diverters and their complications. Thank you very much.
Excellent.
Thanks.
Any one question is allowed? I think we thanks a lot. Now we go to the next session. I think we will request your to please collect your answers.
This is Dr. nowadays shifted. So please, Dr. Pankaj, Senior Consultant Neurologist, it is around.
Now, we go to the next session. We'll be having two speakers, Dr. Ali and Dr. Abdul. First, we'll start with Dr. Ali Niaz. He is my very dear friend from Maldives. Our journey goes back 5 to 6 years back when I was going there and we set up a department of neurointervention in the hospital in Maldives. Now, he is independent neurointervention in Maldives. He's a neurosurgeon and he does all neurosurgery as well as diagnostics. So, I invite Dr. Ali. He will be presenting on the middle artery intervention. Yes.
I think Sir is having some technical issues before the challenge is being uploaded. So can I call upon Dr. Abhi Kassan to deliver the lecture on memory agents?
Sir, can I have the table? सुबह नहीं हुआ ना? हाँ वही तो। Good afternoon, everybody. Thank you once again to the organizers, and my professors also here, Professor Carotid. When I was giving my exams, he was my examiner, and the questions that he asked me was related to the embolic agents. So, there have been traditionally since 1960s or even earlier, sir would know better, there have been multiple embolic agents which have been used, like silicon microspheres, silk suture fragments. Polyvinyl alcohols are very much in use now also, but mostly they are in the head and neck vascular malformations. Detachable balloons have been traditionally used for carotid-cavernous fistulas as well as for any high flow fistulas, and still used. So they are mostly adhesive and non-adhesive embolic agents, and they're mostly in the liquid form, and all the pharmacological evolution has been taking place with regard to liquid embolic agents only. So N-butyl cyanoacrylate is the oldest adhesive liquid embolic agent which we still use and very much in practice because of its fast polymerization, and it is used mostly in high flow diseases. Non-adhesive ethyl vinyl hydroxide based liquid embolic agents have been used and transformed the treatment for arteriovenous malformations. And related to the same EVOH based ethyl vinyl hydroxide, the other newer agents have come into play like FIL and Optura, which have further improved the treatment. So, as we all know, the liquid embolic agents would they form they are monomers of the N-hexyl cyanoacrylate, and when they come in contact with the tissue, they form a polymer which blocks the vessel, and we always use radiopaque agent like lipidol, poppy seed oil to enhance the visibility as well as to increase or decrease the viscosity of the agent. So these are the good, whenever somebody is developing a liquid embolic agent, they would look at the biocompatibility, the workability, the viscosity, the stability, and the visualization under fluoroscopic guidance. And more, like I said, mostly it's used for high flow vascular malformations like arteriovenous fistulas, AVMs, hypervascular tumors, even aneurysms they've been used in. So these are the two basic subgroups, polymerizing types and the precipitating types. Most commonly used in the polymerizing types is the N-butyl cyanoacrylate, which is used with poppy seed oil. And the others, which are the precipitating liquid embolic agents, they are used with dimethyl sulfur oxide, and they are usually the squid, onyx, FIL, the most commonly used in our country. So coming to NBCA, it causes an exothermic reaction with formaldehyde production and causes acute as well as chronic inflammation. It's highly adhesive, it rapidly polymerizes as well as causes recanalization. So this is a young child who had difficulty in walking as well as delayed milestones since childhood. You can see a large saccular lesion in the spine, in the dorsolumbar region. It's a very prominent flow void. When we do the angiograms, you can see that it is pile AV fistula, which is, this level is a D9 level, and you can see how the tortuous the arteries are, and then it is going into a lot of perimedullary and paravertebral veins. This is another level which is at the L1 level. So she has two feeders at D9 and L1. And this is the anterior spinal artery, which is very important. It has this very particular shape, which is a hairbend, and it's bang on the midline. So it's very important to identify this artery, because if it's coming from the vasculature, it's going to be disastrous for the patient. So we went into the feeder with the shortest arm to the vascular malformation, because both the feeders were connected craniocaudally, and we used N-butyl cyanoacrylate. We took a super selective run at the when we reached the junction of the fistula, and you can see how the white and the shadow that you see with the tip of the catheter is where our N-butyl cyanoacrylate is acting, and the whole idea is to cover the mouth of the fistula in such a way that, so they call it a mushroom shape or things like that. So, and this is the post check angiogram. You can see that the vascular malformation is occluded, from both the levels, the D9 and L1. The fibrin glue is mostly used in peripheral, like most commonly in pseudoaneurysms, which are generally tackled with at the groin level, and it comes in a double barrel syringe, and you use a ultrasound Doppler probe to compress the neck of the aneurysm while this is being injected to cause thrombosis of the pseudoaneurysm. There have been other materials which have been developed, but this is a shear thinning biomaterial which has been developed by Mayo Clinic. It's not available. However, it's gelatin and silicon nanoplatelets. It's highly resistant to fragmentation, and they say might replace coiling in the future. So that's one agent which has been developed. There are other agents which are glycol-based hydrophilic hydrogels. They have been used in over coils, which are hydrocoils, but again, recanalization rates have been known in these coils. And the others are polyethylene glycol based, which have low viscosity, and they have been shown to have better tumor embolization penetration. So coming to EVO, ethyl vinyl hydroxide with dimethyl sulfoxide as a solvent, these are the most commonly used agents. They are mostly come with from Onyx, from Medtronic or Squid, from Bolt, as well as a Phil. So they come in different viscosities. They have less beam hardening artifacts on post procedural CT scans, so you can get a better idea on the extent of the nidus. And they need a DMSO compatible catheter. So this is again a young patient who had a posterior fossa bleed. It was a very diffuse Vermean avium, and this whole avium was able to be embolized in one sitting because of the help of these precipitating agents which have been developed. These are it's quite a largish avium with multiple draining veins into the superior serratus sinus as well as the transverse sinus, and you can see that post embolization you have achieved quite a good cast, and the final runs show some perinadular perinadular vascularity, which over time need follow-up to be looked into. So the advantage of fill is that it doesn't need to be agitated like squid and onyx, and it has even further lesser artifacts compared to the tantalum-based liquid agents, and it forms a faster plug. However, at the moment not available for use in India. The new kid on the block is the Optura. It's again a non-adhesive EVOH based iodine-based embolic agent. So it causes the radio opacity to be lost over time. And that's the advantage, and that's going to revolutionize this is a picture from a recent journal which was published, where they show that the AVM was embolized, and this was a CT scan post embolization, and after 6 months you don't see any evidence of any embolic material. So when you have such an image in front of you, you can, when your patient comes to follow up and you're planning staged treatment for AVMs, it will better make you understand the underlying anatomy and the pathophysiology that is happening with that AVM. So this was another patient where they used transvenous approach, and post embolization, after on follow up, only the transvenous coils and glue which were used to occlude the venous side were left to be seen, and the rest of the embolizing agent disappeared. So balloon assisted techniques are also there. They are generally done to preserve the sinus, the venous sinuses if there are dural AV fistulas present, or the arteries if there is a carotid fistula is present. So here you can see that there is a inflated balloon along the transverse sinus with, and you inject these ethyl vinyl hydroxide liquid embolic agents, and you can get rid of the complex dural AV fistula in one sitting and preserve the sinus which is functional for the given patient in the same sitting. And this is another example of the same, and these are check angiograms showing that the obliteration of the fistula with patency of the venous sinuses. This is again a complex fistula which is where a balloon and coils as well as liquid embolic agents have been used to occlude the complex vascular malformation. And this is a carotid fistula which is having a rent at the cavernous sinus, causing proptosis and chemosis for the patient, and this has been again used with the help of balloon in the parent artery to preserve it, and coil from the venous side the cavernous sinus. Again another, you can see the inflated balloon and the coils covering the rent as well as the sinus. So there's another, this is another new variant of the coils. It behaves like a liquid, they say. It's still not available in India. It's called the Swift Pack coils, and they've been used in various treatments in the external carotid system for SDH, MMA embolization, for hypervascular tumors, and they are supposed to be coils made up of a metal but behaving like liquid, in the sense that once they go through a very low profile microcatheter and they go till they meet the resistance, and once they are ejected through the microcatheter, they form the shape of the artery and try to go as far as possible, and that's what they've been trying to show. The radio opacity that you see is the coil. So instead of coiling on to itself, it is going in a linear fashion and finds a path till it finds the maximum site of least resistance, and then also it comes and towards the microcatheter and finds another path. So that's so to conclude, all these evolutions in neurochemistry are providing us with newer therapeutic agents which might add to our present understanding as well as decision making and bring in more permutations and combinations like we saw with these complex vascular malformations, and make treatment more safer and help us study their behavior on follow-up. Thank you.
We can take a couple of questions to somebody. So I call upon Dr. Alimia to present middle meningeal artery embolic.
Good evening, my dear Dr. Arvind and Professor Atlap, for inviting me for this session. I am a Maldivian and I am closely related to India, and a lot of developments in the Maldives is a direct impact from Indian medical community. Thank you very much. So my talk is on management of chronic subdural hematoma, which is very dear to all neurosurgeons. Treatments have been started way back in Egyptian times when trepanation of mummies have been noted. So I come from the beautiful country of the Maldives, where you have beautiful beaches and lovely lagoons and lots of fish to go around. So as the world is aging with newer inventions of medications and treatments, we find more of chronic subdural because people live more to have worsening brain atrophy, disproportionate brain size to the skull as well as to the dura. So why did we think of a treatment which has been working all this while, and all of a sudden we start to think we need a change in the treatment? It all starts because chronic subdural hematoma is known for its recurrence. It's so common that I, being not a very old neurosurgeon, I have also operated one patient for more than 5 times. Probably some technical changes might have benefited, but this is what it is. Chronic subdurals, when the brain does not expand, it remains with the cavity, and if the membrane is persistent, it will leak out. So there's a high rate of recurrence, high rate of reoperations. So we need to find out why we are having this high number of recurrences. So we'll go back to the mechanism of chronic subdural hematoma formation, which is a venous disease. We all know the reason for chronic subdural hematoma is trivial trauma. It's not a major trauma. It's not brain laceration. It's the rupture of bridging veins. When your brain atrophies and the link between your brain, venous circulation and the dura is taut, and with trivial trauma of just a fall or jump into the sea or motorboat ride in the Maldives can lead to a chronic subdural hematoma. And in this picture you can see bridging veins crossing onto the brain with a subtle area of tug on the vein. But we are treating the artery here. Why are we treating the artery in chronic subdural hematoma to reach for lesser recurrence? We are not treating the vein. We are treating the complex hematoma formation. So what happens is when chronic subdural hematomas are formed with the complex inflammatory process, you have something called a membrane formation. So this particular membrane has neoangiogenesis, and these neoangiogenesis are not really perfectly formed vessel walls, and they have leaky vessels, and their fibrinolysis has local coagulopathy. So there are 3 things. One is neoangiogenesis with leaky capillaries and local coagulopathy. At any given time, if you look into a chronic subdural hematoma, you will have chronic subacute as well as fresh blood, meaning it is leaking, it's persistently leaking. I did my research on chronic subdural hematoma during my residency. I operated 100 plus cases, drain versus no drain. I think that era has gone now. So treatment goal is 2 goals. So as neurosurgeons, we want to decompress the brain And now we need to find a solution to prevent recurrence. So one is recurrence prevention, the other one is compression to be relieved from the brain. So in this picture, you can see chronic subdural hematoma of different grades. Despite operating, patients will have some degree of blood remaining because the brain doesn't come back up. And these patients have a higher chance. We thought that these patients are the ones who had higher chances of coagulopathy. So development of chronic subdural hematoma evacuation with associated endoscopic checking of vessels going in through the endoscope and coagulating all the veins did not change the way chronic subdural hematoma behaved. Recurrences persisted. They started infusing fluid, they started infusing post-operatively oxygen into the cavity, nothing worked. So then they evaluated the chronic subdural hematoma membranes. This is where the theory started. We are targeting the blood supply of the membrane, that is the middle meningeal artery. That is where a venous disease is treated with an arterial method. The primary target is middle meningeal artery, which is known to be supplying the membrane. So middle meningeal artery embolization can be used for many, many different treatments. What we are going to use this for is to prevent the hyperpermeable vessels to be supplied. And it is known, I'll go to the meta-analysis as well as some of the studies that they have done. With RCT studies, almost 95% of them have no resolution, no recurrences in the end. I think neurosurgeons would still work, I'm a neurosurgeon myself, still think that at 3 months, most of the chronic subdural hematomas might disappear. Is it what is happening? Have we done enough analysis on this? Yes, and we have. So I have just present 2 cases. I do not have the embolization images here, but this is a case where we had recurrence after chronic subdural hematoma evacuation in a patient who needed a cardiac surgery. She was on blood thinners. We could not stop it. That is when we called Dr. Arvind Nanda and we found a solution for that. And that's when we started middle meningeal artery embolization in the Maldives. So following which, I think the next image, if we can run it, it's not running, sorry. So the image below is a video which shows that chronic, it's not working. Yeah, it's moving to the one. So my message to everyone over here, maybe the juniors, there is no shortcut to just doing a middle meningeal artery embolization in treating a chronic subdural. Most of the time it is in adjuvant therapy. Maybe interventionists might not fully agree, but most of the time it is in adjuvant therapy. Very minute at times you can do primary interventions. That is when the surgical intervention part is not required. Surgical intervention part is not required. I'll give you a list of things when it's not required. So far in the Maldives, we only do for adjuvant treatment only. We want to stick to that until we have more further investigations done across it. So recent RCT, MAGIC MT and STEM trials, they have identified that they have significant reduction in the amount of chronic subdural recurrence as well as reoperation, close to almost 36% in the control group, which is without middle meningeal artery embolization, and as half of that to around 16% with adjuvant treatment. And the first one in the MAGIC trial, they only noticed that there was very less safety issues. So this is a safe procedure, and it is now known to decrease recurrence. So what we use in the Maldives is, this is a protocol which we came up with a group of our neurosurgery doctors from abroad as well as us. We only do middle meningeal artery embolization most of the time as an adjuvant therapy in high-risk patients who cannot be taken off blood thinners, patients who are on anticoagulants, platelet therapy, antiplatelets, hepatopathy causing coagulopathy, thrombocytopenia, or other forms of coagulopathy. And they will or should have neurological involvement as hemiparesis, facial palsy, or any form of neurological deficit. In those cases, you would need a borehole evacuation followed by MMA embolization. The only time when you would be able to do just primary middle meningeal artery embolization should have these things: coagulopathy, and you cannot take them off, the blood thinners, no associated neurological involvement in terms of hemiparesis, hemiplegia, or any form of facial palsy. They should not have major mass effect on the brain tissue or very minimal mass effect. And also they should have symptomatic chronic subdural hematoma. We could find someone who is found to be having an incidental chronic subdural hematoma. You don't do middle meningeal artery embolization in these patients. So it's an emerging technique. I think RCTs have been done. People have started doing, I would say, a lot of middle meningeal artery embolization in the last few months. Probably after 2024, they released their first trial, which said it was safe, and then in 2025 we have decided that we can go ahead and do middle meningeal artery embolization. So scientifically proven, but more research needs to be done to find the subgroup of patients who would definitely benefit. So it's a viable modality for treatment of selected patients. I would still say adjuvant is the key here. I would still permit myself only to do adjuvant therapy, not primary. Thank you very much.
That's a wonderful figure, but as a neurosurgeon, we all view of it in the systems that are CCH has been a part of our throughout our journey. And still, these patients, the subset of patients that you have chosen, do not exactly fall into the category where some adjuvant therapy was at all also needed. Because having no mass effect, only a subtle convexity, you are having synchronous development, you are trying to put a wire and you inside the, when you see primarily, as a neurosurgeon, we discuss a lot into this, but doesn't fit into the criteria because symptomatic progressive hematoma are the only patients who are getting benefited from the other surgeries. And who are those patients who are being benefited by doing this?
So I just mentioned the same thing. I think you miscalculated, sir. I have said we only advocate for adjuvant if there is mass effect, midline shift. And adjuvant therapy means we are doing borehole evacuation of the chronic subdural hematoma, but these patients have tendency to have recurrence, or they have tendency to have bleeding. In those patients only we follow adjuvant therapy. Primary therapy is for those patients who have symptomatic chronic subdural, meaning they have headaches, there's nausea, vomiting, but they should not have neurological deficit. The moment they have a neurological deficit, they go to the first one where they will have a borehole and plus minus adjuvant MMA embolization. So we are not doing for anyone who does not have neurological deficit.
Can I? Have you tried for this mini craniotomy any time? For membranotomy, more concerned about brains, I suppose. So you do a membranotomy, I suppose that will suffice your need.
Yes, of course, membranectomy can be done, but membranectomy also comes with a lot of complications, including seizures. There are two membranes. One membrane is on top of it's a visceral membrane, the other membrane is at the dural membrane. You can always go ahead and dissect the dural membrane, but if you go and dissect the visceral membrane, which is pachymeningeal, is right next to the parenchyma, then you have a higher chance of having seizure disorder. It's very much discouraged at present. Larger craniotomies, mini craniotomies, and evacuation of these membranes are discouraged at present. So I also feel that surgically, definitely, I am also pro-surgical in these cases. I would only do if they are at high risk of having recurrence, or when they come back with a recurrence on blood thinners where you cannot stop the blood thinners.
Can I?
Yes,
I
sir.
differ with you. I am dual trained. I am a surgeon as well as an interventionist. For last maybe 3 years, I have not operated upon a chronic subdural hematoma, even with a midline shift. It is very effective.
Okay.
I will say that if you look at the analysis of even with the surgical results, 30% mortality is in the chronic subdural hematoma after 60 years, not 80 years, because of the pneumocephalus, because of the recurrence. And when the more you try to intervene for the pneumocephalus or these drains or other things, the more infection it causes. So chronic subdural is not as benign as it is known to be. Kindly go to the literature. Surgery has 90-day outcome of 30% mortality. And chronic subdural hematoma from middle meningeal embolization has come out as a very, very elegant solution if done properly. Honestly, I have not done a burhole or craniotomy in last 3 years, maybe 15, 16 patients. The last patient I was just showing was 91 years old, which we could manage in the local. And it disappears or reduces in 2 weeks or less than 2 weeks. Of course, we don't discharge them till they are better. So I beg to differ with you that instead of a secondary therapy, in at least our centers it is becoming a primary therapy.
I agree with you, sir. Thank you very much.
मुझे लगा है नहीं उधर से
Thank you again, Arvind. So I try to make it short, and you had given me, or Atulab had given me the talk as past and future, and there is a huge amount of present in the middle, which is what I'm going to talk about. Okay, so this is the theory which I'm going to just run through, maybe even skip. And this is a disease which hasn't received as much attention as it should have over the years, but it can be dangerous. It can be very benign, and people can have a dural fistula without any symptoms, or they can have headaches, which can lead to seizures, confusion, bleeds, and it can be life-threatening as well. So it needs to be diagnosed early and treated. This is a very old slide of ours, maybe more than 20 years old. This is how you understand the fistula anywhere. This is, of course, on the dura, and you need to understand that what kind of fistula you're dealing with. Is it a single hole or multiple hole, single artery, single vein, multiple arteries, single vein, or it is multiple arteries and multiple veins, which basically means multiple dural fistulas. As I said before, it can cause a lot of trouble, and so unless very slow flow and completely asymptomatic, most of the dural fistulas do require treatment and aggressive treatment. Because just look at all the scans, some of the CTs and then MRs, which I'm going to show you, that if you don't treat them early and aggressively enough, then it may cause those calcium that you're seeing in the basal ganglia. It is because of the congestion which was not treated for the dural fistula, which causes a lot of vascular congestion in the brain. You look at this, there is edema, there can be hemorrhages. I think the next slide is going to show a large bleed because of the dural fistula. So you have to identify it, which can be only done by DSA, and the DSA pictures are often more horrendous than the scan pictures. So the fistulas which drain into, directly or indirectly, all kinds of cortical veins and causing congestion of the brain can be a very debilitating condition. Why? Because these are the normal veins. They just cannot drain out. They just stand there because there is a high flow dural fistula involving a sinus with complete reversal of flow. And so all the cortical veins late into the phase of the angiogram are stagnant because they cannot drain out effectively, which causes the congestion. In any dural fistula that we treat and then we see, we have to look for leptomeningeal drainage, either direct or eventual. So when there is cortical veins which are draining a dural fistula, it becomes a dangerous feature. We started doing this in the 90s, which was, we have to start everything somewhere. So in the 90s is what we started, definitely part of the past. It was only transarterial embolization. Mostly we started using PVA for this, and we did not get a cure. I remember that all those years ago, we just got one dural fistula which we embolized with PVA, and on follow-up it was completely gone. That doesn't happen, it didn't happen. Nevertheless, we have to do what we have to do. As in the previous talk I said that when we talk contemporary, this was contemporary in the 90s. And because of that, we have learned, we have continued to treat them, and where we reach now. We realized in the late 90s, for maybe the next 10 years or so, that to cure a dural fistula, you have to take the vein. By taking the vein, I mean occlude the vein. Unless you occlude the vein, you do not get a cure. That vein can be anything. That vein can be the primary leptomeningeal vein, which is a cortical vein, or it can be a sinus. It can be a sinus as important as transverse sinus, straight sinus. It can be vein of Galen and dural fistula. It can be straight sagittal sinus, and it can be cavernous sinus indeed. So it can be any vein as long as it has a high flow fistula. It needs occlusion, and that's where we get a cure. This is one of the early images of maybe in the 90s, I don't know the exact year, this might be 1997 or 1998, when we were working on a C-arm machine, and this shows a high flow dural fistula which is on the transverse sigmoid sinus. And the image on the right bottom is the post-embolization, and how did we achieve to cure it from the above image to the lower image. It looks like crying out for transarterial embo, but we did not have the material to cure this disease. So we used to go transvenous, and we used to put big coils, where those big coils in the early ages were made up of tungsten, marketed by Bolt, and then the GDC coils, the big GDC coils came through. So this is a very early image of a patient that we treated in the 90s with a cure, in spite of not having the actual proper material. Why? Because we understood back then that to have a cure means you have to occlude the vein. And as long as it is high flow fistula, it is completely safe. So based on this knowledge, we got the material which came in EVOH. We got the material of Onyx, available in India since 2004 and 2005 to now. This is what I mean by the present. 20 years, it's the mainstay of dural AVF embolization. It completely changed the picture. Why did it change the picture? Because it became predictable, it became safe. We always knew that the vein has to be occluded, and there was an easy way of occluding the vein by getting into the artery and using EVOH and Onyx we had available there. So the fistulas now had a very, very high cure rate, which of course earlier we did not have. So fistula may be direct leptomeningeal venous drainage fistula. It can be a high flow falcotentorial fistula, which is basically straight sinus and vein of Galen, or it can be a sequestered sinus with multiple veins draining out of it. Basically, you will and you should get a cure in dural AVF today. Look for dangerous features. And this is how we have gone transarterial, even today transvenous, even today burr hole, which is basically a way of getting into the sequestered sinus and direct puncture of the sequestered sinus. We don't require that today. But the coils can be used, but EVOH is absolutely the mainstay. We have onyx or we have squid. This is what is important about this talk. Get the vein. Safest transarterial axis, which is almost always the middle meningeal. And I'll show you plenty of cases with that. You can use the catheter of your choice. Our catheter of choice is headway duo in all the cases of dural AVFs through the middle meningeal. And we don't use detachable for the simple reason is that unless you use a 5 centimeter detachable catheter, the detachment zone of 2.5 or 3.5 centimeter is going to be a limitation. Because once your onyx is going forward and then it comes back up to the detachment zone without having cured the fistula or the vein, then you are supposed to detach it and take it out without curing it. That's why we use the headway duo catheter. And so far at least, touch wood, we don't have any breaking or fixation of the headway duo inside the onyx cast or squid cast. Pressure cooker is great, but we almost always don't use the pressure cooker technique unless it's in a scalp artery, like an occipital artery. RC balloon, I'm going to show you a case at the end. You must cure. You must cure and you must have angiographic cure. Middle meningeal, why? Is because we have the reflux. We can come all the way across the parietal horizontal course of the middle meningeal artery. Of course, you don't have to come down up to the foramen, spinosum, and most definitely watch for the collateral artery to the ophthalmic. So, you know, when you can have reflux, generally the horizontal part is the safe reflux. Do not come down below the vertical portion and towards near the foramen spinosum. That's where you will have the problems. You will see this. The huge artery over here is the occipital artery. So there is a tendency to use occipital artery to embolize this fistula. But that's wrong because you will get all the onyx. It will just come back on the occipital artery without curing it. The middle meningeal artery is so thready, so small, but the middle meningeal artery is the one that you will use. Again, you see it's a single tip catheter, so it's a headway duo, and you get there and you inject onyx and you get the vein, you totally get the angiographic cure. It can be done at all locations. So this is probably the easiest because it's already sequestered by means. It is occluded on both the sides. Generally, it happens on transverse sinus, which is occluded in the sigmoid and which is occluded towards the torcular. So where will it drain? It drains, unfortunately, through the plethora of the cortical veins and causing a lot of congestion of the brain venous system. And see, the artery that we chose here was the posterior meningeal artery. And through that, you can reach where you want to reach up to the site of the fistula, and then just be patient because as long as you're not limited by a detachable tip microcatheter, you will get the entire sinus that is sequestered anyway. So you see all of vascularities around the wall of the sinus, and you need to enter the sinus because it's sequestered. There is no way of protecting the sinus. You have to occlude it physically. Direct leptomeningeal venous drainage, you can see that on MR we don't understand anything much. You just see that the transverse sinus, maybe there's a jugular on the left side is not there. And unless you do a DSA, there is no real understanding of this dural fistula. And when you do the DSA, you understand that this is a direct leptomeningeal venous drain, which is causing all the havoc to the patient's brain. And again, you choose the artery of your choice, the artery which is going to get you closest to the vein, and then you have your EVOH, onyx, or squid, and get the cast like this. It is not just the arterial collaterals, it is the artery, the supply, as well as the vein. You must physically occlude the vein, Otherwise, it will get recruited from somewhere else. This is a post-embolization picture. Anterior cranial fossa, when we started doing dural AVF embolization, anterior cranial fossa dural AVFs was supposed to be a surgical disease. And of course, it is not. It can be extremely effectively treated by endovascular means. He had a very large venous aneurysm, which was the cause of the huge bleed. It's a beautiful CT scan, which shows the far anterior frontal lobe, where there is a filling defect in the clot, is actually the venous aneurysm, which is ruptured. And the culprit is the dural AV fistula, which is in the anterior cranial fossa. So you can decide, because there was a good access to the ophthalmic, we use that. But if you don't want to go through the ophthalmic, you can very well decide to come from the sagittal sinus right down up to the fistula, not just the aneurysm, that's a draining vein aneurysm. Come down where the fistula exists, and then you can inject what you have. We chose this artery, and we got the fistula like this through the ophthalmic artery right up to where the ethmoid is. And of course, we have to be distal from all the important branches of the ophthalmic and don't have a reflux so much backwards, and then get full cure. This is the cast that we got, the vein, the fistula, and the venous aneurysm. And when you get it, you see the artery in the midline is going to the fox, so from the ethmoid. And this was where the fistula lied. It was entirely inside the ethmoid sinus and the frontal skull base. Cavernous sinus is one of the commoner locations for a dural fistula. If you're lucky, like in this patient, there is a fistula which is diagnosed. If you're lucky, you will have a direct access transvenous through the inferior petrosal sinus, because this is not a transarterial embolization case. If not, then you must look at other parallel veins which can get you to the disease. She also had a fantastic facial vein through which you go to the facial vein, angular vein, and drive your microcatheter backwards towards the cavernous sinus. And again, as I said before, unless you occlude this part of the cavernous sinus, you're not going to get a cure. And so it is easy to do once you have an IPS, which is patent. Otherwise, you'll have to do the facial vein. And then you can use what you want. You can use coils. If you're using liquid embolic, be sure that you keep a balloon inside internal carotid artery, because liquid embolic can go into the small branches, and we have had at least one patient, bad complication of an artery of the cavernous sinus, cavernous ICA, going and embolizing into the MCA. Of course, today you can remove the onyx cast, but nevertheless, if you can avoid it by putting in the balloon, much better. Intraosseous fistulas, look at this patient. Now this is a horrendous looking scan, because it is a huge aneurysm which was reported as middle cerebral artery aneurysm, but of course we know by looking at the other veins that this is an AV fistula. So when you do the angio, the huge aneurysm is not where the fistula lay. The fistula is right here, which is posterior to the big temporal vein that we see on the scan. And you don't need to occlude that venous aneurysm. You need to occlude the fistula, and from there it is going all over the place to the brain, everywhere, congesting the brain, and of course causing him a lot of trouble. And this is where you must go, where the foot of the vein is, and occlude only that. So we managed to do that here with our favorite artery, middle meningeal, which led us right to the foot of the fistula. The selective injection is showing us that. And then you get your liquid embolic agent and inject slowly to get complete cure with the cast which looks like this. Stagnant veins everywhere, which is going from the venous aneurysm. There is no onyx in it. The venous aneurysm has contrast stagnation because it has zero flow coming in. So you've got the fistula. At the back you see like a howitzer gun, it looks like. The fistula and the foot of the vein. There is no reason for us to get into the venous aneurysm. This is the scan afterwards, which shows us that it was actually inside the bone, the petrous temporal bone fistula, and which was draining anteriorly into the big temporal vein with complete cure of the fistula. reduction in size of the aneurysm, and no edema. Needless to say, patient is doing extremely well. So this was a medical student. This is what dural fistulas can do. He was suffering from headaches, and he thought that every time the exam came, I'm getting headaches. But he got examined with a CT scan, which showed there is a thrombosis of the large thrombus in the transverse sinus, and there are other vessels which on MR which actually showed a dural fistula, but he was okay. So he waited for it, but he decided, luckily for him, he decided to come to us, got admitted. We did the angiogram, planned his treatment, and before we could intervene, I think later that day, he became unresponsive and unconscious. This was his angio. And so we waited for, I think, another 6 to 8 hours, and then we embolized him with the design of the embolization that we know. Before that, he was E2, M2, V2. A walking, talking medical student patient suddenly deteriorating, and that was because he had an underlying dural fistula. So we started all this, and we embolized his fistula after a few hours. Again, the artery of choice is middlemeningeal, go right over there, and then we embolized it, occluding his entire sick transverse sinus, which had the dural fistula. And this is what we have at the end. Don't get scared by all the veins, but make sure that to give anticoagulation at the end. Otherwise, if these veins occlude, he may get a venous infarct. So after you have treated the dural fistula, these patients need to be on anticoagulation, either injectable or warfarin. He, of course, made a dramatic recovery because his fistula was completely cured. This is one of the difficult locations for dural fistulas. It's right in the center of the brain because that's where the falcotentorial junction lies. And we know some of these patients do require stages because they may have a supply coming in from the dural branches of SCA as well as all the dural branches from middle and posterior meningeal arteries. Like this patient, you see that there is a dural branch which coming from the scar, which is also supplying. We tend to embolize them first before coming to the branches of the dura and getting absolutely here. We have attacked it at multiple levels after getting into the scar dural branches. This is coming from the middle meningeal, the other one is coming from posterior meningeal. So we attacked from both the ends of the fistula, and then we got complete cure of it by actually filling it up at the falcotentorial junction. Now SSS. SSS is right here. It's an important sinus. Can you occlude it? You can, provided that it's a high flow fistula. So the anterior SSS can drain itself and the posterior SSS can go to the tocula, and the anterior will go towards the cavernous sinus. And so there is no way of protecting this. This time we did not have the RC balloon which we have now. I'm going to show you the case at the end. And this is right the middle of the SSS, the sagittal sinus, which we have occluded. And the anterior SSS, as I said, it will drain through the cavernous sinus, and the posterior one will drain through the tocula. And just what was sick, we have occluded it with onyx. This is the follow-up, the scan showing where the onyx is, and 6 months control with complete cure and complete resolution of all the symptoms. So this is where, when we did not have the balloon which we now use, we had a much smaller balloon, but we knew that we had to keep the tocula patent. So we went with a smaller balloon, which is of course useless. At the same time, because of this balloon, in spite of getting a lot of onyx into the sinus, we have had both the transverse sigmoid patent at the end. And this we could manage with a smaller balloon, which was I think 6 mm or something in size. But now we of course have the RC balloon. What is RC? Who knows what RC is? RC stands for René Chapeau. So, you know, he was the one who actually designed this balloon, and we use this for the sinus preservation. This is the last case where we knew that we had to save the sinus. Even though the sigmoid is not there, it is better to save the sinus. It can still drain towards the tocula and then towards the other side. So we went from the transvenous From the contralateral side, we went into the fistula, inflated the big balloon, got into the middle meningeal artery, and embolized it completely. This is the balloon in place with embolization at the end, with especially the vein of Labbé, and all the afferent veins are fully patent. And this is at the end, this is what we have. Antegrade venous drainage from a sinus which we haven't occluded because of the balloon protection. So this is some of the cases which I showed, and this is from, we started out from PV embolization back in the 90s, and now of course we use liquid embolic, not too many coils, and we have this big balloon now, so we don't occlude too many sinuses. In our life we have occluded plenty of transverse sinuses and big sinuses without any clinical sequel or event. I thank you for your attention. No, no problem.
Next year,
video.
Thank you very much, sir. Now I call on Manish.
I think my entire CCF talk has partly already been given by Dr. Uday. Basic concepts remain the same because carotico-cavernous fistula is basically a dural fistula in the cavernous sinus, nothing else. So, video. So basically carotico-cavernous fistula. So basically it's a communication between the carotid arteries and the cavernous sinus. This is the kind of anatomy you see if you open up the cavernous sinus. Most of the symptoms of CCF are usually due to pressure changes in the cavernous sinus, and this is the anatomy where you can see all the sinuses on the veins which are communicating with the inferiorly. You can see the superior IJV, and then you can see the superior petrosal sinus, inferior petrosal sinus, sphenoid sinus, sphenoid petrosal vein, and pterygoid venous plexus, and internal ophthalmic vein, and superior ophthalmic, inferior ophthalmic vein, and superior ophthalmic vein. And in the middle you can see the intercavernous sinus, and posteriorly down you can see the basilar venous plexus. So this is, if there is any communication, and in between the red thing which you are seeing, that is the carotid artery. So if any communication between this carotid or any of the small dural branches of the carotid gets in communication with this venous plexus directly, that leads to the formation of that carotico-cavernous fistula. This is the venous picture. What we see, that was an animation kind of thing, and this is the original what we see on the venous angiogram. If we see, you can see all the draining veins. And so what are the basic clinical symptoms? Most of the time what we see in a carotico-cavernous fistula is exophthalmos, which may be pulsatile or non-pulsatile depending on the high flow or low flow of the fistula. The next is chemosis and proptosis, and progressive visual loss if there is too much prolonged proptosis of the pulsatile tinnitus. That happens, these symptoms come when the carotico-cavernous fistula is draining posteriorly into the IJV or directly via the superior petrosal sinus. It can also lead to subarachnoid hemorrhage or ICH. Again, it all depends on whether there is some cortical reflux, which may lead to the such kind of features of raised ICP, and cranial nerve palsies, which are the cranial nerve 3rd, 4th, and 6th, which are in the lateral part of the cavernous sinus. Now, there is one Dandy's triad which is there, which is a triad of exophthalmos, Broe, and conjunctival chemosis, which is basically the mainstay of all the. So this is the angiographic classification, which is called as the Barrow classification in A, which is direct shunt between the internal carotid artery as well as into the cavernous sinus. This usually happens after a trauma. Most of the time it's a traumatic fistula. In B, the B classification, where there is indirect shunts arising from the meningeal branches of the internal carotid artery which are draining into the cavernous sinus. Type C is there, in which there is meningeal branches of the external carotid artery draining into the cavernous sinus, and type D where there are indirect shunts both from the ICA as well as the ECA into the cavernous sinus. Etiology most common for direct fistulas is the traumatic, and spontaneous usually happens for small indirect fistulas. And hemodynamic effects basically means what kind of fistula we are having, whether it's a very high flow fistula or a slow flow fistula or an intermediate flow fistula. So these are the basic investigations where DSA becomes the mainstay. So the CT, MR and DSA became. For DSA we need to do, whether it's a direct or indirect, size and location of the rent and number of fistula, hemodynamic effect, whether it's a high flow fistula or slow flow fistula or an intermediate kind, any associated aneurysm, feeding artery or an venous aneurysm, and collateral flow. How is the collateral flow is there, because we need to do a cross compression studies also in case we need to compromise the main internal carotid artery, especially in case of direct traumatic fistulas. And we also need to know the cortical venous reflux and balloon test occlusion or cross compression views, which we need to take during the angiogram. So these three maneuvers are also important when we are doing a DSA angiogram for the evaluation of a carotid cavernous fistula, that is Mehringer-Hayshima maneuver, where slow injection of the ipsilateral ICA and simultaneous manual compression of the ipsilateral CCA to reduce flow in the fistula. Second is Hubner maneuver, which is injection of the dominant vertebral artery and simultaneous manual compression on the ipsilateral CCA, which leads to retrograde filling of the fistula, and exactly we can pinpoint the rent, because via the PCOM the flow goes, the blood goes into the fistula. So we can see exactly where the fistula is there in the ICA, direct rent in the ICA. So the third maneuver is Alcock or Matas maneuver, where injection of the contralateral ICA with simultaneous manual compression or ipsilateral CCA. This is the similar thing, but you can see the filling of the rent, you can see the rent via the ACOM. So treatment are usually, the first treatment of CCS which I saw was using balloon, that was Nycomed. Now I don't know how many people might have, I think Dr. Karapurkar must have used balloons for that. And I haven't myself personally used, sir. I don't. You use. Nycomed gold wall balloons were used to come. Now I don't think we have them. Oh. So basically now the basic for direct CCA, that is the direct rent between the internal carotid artery and the cavernous sinus. Coiling of the cavernous sinus with detachable coils and balloons were also used to come. Liquid embolic agent always should be used with a balloon. Coils and detachable balloons and parent vessel occlusion should be one option. And now there is one stent graft, that is, some people have also used a stent graft placement for the same. That is kind of a float for the fistula. So for indirect CCS we can use transvenous embolization and transarterial embolization. Transvenous embolization we can use either drilling via the IPS. If the IPS is not visible, then you can also drill the IPS using microcatheter, and via anterior approach, as explained by Dr. Uday also, you can use a facial vein and the superior ophthalmic vein. Now I'll show a few cases. So 33-year-old male, had a history of trauma 1 month back, presented with right eye swelling with proptosis and chemosis. So this is the AP view. You can see a direct fistula from the carotid right ICA, and on the lateral view you can see, yeah, this is the entire drainage is anteriorly into the superior ophthalmic vein and the inferior ophthalmic vein, causing congestion of the entire orbit and venous plexus. Video. This is one of the most important thing which you need to do for a carotid cavernous fistula. You need to, especially for a direct, if you have a very small rent, you need to pinpoint the rent where exactly the rent is originating. So once you do it, then you can reconstruct it using a thin section. You can see, you can exactly pinpoint the rent. If you can see there, we have pinpointed the rent, and this is the point of rent from where the microcatheter and wire is going inside. That is the small rent, which is opening into a large venous pouch in that thing. Another video. So you go through that pouch, enter the, now we have entered the pouch, and you can see there is some stasis because the small rent is there, but which is directly opening. So we have already a microcatheter inside. So we start coiling that, and we usually start coiling from the proximal end to distal end. First we go and coil towards the superior ophthalmic vein, close it, occlude it, and then we come back proximally. So these are the next videos. So this is after the completion of the complete occlusion. There you can still see some filling of the superior ophthalmic vein, but this is not a direct filling of the superior ophthalmic vein from the fistula. This is coming at the same time when the rest of the venous structures are coming. So you do not worry about that. The fistula is almost completely occluded. So another case, 19-year-old female presented with headache and pain in the right orbital region with gradually slowly progressive proptosis and chemosis. Video. This is a kind of indirect fistula seen arising from the meningeal branches of the external carotid artery. You can see this filling of this. This is basically not a very high flow, but an intermediate flow fistula. There was no direct rent into the from the ICA. Minimal filling or minimal slow filling was seen from the indirect branches of the dural branches of the ICA also. But predominantly it was via the external carotid artery branches. So we went inside, tried to reach as close as to the fistula as possible, and close to the nidus, and then this is the angiogram. When we go inside, we are almost at the entry of the. So in this thing we used glue, NBCA. You can see how the glue is circulating into that venous pouch, and gradually it is spreading all everywhere. So, and if this glue is occluding the venous outflow and there is too much of turbulence there, you can get a very good result immediately after using this. So even after doing this, the entire thing is gone. And we didn't see any filling from the ICAs also. So another case, 70-year-old female, swelling of the left eye with proptosis and chemosis, which is gradually increasing over the last 2 to 3 months. Another patient. You can see in the from the left ICA, you can see a direct rent. This is from the external, no filling from the external. Here you can see the 3D. Here you can exactly pinpoint what exactly is the rent. Please play again. Yeah. You can see there is a small outpouching initially, and then the entire fistula is filling. So we went inside, had a look at the fistula, went inside the fistula. This was the venous pouch which was there. So we went ahead. Just placed, I thought that maybe I'll go inside, place one coil there, didn't detach it, just place it there and see how it goes. So we placed one coil, did significant reduction, so it made me realize, and plus I had already calculated the same on 3D, that I need not pack the entire CCF with, so I just placed one coil, and thereafter I had put one more coil there, and the entire fistula was gone. Yeah. Again, video please. Yeah, you can see the entire direct fistula is gone. There is no filling of the cavernous sinus pouch or anything. So this is also very important, that you need to realize your anatomy, what exactly the anatomy of the venous system is there in the cavernous sinus. If you have a small outpouching which is further draining into the cavernous sinus, you just need to occlude that outpouching and the entire thing will be gone. So another case, 56-year-old female complaint of headache for the past 4 months, initially limited to right hemicranium and later started to be of diffuse nature. Patient later developed swelling around eyelids from the past 4 months associated with diplopia and redness in both eyes. Video please. Video. Now this is an indirect kind of thing which you can see filling from the ICS. Again, left ICA, you can see it is taking from both the meningeal branches of both the ICAs. Now, these are the kind of aneurysms, if they don't have any external carotid thing, they can become sometimes very tricky. In those cases, you might have to come via external carotid, via venous side. So, you see it? Yeah. This is the ECA angiogram. Now here you can see. Here you can see what is the extent of the collaterals which you can see from the external carotid. You see complete filling of the extensive filling of the cavernous sinus along with the via the intercavernous sinus. It is also causing proptosis and chemosis of the opposite side. So here in this thing, because we did not have any direct rent, and IPS was also not there, so we drilled via the IPS from the right side, went inside, first occluded from the first place few coils in the superior ophthalmic vein on the right side, then went via the intercavernous sinus into the opposite side, and then occluded that, and finally came out and occluded the entire fistula. Run please. So this is the final. There was still some filling was there. This was immediately probably got completely occluded thereafter. So this is the final ICA angiogram. The collaterals via ICA are also occluded. So you can see now there is no filling of the CCF. Mild stasis of contrast was seen in the coiled mass. So this is almost, this we had done using the ipsilateral approach, where first we went from the ipsilateral inferior petrosal sinus, drilling the inferior petrosal sinus into the cavernous sinus, and then via first doing one cavernous sinus on one side, thereafter we went via the intercavernous sinus to the opposite side, and thereafter we did occlude this. So basically, what is very important in treating the CCS, that we should be knowing our neuroanatomy very well. Basically, our dangerous anastomosis, especially in cases of direct fistulas, and also very important thing is to acquire 3D rotational angio in direct CCF, because you need to evaluate the rent very nicely, because if you are not able to localize the rent, then doing it on a 2D simple thing sometimes may become very complicated. Now venous or arterial if feasible. Now an IPS and you need to know and you need to learn how to drill the IPS. In most of the cases, because of the venous angiopathy, the IPS may be occluded. So you need to see how you can reach into the IPS and drill the IPS and reach the cavernous sinus. Thereafter you will be able to do your case. Thank you.
Thank you very much. Now we go to the next session, and I invite Dr. Vinny Fowler to take forward
the last session. Thank you.
Thank you. Good evening, everyone. So, I think this session is the second last session of the day, and it's the second last thing to be standing between you and the drink break that you all need. So, I would like to call the chairperson of the session, Dr. Justin Thomas, consultant interventional neurologist at Apollo City Hospital, Dural, and Dr. Vikas Gupta, sir. Vikas Gupta, sir, maximum introduction.
Good evening, everyone. At the outset, I would like to thank Dr. Atula sir and Dr. Nanda sir for inviting me. And I will not take much time. This is a very important topic, condition where we encounter in our day-to-day practice, especially a mimicker of LETM, longitudinal extensive transverse myelitis, which we get routinely in our neurological OPDs and inpatients. So, slide not moving. Yeah. This is the overview of my talk. And as we all know, spinal dural AV fistula, these are the most common spinal vascular malformations, accounting for about 70% of all the malformations. The basic pathology is the abnormal communication between the spinal dural artery and the vein. And typically, these fistulas are located at the nerve root dural sleeves. And many theories suggest that the site of fistula is probably the glomerulus of Menelfe, which is a specialized vascular structure physiologically present between the two dural layers consisting of two or more arterioles, similar to renal system, two or more arterioles converging with a glomeruloid capillary ball and believed to be involved in regulating the hydrovenous pressure. So this is the probable site of dural AV fistula formation in the spine. And important is what typically defines the symptomatology is not the site of the fistula, but the extent of the venous congestion and the venous mode of drainage. As we all know, Anson and Spetzler have classified this spinal vascular malformation as arteriovenous fistulas and arteriovenous malformations. Regarding arteriovenous fistula, it may be intradural or extradural. When in the intradural, we have dorsal type and the ventral type. Dorsal type means whatever I'm going to talk, that is the spinal dural AV fistula. The ventral type are generally the perimedullary fistulas. Either it is type A, type B, or type C. This is the typical location of these fistulas. As we all know, this is an acquired condition typically seen in elderly male who presents with slowly progressive paraparesis, then sensory symptoms, then later on in getting bladder and bowel involved. And it's acquired etiology, and most of these fistulas are found in the dorsal region between the D5 and D11 areas, and some of the chunk of the fistulas are also found in the sacral areas. That's very, very important because any angiogram is incomplete if you don't look at the internal iliac arteries at the end of the angiogram before calling it as negative. Briefly about the vascular blood supply of the spinal dural malformation with respect to that. As we all know, the segmental arteries which arise at all levels directly from the aorta, it continues and divides into a middle branch known as which supplies the muscles and the cutaneous system, that is a musculocutaneous branch, and which continues as a posterior intercostal artery. And from the muscular branch, there arises a spinal branch. In this picture, you can see very well. I think a pointer, I will make a pointer. Yeah. So this is the spinal branch. The spinal branch, which is radiculodural artery, in addition to serving the nerve root and the dura at some places, they contribute to the supply of the anterospinal artery known as radiculomedullary artery. Similarly, if it contributes to the supply of the posterior spinal artery, we call it as radiculopial arteries. In this image, you can see this is a segmental artery, and this segmental artery has given a muscular branch, and from the muscular branch in this particular segmental artery injection, there is a contribution to the anterospinal artery in the form of hairpin bend. This is the classical appearance of artery of Adamkiewicz, which is contributing to the supply of the anterospinal artery, and this is the muscular branch, and this segmental artery continuing as the posterior intercostal artery. And regarding fistula, how it is seen? This is the segmental artery injection. You can see it is continuing as a posterior intercostal artery. This is the muscular branch, but where here you can see a fistula, and it is draining into a hook-shaped vein known as radicular vein or a bridging vein. This bridging vein is the one which connects the intradural and extradural venous system. Physiologically, this bridging vein drains all the venous supply from the spinal cord and drains into the epidural venous plexus. In the fistula, you can see here, the radicular vein is arterialized, and instead of draining centrifugally, now the supply becomes centripetal, and then all the arterialized blood is refluxing back into the spinal epidural veins, longitudinal perimedullary venous plexus, resulting in venous congestion and arterialization of these veins. This is a normal anatomical picture which I have taken from the neuroangio.org. In the early stages, this centrifugal flow is still patent and preserved, and the patient is typically asymptomatic. As this fistula matures and then starts reflexing into the perimedullary venous plexus, then the symptom starts in the early stage. And this is the stage at which we have to identify the symptoms, diagnose and cure them so that most of them recover. But unfortunately, many of our patients come in the later phase because of the invariable delay at the level of diagnosis and imaging. And in the later stages, what happens is because of the venopathy associated occlusions of these perimedullary veins, most of them get occluded, and very few valuable veins will be left over to drain the spinal cord when we embolize this, and we do not see a good improvement in the symptomatology when we treat them later on. So we have to catch them very early and treat them very early. How do we catch them? As we all know, nearly 1/4 of the cases of spinal dural AV fistula are often missed or misdiagnosed. And on the imaging, if we miss them, most of the time they don't come to the treatment part at all. It is mandatory that in all LETM cases, when you are looking at, especially in the elderly males, slowly progressive, always see that your imaging protocol is adequate or not to diagnose them. Always look for the T2 vascular flow voids, which may be very, very subtle. See for the cord signal intensity changes. How are they? They are predominantly central, sparing the rim of normal parenchyma all around it. Sometimes in a long-standing cases, because of iron deposition, they may bloom also. And characteristic enhancement pattern known as missing piece enhancement pattern, because most of the LETM cases we do give contrast to characterize them. That time we get a characteristic missing piece enhancement. When we see all these things, you need to include a specialized sequences, especially the tricks, which I will be showing you. And another important sequence for all LETM is heavily titubated images, either called as CIS-3D or Fiesta based on vendor to vendor. Then when you confirm the diagnosis, then patient will go for the gold standard, that is catheter spinal angiography. This is what I was telling you. If you see here, this is the titubated images. The flow voids may be very subtle in it, normal spin echo sequences, but if you include a heavily titubated images, these flow voids will be very, very obvious and very glaring. In the post-contrast images also, these vascular flow voids are very easily identified. Sometimes due to venous congestion, the enhancement may be sometimes very scary like this, like a tumor-like enhancement, pseudo-tumor-like enhancement, and do not get biased, because you may tendency to call them as tumors is very high if it is untrained. In combination with these vascular flow voids and this type of solid homogeneous enhancement in post-contrast is very characteristic, and more characteristic is the missing piece enhancement. This contrast study gives a clue in many cases. Spinal dural AV fistula have a characteristic enhancement pattern where there are areas of normal and abnormal enhancement known as missing piece enhancement. This basically happens when, because we all know that venous system, intrinsic venous drainage system of the cord is very variable. Those which are spared or non-enhancing is the one which is normally egressing, that is physiologically draining out. Those which are involved in the fistula are the one which enhances because of the chronic venous congestion, because of variability in the intrinsic venous system in the spine. So if you see this is pathognomonic of spinal dural AV fistula. And there are so many vendors in the MRI, including even in the 1.5 Tesla, where you can acquire you can give a contrast and acquire a DSA-like picture, that is time-resolved imaging contrast kinetic MRA, where it will be very helpful because doing a spinal angio is a painful procedure. It takes lot of time, lot of contrast also. If you can localize and get an idea probably from where the fistulas are coming, yeah, you can make a mental picture that I should look into this area where MRI was showing. So this is very, very helpful. Though MRA, CTR do not contribute, ultimately it is the DSA which helps us, including 3D. But these all modalities give us and help us to save a lot of time and contrast. So catheter angiography with 3D is the gold standard. Preferably do it under general anesthesia with intermittent apnea and a low frame rate. And you should at least acquire for at least 4 seconds to exclude delayed retrograde filling of the radicular veins. Always look for the sacral arteries, intracranial and neck arteries before calling it as negative study. Okay, always acquire a 3D when you get a fistula. Always demonstrate where is the anterospinal artery coming from and whether are you sharing is the fistula sharing the anterospinal artery blood supply, because that may be a relatively very contraindication. You may not go for endovascular, may opt for surgical procedure. So these are the different catheters. Personally, I use C2 Cobra catheter or SIM1 or left coronary LC catheters generally. And these are if you know the anatomy also, you should know from where the segmental arteries are coming, because this is a blind procedure. We have to hook these arteries in a blind way. So if you know at upper dorsal or the thoracolumbar area and the lower lumbar area where you have to hook, you will have an idea. So you can hook it fast. Otherwise, it will take a lot of time to do a spinal angiography. Nowadays, because of advanced cath lab availability, CBCT is very, very useful in diagnosis, planning and treatment guidance for this spinal dural AV fistula. Excellent 3D delineation of micro anatomical features like shunt point, where the venous outflow. This is because of superior spatial and contrast resolution. This should always be included whenever the facility is available. It can give such a beautiful pictures and you can plan your procedure very well. Ultimately, coming to the treatment, the goal of the treatment is elimination of the fistula related venous congestion, allowing cord veins to become the sole user of whatever venous drainage routes remain. Cure requires selective closure of the proximal, that foot end of the draining vein, either by surgical division or endovascular occlusion, usually with a liquid embolic agent. And this liquid embolic agent should not be refluxing back into the intrinsic venous system. You should just restrict them to the fistula and the foot end of the radicular vein. And generally, the gold standard is to use a 20 to 30% NBCA, and it is contraindicated endovascular when it is when artery of Adamkiewicz is arising very close to the fistula point. Then we may reflux and lose the anterospinal artery. So you should be very careful in those cases. And prognosis. Neurological recovery depends on the preoperative neurological function. Motor and gait dysfunction recover in a significant number of patients. Sensory also recovers, but bladder and bowel dysfunction recovery or the sphincter related recovery are very poor. Pain also may persist in many cases. Maximum improvement may be seen by the end of 6 months. So for embolization, the same catheter which we use for diagnostic can be used, and generally we use microcatheters like Marathon or a Magic, which I commonly use, either 1.5 or 1.2, and then use over 008 wire. So it will be very easy. Under GA with apnea, we can take a good injection and then cannulate them. I will show you a few cases. I generally use 20 to 30% of glue in all my cases. This was an elderly male, progressive weakness of left lower limb for 1 year almost, numbness in bilateral distal limbs, urinary bladder urgency, reduced stream. All these symptoms started, and the power was 3/5, sensory level was at D12 level. And the patient came. This was the LATM-like picture with the subtle flow voids, which was picked up and then referred promptly. When we did an angiogram, you can see this is the catheter, this is the segmental artery, posterior intercostal artery, the muscular branch, this is the fistula. You can identify this characteristic hook-shaped vein, that is a radicular vein, which is reflexing back into the perimedullary vein. This is the pre-procedure planning, this is a 3D. So we know that the fistula is coming from here. We have to take care of this fistula as well as the foot end of this radicular vein. This was the plan. Then we selectively cannulated with a Magic 1.5 catheter and injected the glue. You can see this glue cast taking care of the feeder, fistula, and the foot. This part of the radicular vein. This should never reflux into the radiculomedullary veins because these are required for the venous drainage of the spinal cord. And this is a check angiography showing the embolization, complete embolization. This was also a very interesting case, but this was imaging picture was typical for spinal dural AV fistula, but it was not a spinal dural AV fistula. We had a big pouch in the epidural space. It is a epidural arteriovenous fistula, which is a type of fistula which is generally seen outside the dura and forms generally a venous pouch. But pathophysiology and the symptomatology is similar to spinal dural AV fistula. When we did, by this picture we went as a spinal dural AV fistula. When we hooked and saw, there was a feeder which was going into the venous pouch, and from the venous pouch it was reflexing into radicular veins and into the perimedullary veins. This is the planning of the procedure. You can see hooking and then the venous pouch. From the venous pouch, the radicular vein was getting reflexed into the perimedullary veins. So that's why the card symptom, card edema and the abnormal flow voids were seen. And this is the post-glue embolization. You can see that venous pouch, nidus and the venous pouch was embolized. So another case, several times this case underwent diagnostic angio, spinal angio, consistently reported as negative, because every time when they did a spinal angio, they did not do an angiogram of internal iliac arteries. When we did an internal iliac artery selective injections of right and left, we could see a lateral sacral artery coming and giving a fistula in the sacral region, which was draining up, causing a congestion and myelopathy in the dorsal region. So that's why the spinal angiograms, incomplete spinal angiograms are very disastrous, because it will prolong the diagnosis and treatment, resulting in poor outcome in these patients. Never ever complete your spinal angiogram without completing the iliac neck and the external and internal carotid artery injections. So to conclude, spinal dural AV fistulas present with typical clinical and imaging features. Identification is very crucial in imaging. Appropriate imaging sequences are very, very important. A high quality complete spinal DSA is key to the diagnosis. Always do a 3D DSA under general anesthesia, which is a gold standard for diagnosis and planning. Please study the images, plan the procedure and then proceed. Embolization is preferred treatment except in patients with where there is a shared anatomy. The fistula as well as the spinal cord blood supply is shared. Then promptly referring to the neurosurgical colleagues is very, very important and key for the successful treatment. Thank you so much. Yes. Thank you, sir. Thank you.
So this is going to be a complicated part of the day when everybody is tired. I'll see how I can simplify it. I'm going to put a timer on. Okay. Thank you. So my colleague has already done most of the talking. Can I have the main one, not the same? The slides have to be, just do the, remove the format. Just go play. All right. Can you not make the big? No. Huh? Don't want presenter notes. I don't want the next slide. Okay. Okay, thank you. So I'm going to talk on vascular malformations. My colleague has already spoken a lot about things, so hopefully this should be a little bit simpler. He mentioned about the anatomy, and I think spinal vessels form a grade, and you have an anterior spinal artery which is along the anterior ventral median fissure, which is, remember, it's very important to know about the location, because sometimes the fistulas with anterior spinal artery, which are rare, can be difficult to see. And then you have two posterior spinal arteries. So this is from the textbooks where you can see, you are seeing the anterior spinal artery, you're going to arch, you got all these segmental intercostal arteries, and you're going to get some radicular arteries that feed, some of them will feed into the anterior spinal artery. And then obviously you get a feeders from the top, you have the iliacs, and you have the median sacral arteries. And again, when you do an angiogram, you have to know that you want an angiogram, then understand that there are supply coming from external, there is supply coming from vertebral, costocervical, thyrocervical, you need the thoracic, then you need the lumbar, you need to get lateral sacral, iliolumbar, and I've really seen fistulas from all over these places. So it gets missed and missed, so you have to do it. If you see somebody with an MR positive and you don't get an angiogram right and you don't see the fistula, repeat it. If you can't repeat it, ask your colleague to do it. Sometimes it's very easy, and it is very easy to miss, and we all miss it. And here you can see like the vertebral artery, you can see all these vessels, you can see the anterior spinal artery coming in, and then you can see the supply can come from various different levels, as my previous colleague already has talked about it. He showed very nice pictures why you need to do your iliacs also. You have to look at the median sacral artery, because even they can cause trouble here, as you can see here. And you can always do both the iliacs, both the iliolumbars to understand and to get the anatomy right. When you go to Pierre's books, you know how the radicular arteries are formed. You usually have radicular arteries at multiple levels. They start getting fused, and then some of them will join in the midline to form the anterior spinal artery. Some of them will just stay stunted. Some of them will form the posterior spinal artery. And you can get various anatomical variants because of that. What you have to remember that usually the radicular arteries are climbing up because of the cord and the spine grows. And that's why you will always see some of them reaching up to the cord. Some of them will form the radicular PL arteries, and some will form the radicular medullary arteries, and we'll come to that. This has already again been described earlier. You got to say intercostal artery is going to give a dorsal spinal artery. Some of this supply will go to the cord, and then you have the intercostal artery. This intercostal artery will then give some supply to the posterior elements. Again, you can see there is a spinal artery coming in. So, you are going to get multiple feeders, and when you do the angiogram, you have to remember what you are seeing and able to differentiate it. So, when you see this artery here, intercostal artery here, you got a dorsal spinal branch. You can see it's giving some supply to the back of the vertebral body. That's why you see this hexagonal appearance, and I'll show you in the next slide that you can see this supply. So you can differentiate what's external carotid, what's dural supply, what's supply to the cords, what's supply to the bone marrow, and then obviously they all can get connected. So sometimes it can get very tricky when you are doing these angiograms, but this is just one of our illustrator guys had done this. And you can see again the intercostal artery taking the turn. You get a feeders to the dura behind, you get this hexagonal blood supply, and then you get some feeders into the posterior elements, intercostal supply. And as again this was shown very nicely, here you can see all the epidural supply coming in. It's all supplying to the dura posteriorly, and you can see the hexagonal supply when you got a very vascular tumor here. And you can see the supply to the back of the vertebral body. So technically it's very important within all this to identify the anterior spinal and posterior spinal. The reason is because sometimes when you embolize tumors like this and you don't see the posterior spinal, as you start embolizing, I don't know how many of you have seen this, you start embolizing it, and in the middle of the procedure suddenly you start seeing the radicular artery, and then you know what's going on and you are worried about it, and it does happen, and you have to be very, very careful. What I do in my practice, once I do the spinal angiogram, I take my gloves off, I go in the back of the room, I look at all of the imaging again myself. I don't see it while I'm doing it, I will do it, I'll go back, and I think it's a very important lesson. I've seen people missing it, because when you're doing the angiogram, you don't see it. I always will take my gloves off, I will always go through the whole angiogram again to be very sure that I am not missing anterior spinal or posterior spinal. Here you can see again, you can see the supply, and you can see there is an AVM here, and it's so easy. Your vessel can come from anterior dorsoscapular, you can see cervicothoracic, and you can see that from multiple levels. Here you can see the anterior spinal coming in here, and here you can see there is a supply coming here, again supplying the AVM here. This has been covered earlier. How do you differentiate between radiculomedullary and radiculoPL artery? And I'm going through anatomy because this is the most important part of it. You know, your radicular artery will form, medullary artery will form the anterior spinal, whereas the PL artery will form the posterior spinal. And again, you will see the hairpin appearance. It's in the midline, whereas this is on the side of the anterior spinal artery. Has been again typical what you see here. And then you can see the radiculomedullary arteries and the radiculoPL arteries that are supplying the posterior spinal artery, whereas here this is the anterior spinal artery. Anyway, again, same posterior spinal artery. If you look try and look at the plane films and the angiograms, and you can clearly make sure you are very straight, and you will be able to see the anterior and the posterior spinal artery. So here you can see it's much more acute angle, and you know this is the PSA, and if you see that, this is kind of on the side of it, so it's not an anterior spinal artery. Sometimes it's very difficult to get a lateral, so you really have to be very clear about whether this is anterior or posterior. What is important again is the posterior spinal artery supplies the 1/3 of the cord, whereas the anterior spinal artery supplies the 2/3 of the cord. Also is very important. When I was a trainee, Pierre used to tell us anterior spinal artery is a subPL artery, and it's very important. And that's why if you have a fistula from the anterior spinal artery, unless you do an angiogram, it's very hard. You may not even see collaterals. Okay? So you don't see collaterals if you got a direct fistula from the anterior spinal artery. And that is because it's a subPL artery. I've only seen one case in my 20 years of career, one fistula from the anterior spinal artery. When you look at all the spinal axis, don't forget to look at the basket here. It's very important because when you see the basket, what is the relevance? Anything below that, there is no gray matter. You can embolize it. So it's very useful to know where the basket is. And again, the basket, as you can see, this is the anterior spinal artery, and then you are seeing both the posterior spinal arteries. Every time you think about the arterial side, don't forget to talk about the veins, because the veins are equally important, and today we know we do a more and more venous approach, and here you can see the veins then draining in. As you can see, the veins from the anterior and the posterior part of the cord, and then you can see the venous drainage. Again, it's important because if you got a fistula, you got no valves, and that's why you will get reflux, and that's why you get an edema in the cord. This was earlier covered, but I'll briefly mention. When you look at spinal vascular malformation, there are different types of classification. You can look at genetic, you can get genetic somatic, and you can get focal. What we follow, and my previous colleague mentioned, is what we talk about type 1 to type 4. Type 1 is the spinal dural fistula, which has already been covered, so I probably will go for type 2, which is the AVM, and then we have the type 3 and type 4, and I'll show you some examples of each. So spinal dural fistula was covered by my colleague here, and it's obviously one thing is these patients are all quite old generally, but I have seen in younger people, but usually they're older people, they got progressive myelopathy, they often get missed, and they get diagnosed for vascular problems, and somebody then recognizes the fistula on the MR. Here is the picture that you see, and usually it's there just below the foramen, and this has already been shown, and he's already discussed that. Here, quite often, you can see the fistula, and what you want is to get the fistula and to get the vein, and it's very important. And you want to disconnect it. Very important, if you look at the literature, success to treat a dural fistula type 1 in endovascular is around 20%. Okay? 80% of the time, very likely, you will fail. Surgery is still a very good option. So if you are struggling, I would just put some coils in the intercostal artery and pass it to surgery. Surgery is a very good treatment option for spinal dural fistulas type 1. So here it is, and I'm going to skip all this. Sorry, yeah. So the next one is obviously the type 2, which is the AVM. Now, AVM, you could get supply from the arterial side, or you can get a supply from the venous side. As you can see here, you have the arterial supply, or you can get the venous supply, from arterial supply from the anterior spinal or the posterior spinal artery. Usually they are male, usually they are younger people, and I've seen so many of them, most of them are very young, and they often may present with either myelopathy, they can get a bleed because of the AVM, or because of the aneurysm, or because of the mass effect, or because of the edema. They can be associated with some syndromes. Quite often you will see a subarachnoid hemorrhage, so you've got to think about cord when you can't see intracranial. You might see on MR, you might see flow voids, it looks like a typical AVM, and you may need to embolize depending on the location, but it's always a tricky option. Here is a lady I treated, she had this spinal AVM. As you can see, she had a nasty AVM, she had bled, and what I did was I went at multiple times into this, and usually the anterior spinal artery gives her a sulcocommissural branch, which is what you are seeing. And multiple times I went in, maybe about 7-8 sessions to reduce this fistula. And I believe that this lady has recovered and the whole AVM is gone. But literally I must have done 8 or 10 sessions. Drop of glue, 50%, and come in and out. So you can get, this is one of the HSTs. Again, you can see this is a AVM that you can see. This patient has an aneurysm here. And then you can see there were multiple supply from the thyrocervical trunk. And there was a feeder coming from the top. As you can see, there was, now because there was some embolization was done, there was some preferential supply coming in. This was again embolized, and then this, you can see, this was embolized right at this point. And the AVM just disappeared. As you can see, the whole thing was actually a fistulus. This boy is now 18-year-old, and the whole AVM has gone. So how do you differentiate ASA and PSA? We already talked about it. How do you differentiate between AVM and ST? Remember, age is very important. Usually you see AVM in a lot of younger people. The type 3 is usually you might get a radicular AVM, as you can see here, and you can see a spinal cord AVM. So you remember when you're looking at it, you might get a perimedullary type of a fistula, and I'll come to that in a minute. But here, if you look at type, here you've got a small AVM here, and you can see another AVM here. So you are seeing a metameric AVM in a type 3. And here is another one with a spinal patient had a bleed, as you can see. And then you can see that the patient had a AVM which was seen on the MRI scan. And you can see it's right at the anterior part of the cord. This had an angiogram. You can see multiple feeders from the vertebral artery, multiple feeders coming from all other sides. And there was this aneurysm that was seen. This was then accessed. As you can see, he had a glue, and then he had some more glue, and we had some. I generally prefer glue if I am treating spinal AVM. I generally don't like putting I had a complication also when I was injecting onyx in a spinal AVM, so I'm very careful. I'm more and more tempted to use glue if I can. As you can see, this is a glue injection here, and then the aneurysm, and then the AVM was treated with successful embolization. When you look at type 4, again you can see here you have a small bleed here. You can see there are some flow voids. Just a minute here. I'll just show the last case. So this is a perimedullary fistula. As you can see, there is a direct fistula here. This was not complicated to treat. We just had to get into it and then put some coils and treat that. I'm going to show you one complication, if that's okay. Can I show you a complication? Okay. So this is a chap I treated with an, as you can see, is a fistula. He was a chief executive of a big multinational company. I was treating him privately. And as usual, we discussed, he had an angiogram that showed the fistula. As you can see, it looks like a type 1 spinal dural fistula. Everybody agrees? This looks like a very normal fistula that you would treat. I was in. It was at T7 level. I was in, and that's where I wanted to get. And as I was injecting, you can see a big blob that you can see, and his vein ruptured. Okay? I've never seen that. I've shown this to many people around the world at multiple M&Ms. Nobody has seen it. And he was paraplegic. And, there are two complications that we get in our life. One is if you give somebody blindness or you give paraplegia. Death is not a big problem because he's not complaining. But if he has a paraplegia or he gets a blindness, I can tell you they will sue you in my world. Okay. So anyway, he was taken to surgery. There was a hematoma that was removed. And then he still had that fistula, which was then surgically treated. As you can see, he had an angiogram. You can see the glue there. And then he didn't really improve. And he sued me, but he didn't win because there was nothing I could have done anything different. And there was no negligence there. But otherwise, spinal paraplegia is a very difficult, you always feel terrible about it. But that was my only complication I had in a type 1 spinal dural fistula. Thank you.
Again, excellent session. Thank you, Professor Tufel. Now I welcome Professor Dural, Intervention in CCFs.
Thanks. Connector. सेम चीज करके देखते हैं. क्या किया था पहले? Okay. So, good evening again. So, this is more of a conceptual talk rather than intervention talk because intervention, the neurointerventions in CVT is not done frequently. There is no class 1A evidence that it should be done frequently. And world over, whosoever is practicing neurointervention, they would vouch for that we are really not sure which are the cases where it should be done. Okay. So, but what needs to be done is in cases like this, when like in this side, right side sigmoid sinus is closed, you have to open it, whether you open with endovascular means or by medical means. That's our goal. So I'll start by sharing two cases. One is a very young male. It's uncommon to have CVT in males, and that too in such young patients. But he did have, there was some history of spurious intake, some protein supplements, and superior sagittal sinus posterior half was occluded. So patient came with neurological symptoms as the protocol is in our hospital and majority of the centers around the world. Patient was anticoagulated. So he was okay for a day or two, and then he started worsening for 5 days, I think. And then he started showing rapid worsening, and that was the time when we took him for intra-endovascular treatment. So this is the major indication for me whenever the patient is being anticoagulated and he shows deficit more than 3 points on NHS scale, or there are some worrying signs on radiology, then we take these, only those patients we take for endovascular treatment. Earlier we were doing mainly thrombolysis. This is one such case. So you can see on the DSA, this is the large portion of the SSS which is blocked. And you can see indirect, there is drainage, a lot of cortical drainage, and even the emissary veins going through the bone and draining in the superficial scalp venous system. All this is outside the brain. And on the anterior posterior, again, the same image. There's a large thrombus sitting in just above the trocula. So we went in. I earlier used to do through the femoral route, but it's easier from the jugular route. But this case was done through the femoral route. Procedure is very straightforward. Take a guiding catheter inside the sigmoid sinus or above the jugular bulb. Through that, to take a large bore microcatheter like a 027 catheter, cross it. lace the clot with the thrombolytic agent, urokinase. I use TPA, and then leave the catheter there for some time. This is for IV intraarterial thrombolysis. And now we have large bore catheters, so aspiration is my favorite thing. But overall experience in terms of number is very low, so there is no generalization that this is better or that is better. This patient actually did well. The sinus opened well, the congestion went away, and patient improved. So this was a good result. Another patient, again a youngish patient, came with headache, diplopia, posterior circulation syndrome. Again, posterior circulation CVT again is one category of patients where we like to intervene early. Me and our neurology team, we work together and see we are primed that if it is a posterior circulation CVT, we might have to go in early as compared to anterior circulation. So here, this is the block on the left side, the sinuses are blocked, and there is a cytotoxic edema on the FLAIR and T2 images on the left side, and this patient showed early hyperdensity within the hemorrhagic area. So this patient was taken up, and you can see there is no drainage on the left side. Everything is draining either through the cortical veins and then going to the right side or directly to the right side. So now we like to do jugular access because it's faster, easier, and you can go more distally, more safer. So direct jugular access was taken. Again, thrombolysis was done as I showed before, and this is the result. It took long time. Generally, it would take anything between 12 to 36 hours, long term. So this is what we do. We have to open the sinus either by drugs or by stent or by aspiration. Your practice can differ. But the larger question in interventions in CVT is which are the patients you have to do. So what is CVT? CVT is not a single disease that clot forms due to this X reason or Y reason. It's a multifactorial, and that is why the treatment algorithm is difficult to decide. And symptomatology wise also, it is very difficult to diagnose just based upon the symptom that this is CVT. In ischemic stroke, it is easy. You lose a function, you know it is a ischemic stroke, and you work around that. But in CVT, diagnosis, very high degree of suspicion. And this is predominantly because the symptoms depend upon what is occluded, whether it is perissagittal, transverse, sigmoid, cavernous. So symptoms differ. But there are a couple of symptoms which tells us to intervene early. Again, I'm rushing through because diagnosis is not very difficult. You have a cross-sectional imaging, we have MRVs, we have CT angios, delayed phase CT angios, and you get images like these where you have a hemorrhagic infarct or a hemorrhage. You might not appreciate the infarction part if the patient comes late and the sinus or a vein is occluded. So diagnosis probably, as of now, is not very difficult to establish. However, what we don't see, which we now lately are trying to find out and see on the venograms, what is the collateral drainage pattern? And there is some thought that maybe with these drainage pattern, whether like just for example, if this is the occlusion and this is the brain, which is vein which is bypassing this occlusion and draining antegradally. So this would be better result clinically. Or this is type 2 drainage, collateral drainage, that if there is occlusion here and the vein is bypassing the occluded site and directly draining antegradally, or collaterals like this, where the drainage is from the superficial to the deep venous system. So there is some thought that if the collateral pattern is type 3, if the drainage is from superficial to deep, then those patients do worse with treatment, any kind of treatment, especially medical management. So probably these are the patients which can be taken preemptively for endovascular treatment. But again, there is no hard evidence. It's anecdotal papers for this. But this is one way to go choosing the patients. So coming to the treatment, we all know anticoagulation either with heparin or with low molecular weight heparin is the way to go. And algorithm is very simple. You diagnose it. Once it is diagnosed, you put the patient on low molecular weight heparin. And it does not matter whether there is a hemorrhage there or not. One has to put these patients on anticoagulation. And this is first line treatment. But if you see whenever we say, okay, this is the first line treatment, we always ask from, I'm from the opposite side. I'm not a neurologist, I'm a neurointerventionist. So from my perspective, I will ask why it is therapy to go. So if I see the data is not very strong actually. If you see the studies based upon which this therapy came into picture, The data is of 20 patients, 60 patients, 80 patients. None of the data is more than 1,000 patients. So data is very not very strong. But the therapy works, and there is no easy alternate therapy. So it's going on. And there are class 1 guidelines, both in American and European, that it should be given irrespective of hemorrhage or not within the infarction, venous infarction. So what is the status of neurointervention or endovascular treatment? Again, there is no clear guidelines. Ma'am was just asking me which are the patients you take up for intervention. I don't have an answer for that, because standard what we say, patient who go down rapidly after anticoagulation, if there is uncontrolled seizures, if it is a posterior fossa involvement, if patient is comatose. So those are the patients. But how do you decide which are those patients? Once patient goes into comatose state, he may not come out. We have to preemptively diagnose this patient, and that is the key which will make or break the endovascular treatment. And it is very similar to status of 2008, 2009 in ischemic stroke, when mechanical thrombectomy was told that it's not a good therapy. Because the way the studies were being done, that was not correct. And the results were negative for mechanical thrombectomy. And today we are standing and talking since morning that it is, now we have class 1A evidence for that. So as I was saying in the beginning, how we do it is not important. I showed you a couple of cases. Usually what I do currently is we give some TPA and we try to open it with aspiration catheters as much as we can. We have 072 catheters, which are the largest. Some people take larger guiding catheters above, long sheets above. But we try to make a channel. We are not very keen to totally debulk the sinus. We just want to have an antegrade flow. Once that is achieved, our job is done. So what is the evidence for endovascular treatment? Again, there is a lot of evidence, again not very strong. If you see, these are the studies based upon which the endovascular or intrasinus thrombolysis was started. So one thing is clear, it is a safe therapy. There is not much risk in doing it in trained hand. So we know that. And why do we know that? Because we have, this is just a so we have a lot of meta-analysis now. But before that, before the data is coming, the 10 years back, only one randomized trial has been done till date comparing medical management versus endovascular treatment, which was done maybe a decade back. And it showed that there is no benefit. The trial was shut down early, but the number of patients was 67. And there were a lot of issues with that. It did not show any benefit, but there were a lot of issues with that. The number of patients were less, it was underpowered, the therapy, I mean, whether you have to do stent, aspiration, thrombolysis, it was not standardized. And the major limiting factor was whether the sinus has opened or not. They did not see post-procedure. They did not report post-procedure, they reported at 6 months, right? So the only evidence, only randomized trial is not very good, and we need a better randomized trial. Two very good meta-analysis I will share with you. Both were published this year. This is from Nepal, and see the good functional outcome, complete recanalization rates, mortality, morbidity, right? So very low. And wherever hemorrhages did occur, they were not very significantly, clinically significant. And this another systemic review, again this is a larger, relatively larger view, which compared which therapy is better, whether thrombectomy is better or aspiration is better. So although data is not very strong, but it concluded that aspiration alone is better than any of the other therapies individually or in combination. So probably when we have larger than 072 catheters, like superbore catheters which are there in Americas, when we have those, probably that is the way to go in that. So I'll end with this. What are the knowledge gaps? Again, as I said, which patient to do, which patient to take for intervention in the first go rather than waiting for him or her is to deteriorate. We have to choose better, we have to find out better choosing criteria. So we can take help of, this is the one systemic reviews for negative prognosticator factors. if you see, we can choose many, like seizures. Early onset seizures has a poor outcome, so we can choose these patients. Coma, of course, we know has a negative thing. If there are hemorrhagic parenchymal lesion, again, those have shown better. But in addition to imaging and clinically, we can see these biomarkers. If you see some of the biomarkers, including D-dimer, the high positivity, again, leads to poor prognosis. So we can choose these patients. And in addition to creating better devices, which are targeted for venous thrombosis, we have to choose our patient multifactorially, not only clinically that they go down, not only radiologically that there are poor features, but clinical, radiological, biomarkers, and we have to change the scales with which we evaluate. We say endovascular does not do well because MRS, there is no difference at 6 months in MRS scale, right? But MRS is not a scale, universal scale, because CVT patients, they have cognition deficits long term, they have chronic deficits. So we have to change the clinical scoring system when we are deciding which patients to choose. And so these are the knowledge gaps and these are the way forwards when we are thinking about interventions in CVT. Thank you very much.
Thank you very much, sir. So, we close the session. We like to follow on the chair questions in the next session. Dr. Priyanka Namocha, consultant in biology at Idiopathic Hospital, and Dr. Ajit Singh, consultant neurosurgeon at Balas Hospital, Udaipur.
Thank you so much. This is a very interesting and my favorite topic, the CSF hydrodynamic disorders. I will be covering 15 minutes of SIH. I know this is a short time for SIH and IH to cover. I will update regarding what are the recent advances, how to diagnose them, and current guidelines. I will start with spontaneous intracranial hypotension to begin with. Okay. So, regarding SIH, it's the understanding regarding the SIH is still in evolution. This is a unique disease because the leak is in the spinal level, but all the manifestations are in the brain. The ideal terminology to be called for this entity is spontaneous spinal CSF leaks, rather than calling spontaneous intracranial hypotension, because most of the times, especially in chronic cases or obese individuals, if you do a LP, there will be no hypotension demonstrated in all the cases. You require high index of suspicion, and knowledge of imaging findings is a key to diagnose them early. And always, when you are suspecting any case of SIH, always ask history of remote lumbar puncture, any procedures, drains, epidural anesthesias, which will help us to resolve the issues. It is said that the incidence of this condition is around 5 per 100,000 population per year. Females are twice more commonly affected as compared to the male. I would request all the experts here to switch over to the pencil point or the dimal tip needle for doing a lumbar puncture rather than using a cutting needle, because it induces a lot of trauma, and the tear which it causes on the dura is difficult to heal. So switch over either to a Whitaker needle or Gerdy marks, such type of pencil point needle, and you should always avoid these quincase needles as much as possible. This I call it as SIH iceberg, because as I told you, it affects 5 per 100,000 per year, but most of the cases remains underdiagnosed. True burden is much higher than what we are seeing in our day-to-day practice, because more than 90% of the cases are misdiagnosed initially. They will be either labeled as migraine or tension type of headache, and chronic cases even labeled as a psychiatric illness. And this disorder is a elusive disorder. Because if you see, in the initial presentations are classically orthostatic, about 90 to 95% of the cases come with a typical postural headache. As they lie down, they feel better. As soon as they get up, they get a headache. Some cases also, the slow leakers say that, my headache doesn't come in the morning. As the day gets, like second half of the day, I generally get a headache, which I have to lie down to get them relieved. It is called as second half of the day headache. And generally it is said that after 11 weeks, this orthostatic nature of the headache generally disappears and it persists throughout that. So you have to retrospectively ask the patient. Unless you ask a leading question, they may not tell you that how was the headache, how was your headache to begin with. Probably that time they may say it was initially the postural one which gradually became continuous. And we have seen that most common presentation is the back of the head or the suboccipital region. Neck pain is the most common thing. The diplopia is another thing. The muffled hearing, sixth nerve palsy often comes with diplopia, those type of symptoms. But as the chronic cases, the long-standing cases, they come with very difficult findings like gait ataxia, Parkinson's-like symptoms. Some cases have been reported to have a frontotemporal dementia-like picture, also known as spinal dementia, to highlight the importance of spinal leak causing this dementia. And so many cases come with complicate with PRES, CVT, chronic subdural hematomas for the first time coming with and diagnosing as SIH, which is a difficult time and some patients come with lethargy and coma due to the subdural hematoma and herniation. If you see, the skull base leaks never present with typical orthostatic headache or postural headaches. It's only the spinal leaks which comes with the symptoms of SIH. Because the CSF rhinorias or otorias, they come with, they typically say the watering from the nose when they bend forwards. They never come with postural headache. They come after complicated with the infections, pneumococcal meningitis or some things. Because when the patient is lying down, and an individual is lying down, the pressure throughout the spine and the brain is equal. When they stand up or sit, if you see the intracranial pressure, they are much lower as compared to the atmospheric pressure in the sitting or standing posture. And somewhere at around C2, C3 level, this pressure equalizes, and as you go down, the pressure builds up significantly down. So the leaks in these areas are the one which causes the CSF leaks and symptoms related to that. And it is known as hydrostatic indifference point theory. It is similar to this overhead water tank, where the leak, where the pressure in the lower part as compared to the head of the tank is a difference. And this is a very old paper, 1976 paper, which explains all these things, known as hydrostatic indifference point theory, which I will not go into the details. We will talk about the classification. There are 4 types of classification. There are 4 types of CSF leaks. Type 1 is the most common which we see in our setup. It is due to a dural tear. It may be ventral, more than 90% of the cases, or ventrolateral or a dorsolateral. And I always use the word SLEC. SLEC stands for spinal longitudinal epidural collection or extradural collection of the CSF. Whenever there is a dural tear, generally we get a SLEC positive type of leaks. In second type, accounts for around 15 to 20% is due to the rupture of the meningeal diverticula in the lateral aspect. When they are proximal, they cause SLEC. When they are distal, they cause paraspinal CSF collection. And the very interesting entity which was diagnosed for the first time in 2014 is the type 3 leak, which is known as CSF venous fistula. And this is always SLEC negative because the CSF directly escapes into the venous systemic circulation, and hence there is no epidural collection of the CSF. And so many times we don't get the cause of the CSF leak, then we call them as type 4, and nowadays they say that it is the CSF lymphatic fistula which has been recently discovered, probably contribute to these type 4 things. So once you label them, then you label them whether there is an epidural collection of CSF or not, SLEC positive or SLEC negative. How does the SLEC positive look? You can see the dura here displaced and the fluid all around it, especially when it will be very well appreciated if you do a 3D fat suppressed heavily titubated sequences. See this, the dura being displaced. Usually this dura will be adherent to this bony canal. You don't see a collection all around it. Here dura is displaced and see the CSF all around it. In this case, there is SLEC negative. There is no fluid collection at all. You are seeing a card and CSF, that's all. In this case, card, CSF, dura, and outside the dura, there is a CSF collection. This is the SLEC positive cases. This is a typical type 1, a discogenic spur causing a tear and CSF escaping out and collecting all around the dural tube. And you can see the splitting of the contrast in the digital subtraction myelogram. This is in the thecal sac. From here it is coming out and forming a parallel track, running all the way up. And this is the ruptured meningeal diverticula type 2. And this is a type 3. There will be a meningeal diverticula, but this meningeal diverticula forms a fistulous connection with the foraminal vein, which will drain either into the epidural plexus. Sometimes it drains internally to the basivertebral vein as well. So this is known as CSF venous fistula. And this is one of the difficult cases to diagnose and treat. So percentage, once this fistula is discovered and the imaging modalities have improved, it is said that recently around 40% of the cases are due to dural tear, that is type 1, 17% are due to meningeal diverticula, type 3 accounts for 23% of the cases, and another 20% of the cases we may not be able to detect the exact cause. Remember, if CSF is seeping out, so this mnemonic is easy to remember, seeps. Remember that 20% of the MRI may be negative in even actual SIH cases. The classical imaging findings are, as per the Monro-Kelly hypothesis, the volume should remain constant within the rigid calvaria, that is the brain, CSF and the blood. Since CSF we are losing, the other compensatory measures kick in. The subdural collections, enhancement of the pachymeninges, engagement of the venous system, which is the most common, earliest and the most consistent finding which we see. Because of pituitary hyperemia or due to hypophyseal venous congestion, sagging of the brain, in chronic cases you will see the posterior fossa superficial siderosis. And remember, all these findings do not appear simultaneously. It takes time. Within the first week, the venous engorgement starts, then the pachymeningeal enhancement starts, then the perioptic sheath collapses around the optic nerve, which is consistent and the earliest finding. Pituitary engorgement, subdural collection and sagging of the brain takes nearly 3 to 4 weeks to appear. So these are the imaging findings which takes time. You may not get in the early first or second week. So how do we evaluate them? If we are clinically suspecting a case of SIH, always recommend a contrast-enhanced MRI and whole spine screening. And it should involve 3D T2-weighted fat suppressed sequences. These are the must imaging sequences. Once the imaging is done, if you see a positive signs of imaging, the imaging findings are consistent with, brain findings are consistent with SIH, you look at the spine, what is happening. Is the fluid collection is there all along the dural tube? Is it SLEC positive or SLEC negative? If it's SLEC positive, and brain findings consistent with SIH, the patient will go for prone ultra-fast dynamic CT myelogram. Then localize the site of leak, treat them either preferably with a targeted epidural blood patch or a glue injection or a surgical repair, which is a permanent cure. If there is no SLEC, but brain findings are consistent with SIH, then you have to ask the patient to go for decubitus digital subtraction myelogram, which is a gold standard, or if the facility is not there, at least decubitus CT myelography, which is gaining traction, because you are suspecting either a type 2 or a type 3. When you diagnose them, then you can either treat them accordingly based on the diagnosis. If you don't have anything, if you can't do an ultra-fast dynamic CT myelography, you do a 2-level epidural patch, and the patient improves significantly, wait and watch. If the patient is not improving, then you must push it for the lateral decubitus myelogram or a CT myelogram. This is called as SIH pathway. We have done a brain and spine, SLEC positive going for prone ultra-fast dynamic CT myelogram, SLEC negative cases going for lateral decubitus myelography, either in cath lab or in the CT room. This is how the patient will be lying down. Prone versus lateral depending upon SLEC positive or SLEC negative. Restricted breathing and thecal sac pressurization. Before we even do a myelogram, we generally inject 10 to 15 ml of saline into the thecal sac, so it gets distended. Patient symptomatically also improves, and this helps us to detect these fistulas as well as the leaks very easily when you pressurize the thecal sac with a normal saline, and then you do a procedure. And always ask the patient in the CT room to breathe through a straw. The restricted breathing is said to be the best way of breathing while doing this myelogram, because it increases the conspicuity of detecting the CSF venous fistula or the leaks. So what are the treatment approaches available? The gold standard is the epidural blood patch, preferably the targeted epidural blood patch. Unless you don't have expertise, then you have to do multi-level blind epidural blood patches. Percutaneous CT-guided glue injections, endovascular embolization of the foraminal vein for the CSF venous fistula, and surgery remains the integral part of the treatment of SIH. Let us see one or two cases. 45-year-old lady with a postural headache past 3 weeks. Perioptic CSF sheath is collapsed, subdural collection is there. You can see that blood all along that bilaterally. Contrast enhancement, you can see dural enhancement even in the infratentorium. And there is a dural thickening all along the clivus, which causes Duralos canal's compression and causes sixth nerve palsy. It goes all along the internal auditory canal, causing muffled hearing. Then all the parameters, we could do a scoring called as Bern score or a Mayo score. In this case, it was complete score 9 by 9. When the score is high, then the spine imaging was also done, which showed SLEC positive. There was epidural fluid collection. All the findings were fitting, classical. Then we send the patient for prone ultrafast dynamic CT myelography. You can see that one of the studies showing that how fast the leak is, why we should not do conventional myelogram. It took just 1 second after the injection of the contrast to come out of the dural tear. If you delay, if you don't acquire it in time, then you will miss this leak, and by the time you acquire the images, all the contrast would have come into the epidural space, and you will be missing the diagnosis from where exactly the contrast has leaked out. So it is as fast as 1 to 1.5 seconds. So that's why ultra-fast dynamic CT myelography. This is the wedge you can see. This is how the patient lies down in the ultra-fast CT myelography. This is for SLEC positive type 1 dural fistula. This is the position. You are injecting the contrast here, and while injecting the contrast, you are acquiring the images simultaneously from the sacrum to the CV junction area at least 2 to 3 times. See this, the operator is standing behind the lead glass and he is injecting the contrast. When the contrast goes up, wherever there is a leak, there will be a Y sign or a splitting of the contrast. So this is the point where the leak will be there. Generally, if you go and see the plain CT, you will get a discogenic spur or a bony specule at that level, which is puncturing the dural. So this is our setup, which we are doing ultra-fast dynamic myelogram by localizing it. And we do, and this is Dr. Andrew Kellan, who is a pioneer in doing CSF leak procedures. He works in Colorado University in Denver. He has customized a table, which is easily fitted to the CT room, CT table, and it can go in and up, and you can change the angle. So this, because the position is very, very important, so that you can get a free flow of the injected contrast. So I visited him and spent there 2 to 3 weeks. Then we learned a lot of things from there. So in our case, there was a discogenic spur there, and the patient was not taken out. The patient was still lying there. We put the radial line in the patient and keep him in the prone position. Once we study that, it takes another 5 minutes to assess where is the exact leak. Once the images are done, then remember that after the myelography, sometimes you get a contrast leak physiologically also at C1, C2 level. So these do not represent the exact site of CSF leak. So these are resulting from the transudate from the dilated epidural or suboccipital veins. It's a false localizing sign. Once the patient is still in the gantry, CT gantry, we took a epidural needle, we localized where is the leak. We took a epidural 18G needle, did enter the epidural space under the CT guidance, injected the air epidurography was done. Once we confirmed that this is a translaminar approach, posterior approach, patient is in the prone position or in the lateral decubitus position based on the operator's comfort. Once your needle is in the epidural space, take out the blood around 6 to 8 ml at the cervical level, or you can inject up to 10 to 15 ml in the dorsal level. In the lumbar, you can go higher also. So then after 24 hours bed rest, the patient will be discharged, and immediately next day we ask the patient to sit for 1 or 2 hours and give the scoring. And the patient improves, we send them with what not to be done, like not lifting the weight, not swimming, no gym, all those printed protocol we follow. And the patient comes back after 1 month for a follow-up MRI. This case, you can see the perioptic sheath was completely collapsed. It has come back now. The pituitary, which was congested, has gone down. This venous distension has completely disappeared. And all the suprasellar space, prepontine space, interpeduncular space, which was all effaced, which has come back. And sometimes if you don't have expertise to do all this myelogram, then the best guide, best thing what we are following nowadays is, because of lot of radiation and expertise required, if the brain findings are consistent with SIH and the SLEC positive is there, do a plain CT, look for the discogenic fur, see that your epidural CSF collection is also around it in the MRI, go there directly targeted with the epidural needle, inject the air, confirm in the position, and take a blood, mix with 1 ml of contrast and inject there, and wait and watch. So many times discogenic spur guided epidural patch will skip the necessary of myelogram, and most of the times it cures the disease. That's what we are following in almost last 30 cases has been done under this. No recurrence has been seen. And another technique of injecting the epidural patch, the blood or a glue is transforaminal approach, because you reach the anterior epidural space rather than the posterior epidural space, which I was showing, which is very close to the rent. Now you are very close to the rent, you can directly inject the blood or mix the fibrin and the blood or inject the fibrin glue also directly to the rent. The efficacy is very, very high. So in this case, there was a SLEC positive case. You can see the signs of SIH. Transforaminal approach, enter the epidural space, inject the contrast, confirm you are in the epidural space, and inject the blood at that level. It's very, very effective, but it is more technically demanding as compared to the simpler interlaminar approach. In this case, you can see there is something called chronic SH, where this collection becomes more organized like a pseudomeningocele. Your posterior interlaminar approach will not percolate into that this space because there is a membrane formation. This is an organized SLEC with a superficial sidrosis. This patient typically came with a gait ataxia, sensory neural hearing loss, memory disturbances, ALS-like symptoms. And when the imaging was evaluated, it was a chronic SIH. And this ventral, you can enter the transforaminal route, puncture this leg, enter into this pouch, then do a patching. The success rate is very, very high. Ideally, these cases should be localized where the exact site of leak, and surgery should be offered for the permanent thing. And another interesting technique is, in the cath lab, take the patient to the cath lab, make the patient in a prone position, localize at L3 level, with a 19G toy needle under local anesthesia, you enter the epidural space. How you put a epidural catheters for anesthesia? You take a wire, put a 4 French sheath into the epidural space, take a 4 French diagnostic thermocatheter, and enter the epidural space. Keep on injecting 2 ml of blood at all levels and pull back your catheter up to the lumbar region, from the cervical region to the lumbar. You will smear entire thing, and in the prone position, make the patient lie down for a few hours, and then the success rate with this technique is said to be nearly 89%. And the amount of volume they could inject was nearly 50 cc in this procedure. And very, very effective treatment, where this study has shown nearly 85 patients. If you don't have any expertise, do not lose the hope. Do at least 2-level epidural patch, which is equivalent to a targeted patch in many studies. At least go to the cervicodorsal region, inject 10 ml of epidural blood, and also come to the dorsolumbar region, inject another 15 ml of blood, and wait and watch. Most of the times this will solve the problem in all these leg positive cases. So coming to the CSF venous fistula, the gold standard is digital subtraction myelography. It is a 2-day procedure because it has to be done under anesthesia. Maximum amount of intrathecal contrast what we can give is 11 ml, maybe up to 15 ml, not more than that. That's why patient has to undergo 2 times myelogram in this position. One on the right side where the most common fistulas are there, and then the patient will come, if it is negative, for the next day in the left lateral decubitus position. And if the fistulas are found, you do either CT-guided fibrin glue injection into this pouch from where the vein is coming, or inject the blood or the glue, or sometimes you and the new procedure known as endovascular procedure, where you go through a venous system, enter the azygous system, come to the these veins, foraminal veins, inject the onyx. If you don't have all those expertise, surgery is the best, where we can clip that CSF venous fistula and cure them. So this is one of our case, lateral decubitus myelogram in the cath lab. You can see this is a pouch and the veins are coming out. You can see this pouch and the vein draining out. This was done way back because at that time we don't have endovascular procedure was not yet discovered. So we did a DSM and sent the patient for the surgical clipping of that fistula by localizing that. See this patient before procedure, and this is after procedure. Subdural disappeared and everything cleared. So endovascular embolization is a very good technique, very easy relatively, but the thing is you should know how to evaluate, how to localize it, because if you miss the level, it will be difficult to embolize. You should, in this case, you can see there, this is a SLEC positive, this was a SLEC negative case. So there is CSF venous fistula, targeted glue injection was done initially, but it failed, and hence the embolization was done. Then after that, the patient was cured. Transforaminal onyx embolization. These are the different literature supporting the same. And remember that once you treat, in nearly 25% of the cases, especially in chronic cases or CSF venous fistula, patient may return back to you after 1 or 2 days with a rebound intracranial hypertension. Now, physiologically, the CSF production is very high in these cases. In a long cases, supraphysiological secretion of the CSF will be happening. Once you seal the rent, the CSF still continues to produce in a higher volume. Then the patient typically says, now, this headache character has changed from suboccipital to the forehead, around the periorbital region. He feels better when he stands up rather than lying down. Do not panic. You can easily manage with the acetazolamide tablets only. And very rarely you may have to do a lumbar puncture to relieve this pain. It is like IAH. It starts behaving like IAH, but it can be managed very effectively and conservatively with acetazolamide. Nearly 1/4 of all our cases come with this. So I prime them before I do embolization. So I will skip this. So every comprehensive center should have a CSF clinic, where you have a neuroradiologist to do this imaging and guiding. You should have a headache specialist. You should have an anesthesiologist who helps to do these epidurals, all those things, and a neurosurgery team who can help us bail out in a difficult cases by doing surgery coordinator or a nurse to follow up these cases, and OPD consultation separately for a CSF clinic. And we need to promote this and create awareness so that all this suffering of these patients can be alleviated. Thank you so much. So this is the conclusion. This is the same repetition. So I would like to go to IAH if there are no cases, no questions in this. If there are any 1 or 2 questions, we can take.
I think we can proceed to the next session.
Yeah. We can take questions at the end also.
Next topic is update on idiopathic intracranial hypertension management, including venous stenosis.
Yeah. This is a relatively well-known entity as compared to the previous topic, SIH. IH, currently the experts say it is a systemic metabolic disorder. And as we all know, it is an enigmatic disease where we are still in the process of understanding the etiology of this disease, where the diagnostic criteria are well established before we know the etiology. And the typical risk factors are the women with a high body mass index in the reproductive age group, rapid weight gain, associated polycystic ovarian disease or obstructive sleep apnea. And the incidence, which is in general population, which is 2 per 100,000, jumps up to 20 to 30 per 100,000 in a woman of childbearing age group. And it is the center of all this pathophysiology is the central obesity or the adiposity. We all know that this adipose tissue can act like an endocrine organ. It can actively secrete mineralocorticoid releasing factors, which could be another possible mechanism of increasing in ICP. And last 2 decades, we have seen that there is a doubling of these numbers in IAH cases. And modified Dandy's criteria are the more popular. Friedman criteria are used. The papilledema remains the main diagnostic criteria, but there are cases where there is a IAH without papilledema. If you don't demonstrate a papilledema, you should have all the remaining 2 to 5 other criteria in the presence of unilateral or bilateral 6th-nerve palsy to diagnose IAH cases. And this is very important. Current theory, as I told you, we do not understand the exact pathophysiology of the IAH, but the current theory, which is very popular, is known as venoglymphatic theory. It is said that adipokines, which are secreted from the fat cells, the increased glucocorticoids and female sex hormones, ultimately they result in aquaporin water channel dysregulation. And the 2 aquaporins which are abundant in brain are aquaporin 4 and aquaporin 1. Aquaporin 1 are abundantly present in the epithelial cells of the choroid plexus. And another chemical which is very interesting and involved in this pathophysiology is 11-beta hydroxysteroid dehydrogenase, which converts inactive cortisol to active cortisone. Inactive cortisone to active cortisol. That is 11-beta hydroxysteroid dehydrogenase 1. So ultimately, due to this aquaporin dysregulation, the lymphatic dysfunction results in interstitial fluid accumulation. The interstitial fluid accumulation results in increased brain volume. And the brain volume, when the brain volume is increased in IAH patients, ultimately they compress on the venous structures. The most compliant venous structure which is vulnerable to this compression is the lateral aspect of the transverse sinus or the proximal end of the sigmoid sinus, and followed by posterior 1/3 of the superior sagittal sinus. So what exactly happens is, because of this venous stenosis and venous congestion, the venous congestion increases. This venous congestion further increases the intracranial pressure. Thus, this results in a positive feedback loop known as self-sustaining venous collapse. So, more the venous stenosis, more the venous congestion, this increases the volume, this again compresses on the venous stenosis. Somewhere we have to break this positive feedback loop. And the carotid stenting, this venous stenting breaks this venous stenosis at this level, where your venous drainage is improved, intravenous pressure is reduced, increased CSF absorption happens. Basically, the venous stenosis is an effect, not the cure. In so many papers, they have done an MRI and demonstrated the venous stenosis, did a LP, at least 30 cc of CSF is drained out, and immediately patient is shifted to MR venograph, and they have demonstrated that veins have opened up. So it is not the cause, it is the effect. So we are treating the effect, not the cause, by doing a venous sinus stenting here. And regarding veno-lymphatic theory, again I am saying you, there are several literatures to read about that. But one of the very popular paper which I like personally is by the Alprin et al., who observed that extraventricular CSF space in IH patient was approximately 30% larger. That is approximately 220 ml larger than the control group, presumably due to congestion known as lymphedema, and CSF aquaporin levels in these patients were reduced in IH patient as compared to the controls. So brain volume is more, so many papers are there which suggest that this is something related to a glymphatic system. Even in a AJNR paper, if they have studied that IH patients have more prominent perivascular spaces where the glymphatic system lies in, and this is one of the papers showing more prominent VR spaces in compared to the age match control. And this is another study where 81 patients with IH with a venous stenosis, transverse venous stenosis, they underwent DTI for analyzing the lymphatics along the perivascular space. This also says that more venous stenosis is associated with more poorer glymphatic clearance, and supports the venoglymphatic theory as well. So clinically there are two subtypes, benign and fulminant. Approximately 2 to 3% of IH present with very severe form with rapid vision loss over days are within a month of symptom onset, and fulminant IH is a neurological emergency and conservative treatment do not help in these cases. Your acetazolamide and other conservative lifestyle modifications do not help. Such cases, fulminant cases, has to be sent to either surgery for a CSF diversion or optic nerve fenestration or endovascular treatment like say venous stenting to avoid permanent visual loss. Typically what we see, we all know that, I will not waste much time here, prominent CSF sheath, vertical tortuosity, bulging of the optic disc, and sometimes malignant or a fulminant papilledema can show a restricted diffusion and enhancement also in the optic nerve head. And prominent is enlarged arachnoid outpouchings, the empty cella, Meckel's cave becoming prominent, more arachnoid granulation seen at the occipital region or the skull base region. These are also very, very common imaging findings. The occipital emissary vein prominence in a venous stenosis is also very, very classically seen. And this is the one which is very, very specific, seen in 90 to 95% of the cases, where the transverse sinus stenosis is, it can be either two types, smooth long segment versus short segment. It is known as intrinsic occlusion versus smooth long segment is generally associated with compression due to lymphedema. As we all know, regarding the management, it's the core of the treatment is for reducing the central obesity in the form of dietary and exercise interventions along with the cognitive and behavioral interventions as well. The standard medications are here, acetazolamide, topiramate, furosemide, but new therapies, exciting studies are going on with the GLP-1 receptor agonist and 11-beta HSD inhibitors. The recent paper was published last month regarding IAH and 11-beta HSD1 inhibitor and has shown a promising, probably these two new therapy, targeted therapy, if they come, probably it will help a lot of IAH patients. And the other one is the surgical arm, optic nerve fenestration, CSF diversion, bariatric surgery, and venous sinus stenting. This is the surgical arm, this is the medical arm, this is the standard lifestyle modification measures. But if you see a trend from 2016 to 2020, the incidence of optic nerve fenestration has reduced from 100 to 46, CSF shunting has reduced from 100 to 81, but the tendency of venous sinus stenting has become from 100 to 180 now. So percentage of interventions, endovascular interventions are increasing as compared to this conventional standard therapy. Even there are so many papers. This is one of the meta-analysis of 20 studies across the 18 centers which showed overall improvement in papilledema, headache and pulsatile tinnitus rates in patients of IIH with venous sinus stenosis as compared to others. They have compared directly with optic nerve fenestration, CSF diversion and venous stenosis with respect to vision, headache, papilledema, and in most of the cases venous sinus stenting has done a good job as compared to those two. And major complications are also very, very less than 2.9%. Minor complications are also less, and the repeat procedures are also very, very less in venous sinus stenting as compared to CSF diversion procedure and optic nerve fenestration. How do I do it? What cases to be selected for this procedure? Medically refractory IIH and fulminant IIH are the true candidates. How to plan? Post for a venogram and do a manometry under local anesthesia. IIH medication should be withheld at least 2 to 3 days before you do a manometry, CSF pressure manometry. Avoid caffeine consumption at least 48 hours before that. Stop all the treatment. And if you demonstrate that the pressure gradient is more than 8 millimeters of mercury, so that you are selecting the correct cases, antiplatelet treatment is similar to carotid artery stenting. There is no difference. The procedure is done under general anesthesia, but all the manometry should be done under local anesthesia because GA may interfere in the measurement of the gradients. Always, earlier we used to go through femoral vein, now we have shifted to jugular approach where 8F sheath will be put and the distal access catheter are used to cross the stenosis, and we take a O88 ballast or something like that which is very smooth, and then we be close to the stenosis, and we use a larger stents, preferably the longest stent available. Balloon plasty generally is not required, and in some cases it may be required. So longest available 9 mm stents I use. Watch for the wire tip entering into the cortical vein when you are doing all these procedures. It may cause a cortical vein tear and subarachnoid hemorrhage. That is the most important point. Always keep a watch on the distal end of the wire. Extubate the patient immediately. After your procedure, always do a measurement of the pressure, that whether the gradient has become equalized and there is no gradient existing after the procedure. Then dual antiplatelets can be continued up to 6 months. You can generally, because in unlike atherosclerosis, you don't have to continue dual antiplatelets for longer time. Even the aspirin can be stopped after 1 or 2 years. So patient essentially do not need any antiplatelet after 1 or 2 years because the stent will get endothelialized. There is no diseased artery there to continue aspirin. So this is how we measure the pressure gradient under local anesthesia, make a chart, do it in a awake state. And this is, I will show you a case of venous, this is the visual chart, the tight stenosis, all the MRI features. This is in the sigmoid area. You can see in the lateral view is the best view to see the stenosis. Once you see the stenosis and demonstrate and measure the pressure gradient more than 8, you have deployed a open cell design stent. Now I use a lot of wall stents, 9 mm wall stents, which are 60 mm or 50 mm. This is the earlier cases, 860 Proteus stent has been put. And once you put and then redo the pressure gradient. So similar cases, I will not go into these cases as a standard cases. One of the case I had to do a bilateral stenting. It's a long-standing bilateral venous sinus stenosis. And regarding the what you should watch out when you are doing a venous sinus stenting, what are the risks you will explain to the patient. The serious complications are less than 2.2%. Subdural hematomas or cortical vein injuries are the one when you are dealing with this, because if your wires are going here and there and you are doing aggressive ballooning, you may injure the dura and cause subdural hematomas. But it's very, very rare. Believe me, it's one of the safest procedure. But what is important is 14% of the cases over a period of time have a adjacent, it's called as toffee wrapper stenosis or a juxta-stent stenosis. On the either edges of the stents, you get a stenosis over a longer follow-up up to 14% of the cases. Because what is the exact cause of this stenosis occurring at the edges of the stent, we do not understand till now. But the longer and dedicated stents, because all these stents are not made for the venous system. We do not have a dedicated venous sinus stents. But nowadays there are 2 stents which have come into the trials, and probably they will come very soon into the market, which are dedicated to that. Those stents may reduce this venous sinus stenting. I will recommend everyone who are doing this procedure to go through this article, It is called a dural sinus septum related issues. Why we deal with the complications, why sometimes stent do not open, because physiologically there is a fibrous septum in the venous sinuses, and these septums sometimes come in the way when you are doing a angioplasty, because you may have entered this septum and trying to do a plasty, or you would have deployed a stent in this septum. So how to avoid this? What is slide test technique? This article is a wonderful article which was published in 2023. You would, if you read this and how to identify this septum, how to avoid the complication, probably your percentage of complications will be less than 1%. And this is a reverse study, a dedicated venous sinus stent study which was published last year. This is a open cell design tapered stent. The distal end will, the tapered distal end will be close to the torcula, and the other end, which have a very high radial force, will be towards the sigmoid sinus. And even this study is a very, very positive study favoring the venous sinus stenting. And this is another study, another stent, which is a braided stent. And the beauty of this stent is it is a DFT technology, nicely visible, and it can be delivered through a 5 French catheter, like Navian 5 French or a CAT 5. You can deliver this very easily. And these stents are very long stents. Probably the dedicated stents will avoid this delayed venous sinus stenosis also. And they come in 7 to 9 millimeter sizes up to a 80 mm length. So this is, even these stents are very good for venous sinus stenosis associated tinnitus and diverticulus also, because they divert the flow very, very well. And another interesting paper on regarding IAH associated CSF rhinorias. There are several papers saying that if the patient do not have active infection, patient coming with CSF rhinorias, you just stent them and CSF pressure is reduced, the leak will spontaneously stop and heal by granulation tissue and fibrosis. So there are several papers on that. I will not go into the details. Another interesting is very effective technique is venous IIH associated sigmoid and transverse sinus junction diverticulus, which causes intractable tinnitus. Patient, when they compress the jugular vein, the tinnitus disappears. After doing LP, it disappears, but it comes back as soon as you. This causes a lot of trouble to the patient, and when you do stenting, this tinnitus disappears on table. You may add few coils if you found a pouch, but this stenting remains the core treatment of choice. You can see here one of the stent has been, Boss stent has been put, and the coiling has been done to this pouch. This is very, very rewarding and very, very useful, and no other procedure can replace this venous stenosis cure. So to conclude, IAH case is rapidly growing healthcare concern, and probably it's a metabolic disorder leading to impaired CSF hydrodynamic, important cause of chronic daily disabling headache and permanent blindness in a prime age group. Venous sinus stenting is emerging as an alternative treatment for refractory IIH cases, but symptom recurrence in long-term follow-up is a concern. So dedicated devices and RCTs, there are 4 RCTs which is going on. Probably all the results will be coming very soon. With a long-term follow-up will help us to fulfill these gaps in the knowledge. Thank you so much. Yes, sir. Mike. Yeah, yes, sir. Sir, the outcomes, there is a paper where the CSF fistula, they have tried epidural blood patches as well. Theoretically, it will not work because it is a direct fistulous communication, and in those papers they have found less than 5% of the cases have a permanent cure. They have transiently they improve, but they have invariably come back in almost all the cases. Less than 5% is the cure rate for the, it is ineffective, sir. When we have found a SLEC negative, probably we should think something away from the epidural patch, classical patch. Yeah. 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 Volume is good enough. What I do is, when I found no exact site of leak, when I do a myelogram also, I don't send the patient back. I make the patient lie in the prone position at the cervical, somewhere around D1, D2 level, where the spinous processes are very parallel, easy to go in the posterior interlaminar approach. Go to the epidural posterior interlaminar approach, deposit at least 10 ml of blood. because cervical spine takes around 6 to 10 ml or maybe up to 15 ml in few patients. Then you come back down in the dorsal-lumbar junction about D12 or D11 level, you can go up to 15 to 20 ml. Generally 1 ml smears 1 vertebral height. So by that you will be covering entire, make the patient lie down in a prone position for at least 1 or 2 hours if they are comfortable, and then they can lie down as they wish. And most of the time it percolates because we add contrast and we see in that delayed, and every time when you do it, it nicely smears all around that. I have so many images to show, but this is good enough. In all my 35-40 cases of blind patch, most of the patients have not come back yet. Transform, yeah. Yeah. No, yeah. Because they have done 85 cases, and the complication rate, 2 complications are dreaded, like epidural hematoma and infections. They say infections are so rare unless you leave a sheath or a catheter there for more than 24 to 48 hours. They have never found an infection because epidural anesthesia, epidural catheter placement is a routine procedure without a complication. Even 1 in 1.5 lakh is the incidence of epidural hematomas also, very rare. Volume 2 ml at all vertebral levels. 2 ml and pulled back from C2 2 level, C3 2 ml, C4 2 ml. So by that they have injected effectively 50 ml. Yeah, venous or arterial, as you wish. Doesn't matter. Yes, thank you, sir. What? Blindness. Yeah. Yes, sir. Yeah. Yes. This is what, that's why I am very clear in that, saying that it is not the cause, it is the effect. Yeah, once you drain it, after doing a LP, they have done several papers, Journal of Neurosurgery has a recent paper, where they have done a TAF MRV, then taken back the patient, did LP, drained 30 ml of CSF, immediately sent the patient within 45-50 minutes, and demonstrated beautifully that venous sinus has come back to normalcy. So it is not the cause, it is the effect what we are treating. That is to break that positive feedback loop. Probably, sir, it's a long-standing probably, otherwise, yeah. Yeah. Yes, sir. Thank you, sir.
Sir, it was really wonderful talk. I mean, thank you very much.
Thank you, sir.
So I think we are done. Thank you very much, chairpersons, Dr. Ajit and Dr. Priyanka. So it's a long day, a lot of learning.